Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. I would like to call this hearing to order. Today is Monday, April 29th, 2024. The time is 9:31 a.m. We are holding a hybrid meeting in room 120 of the John A. Wilson Building and via the Zoom internet platform. This meeting is also being broadcast live on cable channel 13, as well as on my YouTube page at CMC Henderson. Today, we are holding the fiscal year 2025 budget oversight hearings for the Office of the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance. We will first hear testimony for public witnesses for DMHHS and then call for the public witnesses for the Department of Healthcare Finance. We will then hear testimony from Wayne Turnage, who serves as both the Deputy Mayor for Health and Human Services as well as the Director of Healthcare Finance, and his teams from each of those agencies. The Office of the Deputy Mayor for Health and Human Services supports the mayor coordinating benefits services across multiple agencies to ensure that district residents with and without disabilities can lead healthy, meaningful, and productive lives. In addition to overseeing the operations of the agencies within its cluster, DMHHS leads the Interagency Council on Homelessness, Age-Friendly DC Strategic Implementation Plan, as well as the Encampment Response Team. The Department of Healthcare Finance administers the district's Medicaid program, the State Children's Health Insurance Program, the Healthcare Alliance, and the Immigrants Children's Program. The mission of healthcare finance is to improve health outcomes by providing access to comprehensive, cost-effective, and quality healthcare services for district residents. The agency provides health services to more than 300,000 District of Columbia residents, nearly half of all residents. The committee sent pre-hearing questions to the agencies, and we will reference those throughout the materials today. If you would like to see them, they can be found online on the DC Council website at dccouncil.gov/hearings. I don't see any of my colleagues who have joined, but they may throughout the day. Before we get started, I want to review the public witness testimony guidelines, as we have a number of witnesses who have signed up to testify today. All of the witnesses will have 3 minutes to speak. We have a clock that will begin counting you down when you start speaking, and I will give you a nudge when your time has expired. For those of you who are testifying virtually, you will need to affirmatively accept our invitation to become a panelist when your name is called. And then please also make sure that your name is correctly displayed on the Zoom platform so that we can promote you. We won't promote names that we do not recognize. So just make sure you check on that front. Okay, so we have some folks who are testifying in person. I have 4 chairs in front of me, so we will call and see where we go. All right, Sarah Buckley. Deborah Thomas, who's a nurse consultant with the DC Nurses Association. All right. Kenneth Page. Lucy Cosgrove. Brady Woodhouse. All right. Evie Core. Evie Core. Okay. What's your name? Okay, you're Lucy. And your name? Okay, great. All right, Sarah, when you're ready, just turn your mic on.
All right, good morning. My name is Sarah Buckley. I know you have seen me here to talk about school nursing before. As you know, I'm a parent of a kindergartner at Amadon Bowen in Southwest. And I just want to address and make sure that you're remembering the importance of school nursing and the funding for this budget cycle. I reviewed Director Bennett's testimony recently in which she stated that the cluster model for nurse staffing has been a success, citing what appears to be a very recent data that 95% of schools have 40 hours of staffing in their health suites. I want to emphasize that ignores months of dysfunction where similarly high levels of staffing dropped to less than 50% in a matter of months. And it's unclear from Director Bennett's testimony whether the program has made changes in the implementation and staffing in a way that will make the model sustainable beyond the budget issues. But I do want to focus on the budget issues today. Director Bennett said that the budget allots $25.1 million for the program, which she acknowledged funds overhead, training, and the staff salaries, but does not fund a telehealth line, When the cluster model was initially rolled out at the beginning of this school year, the telehealth line was billed as one of the important elements that would allow a model in which about 75% of our schools are staffed with health technicians rather than licensed nurses to meet our students' needs. And I think it calls into question, what is our goal for school health suites? And is this budget designed to actually meet that goal? We know that Director Bennett indicated that the health technicians are in schools to give out medications and deal with minor injuries. But she's also acknowledged that a health technician is not licensed to assess a student's health condition or symptoms they might be experiencing. So if a student walks in complaining of stomach pains and a rash, they might not be able to identify those symptoms as symptoms of an anaphylactic reaction that requires the administration of emergency epinephrine. It seems like perhaps a situation like this is what led to a student at Shepherd Elementary School to be hospitalized recently and intubated after she was incorrectly given Benadryl. I want to emphasize that having persons in a school building to give medication and address minor injuries is not supporting our students and providing the services that the CDC and other organizations that are concerned with school health staffing have recommended. And I would continue to advocate for increased staffing or increased funding to ensure that we at least have that telehealth line to support health technicians and to continue to push DC Health to increase the number of nurses that are available to our schools. Thank you.
Thank you. Lucy?
Hello, my name is Lucy Cosgrove, and I'm a member of the Health Justice Club at School Without Walls. I'm here to convince you of the importance of assisting DCPS public and charter schools in paying nurses competitive enough wages to station one full-time nurse for every school. As a student who has been negatively affected by the system of shifting nurses that schools call the nursing cluster model. I am one of the many students at my school who suffers from a chronic illness called postural orthostatic tachycardia syndrome, or POTS, which is a dysautonomic condition that causes fainting, nausea, dizziness, and many more difficult symptoms. My condition causes me to often need breaks, snacks, and a place to lie down. It is also hard to convey to an outsider how I am feeling or what I need when these symptoms may occur. The needs of my condition, in conjunction with the lack of a full-time nurse, has caused me to miss a lot of school since I do not always feel confident in the safety and health measures that my school can offer under the nurse cluster system that DCPS schools currently use. I struggle with both my condition and keeping up with school content as a result of my condition, and this inequity stems from the 3-day week schedule that our nurse has, or rather the 70 school days a year that no medical professional is there to support me in the likely case of enhanced symptoms. I can only imagine the fear of students with POTS at schools that are worse off in their nursing schedule than Walls is. As a junior and a member of the Health Justice Club, I see it as my duty to create a more health-aware and caring environment in the DCPS system for those my age and the following grades. That is why it is so crucial that each school has a designated full-time nurse, one that is aware of my condition and one that I can count on being there when I need assistance. I want to reaffirm that it is well within the ability and responsibility of policymakers and budget planners to help address the nursing shortage from its roots and following suit with increased nursing staffing for schools. But it's not just me, since many students throughout DCPS have chronic illnesses. So I urge you to please create a more caring, understanding, and safe school environment by making progress towards addressing the lack of nursing support in DCPS schools. Thank you.
Thank you. Brady?
Hi all, my name is Brady Woodhouse and I am a type 1 diabetic student at School Without Walls and the founder and president of the Health Justice Club. My club and I have come here today to condemn the nursing cluster model that DCPS uses and demand that the Department of Health work to keep school nurse wages stay competitive as the future budget is decided. For most DCPS schools, a region of 4 schools has to split the time of only one registered nurse, one licensed practical nurse, with other medical staff filling in, despite not having the full capacity of registered nurses. As a result of this system, I, as a type 1 diabetic, have a subpar support system when it comes to my low or high blood sugar levels. If none of you here know exactly what a diabetic low blood sugar is like, I'd first consider you lucky, but then I'd add that it can become hard to maintain consciousness. Even in less extreme circumstances, it is impossible to fully focus on the content at hand. Even if a nurse is in the building from Wednesday to Friday, I have diabetes more than 3 times per week, and my condition-induced episodes don't follow the same schedule that she does. However, it is not just my voice condemning this system. The CDC recommends that each school building have a nurse for every 750 kids. Groups we've been working with included Parents United for School Health and the DC Nurse Association demand at least one nurse in every school. The unseen members of the Health Justice Club at Walls and Washington Latin that are currently at school have far too many stories that detail the negative effects of the cluster system. When thinking of solutions, it always comes back to money. Nurses need to be paid competitive wages if they are going to stay at DCPS, and money must be invested into enhancing the nursing industry in DC. We hope to convince you that addressing the nursing shortage in DC and DC schools is both within the ability and responsibility of this department. The city owes its future generation and the nursing coverage that is so essential to creating equitable and productive school environments. Thank you for your time, and I hope that my words are considered when deciding how much money is allocated to school nursing support.
Thank you, Brady. You said your name is Charlie. Okay, just introduce yourself for the record in place of Evie. Go ahead.
Hello, my name is Charlie Cole, speaking on behalf of Evie Core. I am a member of the Health Justice Club and a student who's witnessed firsthand the consequences of inadequate medical support in DC public schools. Today, I want to demonstrate to you the importance of assisting DC public and charter schools in paying nurses competitive wages in order to combat the nursing cluster system. Though the nursing cluster system has particularly problematic effects for students with chronic conditions, I want to make it clear that the nursing system that DCPS uses is a hardship for all of us students who may or may not suffer from chronic conditions. As members in a community with insufficient health staffing, me, other students, and teachers are tasked with picking up the slack. For example, my friend has type 1 diabetes. On those days of the week that our nurse isn't in the building, I'm tasked with being conscious about whether he might be experiencing low blood sugar, is managing all of his medication correctly, things like that. After all, on those days, there's no safety net for him in the building other than me, one of the few members of the community who have an idea what to do in case something goes awry. He is not the only member of our community who's affected by the nursing system. I can name at least 3 students who are close to me with the condition called POTS, which is the syndrome related to reduced blood volume that occurs when standing up or laying down quickly. Some of you might not know what that is, and I certainly don't know the name. I didn't know the name before joining the Health Justice Club. All I know is that these students experience fainting spells during class, and a teacher can only respond with pour water on your face, especially when one student did faint. I think this attests to the fact that no matter how hard we try, community members cannot pick up the slack for a missing nurse. But the lack of a nurse has not only heightened the stress for those with chronic illnesses in my community. Students get sick, students get hurt, and students need medical advice any day of the week, not on a schedule. Nurses can help students with their physical and emotional well-being, offer guidance on healthy habits, and be a trusted adult to turn to in times of need. Building a positive connection with nurses promotes a safe and nurturing environment for students to thrive in. This positive relationship, again, can only be possible with a nurse present every day, not on a schedule. Thank you for your time, and I hope that you better understand the importance of amending the budget to address the school nursing shortage.
Thank you. Thank you to this panel of witnesses, and also always thank you to the students who have joined us. Ms. Buckley, it's good to see you again, and thank you again for your continued advocacy on behalf of not just students at your son's school, but all over across the district. So this is the hearing for the Deputy Mayor for Health and Human Services, Department of Healthcare Finance. When we did have the hearing for DC Health, which is where the school nurse program is housed, we did have conversations with Children's around the breakdown in terms of the various, I would say, features of the program that would need to be turned on and off without having some additional funding. And telehealth was one of the things that they talked about. And so we're having conversations with colleagues in terms of how to sort of restore that funding. In terms of the overall, Ms. Buckley has heard me say this, but for the benefit of Lucy, Brady, and Charlie, this is the first year that we haven't had to restore cuts to the school nurse program. Last year, there was a $5 million cut to the program that we had to partially restore. But overall, in order to have a full-time nurse in every school, we're talking about an additional $25 million, which I can't pull a rabbit out of a hat, at least within my cluster. But we also have these ongoing challenges around just finding people in general. Nursing, there's less students who are going to nursing schools. There's less nurses who are graduating from nursing programs overall. But we're going to try to address it as best we can. Now, I want to ask a question because Lucy, you said there's only a nurse at your school 3 days a week, but the data that we have shows that School Without Walls has 40 hours of a registered nurse, which means that there would be a nurse there every day.
So that was the data that I got.
Okay.
And in my personal experience, probably 80% of the time that I do go to the nurse is not there.
Okay.
Whether that is like the data that I got is different. But whether that's like extended lunch break or certain things, or they're just not there that day. But there's definitely, I know maybe Brady can speak more on this, but there is definitely a lack of presence of the nurse, definitely.
This is why we're asking. I'm not in
Yeah,
school every day, right? So they send us a piece of paper that says, no, you have 40 hours. If you guys are saying you're not seeing this person, then that tells me that something's wrong.
Yeah, I would say so. Maybe, I don't know if Brady can speak more on this, but yeah.
Okay.
I would echo that. I've had to go to the nurse, multiple times a week because of diabetic related things. And there have definitely been like multiple times where she hasn't been there. And I was under the impression that her schedule was from Wednesdays to Fridays. So I don't understand why the data would reflect that, but maybe we're mistaken, but we can go check.
Okay. No, we can also check as well, but I want to thank you guys for your testimony and for coming down and participating in the process. I checked before I came downstairs. We only have 4 witnesses who have uploaded their testimony. So we need copies of your testimonies for the record. So if you just go to the DC Council website, you could just upload it right there. Just 3 clicks, maybe. But thank you so much again. And we're going to go to the next panel. Thanks, guys. Okay. My list for in-person for the Deputy Mayor for Health and Human Services is over. Is there someone here who expected themselves to testify for DMHHS? Okay. What's your name? Blanche McLoud.
Healthcare, it's going to be healthcare finance, yes.
Yes, in the next panel. We're just doing Deputy Mayor for Health and Human Services right now. Okay. Yes. Come on up. Okay, what's your name? Capri. All right, hold on one second. Anybody else? DMHHS in the building. All right. I'm sorry you have to sit by yourself, but you're gonna kill it as a solo. Go ahead. Oh, just turn your mic on. Hit the button.
Okay.
There you go.
Hi.
There you go.
Hi, everyone. My name is Capri Romney, and I'm a junior at Washington Latin High School and the founder and president of its Health Justice Club branch. I'm here to convince you of the worthy cause to make budget changes that assist DCPS in paying nurses competitive enough wages to station a full-time nurse in each school. In February of last year, on a Monday to be exact, I got increasingly dizzy as my morning classes progressed. This was very unusual for me and I was scared. When I left the class I was in to walk to the nurse, I went to the nurse's office and was met with the big letters, "No nurse until Wednesday." taped to the door. In this instance, we've been told at Washington Latin to go to the front desk as they can help with medical needs in the absence of a nurse. But when I went to the school secretary in the condition I was in, she could find no way to help. And I know it was not her fault. Nursing requires years of school, and they have much more knowledge to diagnose and aid a student rather than a secretary or faculty member does. Unaware that I had a temperature of 103, the lady at the front desk told me to get back to class because she was certain it was just the Mondays. What she couldn't have been certain about was that I would pass out on the stairs back to class and have to be taken straight to the children's hospital by my mom. There, it was suspected and later confirmed that I had a condition called postural orthostatic tachycardia syndrome, aka POTS. POTS is an abnormality of the functioning of the autonomic involuntary nervous system. It makes me and over 3 million American, mostly young girls, have symptoms of nausea, dizziness, and fainting daily. Though I am fortunate my symptoms can mostly be managed by lifestyle changes, I still need many breaks during school to rest and have a high sodium snack. Sorry, I lost where I was. And because of the nursing system in DC, that is not accessible to me when I need it. Just last week, a school director of many important daily responsibilities had to halt what she was doing just so I could have someone monitoring me in the nurse's office. And additionally, I was informed by a teacher at my school that there was a young student with a colostomy bag attending a DC public school. And because that school doesn't have a nurse consistently, the vice principal actually has to change that colostomy bag multiple times a day. And while most schools in the DC nurse cluster system have one registered nurse for every 4 schools, meaning not every school even has a nurse at all times, our middle school, the Cooper campus, doesn't have a nurse at all. These are just examples of the many hardships that come along with the lack of budget and system for DC nurses, which have not only negatively affected me, but many of my fellow students and teachers. I'm lucky to be able to access healthcare for my medical needs, but I know many of my peers cannot. And the school nurse is the best healthcare they can receive. We need more nurses in our schools, and DC has the means to do it. I strongly urge you to consider all children, healthcare, and education workers whose lives have been impacted every single day. I thank you for your time.
Excuse me. Thank you, Capri. Sorry. Thank you for your testimony and for advocating. And I think also highlighting too that our school nurse issue is not just within DCPS, but it's also within our charter schools as well. And I think your Cooper campus is new.
Yes.
Okay. So I think we're going to figure out whether or not I know that there is going to be some sort of construction that is happening at that particular campus over the summer to determine whether or not they'll have a nurse suite next school year.
Okay, great. We've had our Cooper campus for 2 years and we still haven't had a nurse. That's why I'm bringing it up.
Okay, awesome. Well, thank you so much for.
Of course.
All right.
Thank you.
Thank you. Okay, so we're going to turn to our virtual witnesses for DMHHS. Only 8, so I can call everybody. Again, for the virtual folks, you have to affirmatively accept our invitation to become a panelist. John Gloucester, Ward 8 Farmers Market, Libby Buckley, Parents United for School Health, Heidi Ellis, DC LGBTQ Budget Coalition, Deidra Brown, the Committee of the 100, Laura Pukat, Miriam's Kitchen, Joshua Drumming, Washington Legal Clinic for the Homeless, Eric Walcott from the DC Home Health Association, and Hillary Kaser. Again, you have to accept our invitation to become a panelist. All right. I don't see John Gloucester. Is Libby? No, Libby. Okay. Heidi? No, Heidi. Okay. Deidra. I see Deidra. Deidra, if you're speaking, you're on mute and your camera's off.
There we go.
There we go.
All right. You want me to go ahead and get started?
Sure. Yes.
Good morning. Thank you for your time. My name is Deidra Brown, and I'm submitting this testimony for the record on behalf of the Committee of 100 regarding the mayor's proposed budget for the Office of the Deputy Mayor for Health and Human Services for the FY 2025. DMHHS stands out as one of the few offices still set to receive significant federal funding despite the expiration of the $80 million in American Rescue Plan Act funds. We recognize that with an additional $184 million from federal grants boosting its operating budget, the proposed FY 25 budget exceeds that of the F 24 by $15 million. While Committee of 100 supports the mayor's initiative to augment the temporary assistance for needy families, there are concerns regarding proposed cuts to critical housing programs. Specifically, the mayor's plan includes a reduction of over 25%, amounting to more than $63 million for the Emergency Rental Assistance Program, Permanent Supportive Housing Program, and the Rapid Rehousing Program. While acknowledging the strain on local funds due to declines in commercial real estate revenue, the Committee of 100 urges the Council and the Office of the Chief Financial Officer to carefully assess the duration and extent of this financial impact. In the interim, drastic cuts to programs aiding residents with limited alternatives appears unjust and avoidable. The Committee of 100 also notes that the mayor has proposed Budget Support Act amendments that would affect the Rapid Rehousing Program and ERAP reporting requirements to the Council. We do not support repealing the monthly reporting on ERAP at a time when this budget could be significantly reduced. We recommend that the Council consider these reporting amendments via the regular legislative process to allow for public comment and more thoughtful consideration of the proposal. In conclusion, the proposed budget cuts to vital programs within DMHHS represents a troubling shift away from supporting the city's most financially vulnerable residents. These reductions will significantly impact the city's ability to address and prevent homelessness. It's imperative that these budget priorities be reconsidered to ensure equitable access to housing support for all residents, particularly those most in need. For these reasons, we are asking that the Council undertake a comprehensive review of the budget priorities and make significant adjustments accordingly. Thank you for your time.
Thank you. Laura?
Good morning. Good morning, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify. My name is Lara Pukat, and I am the Chief Advocacy Officer at Miriam's Kitchen, where we offer on-site meals and case management, street outreach, and permanent supportive housing. In addition, we convene the Way Home campaign, an advocacy movement to end chronic homelessness that's supported by 7,000 individuals and 110 organizations. I'm testifying today on behalf of Miriam's Kitchen and the Way Home campaign to express concern about upcoming encampment evictions. As you may know, the National Park Service and the DC government are slated to evict and permanently close 7 encampment sites in Foggy Bottom in May, a harmful approach that will displace up to 70 people. While a small NPS encampment closure was scheduled months ago, NPS has recently expanded the scope of these evictions, and the DC government, led by DMHHS, has taken this opportunity to close various sites on the same timeline. Displacement harms our neighbors. Clearing encampments damages trust and relationships that outreach case managers have worked hard to build with residents. These are some of our most vulnerable neighbors, and evictions will make it difficult for them to access the life-saving support and services they need to survive. Homelessness is traumatic, and the forceful eviction of encampments, often under threat of arrest, adds to this trauma. Encampment evictions make it harder to end homelessness. An estimated 20 people living in the encampment slated for eviction are matched to a housing voucher. And while DC must accelerate its housing process, displacing individuals will only make their housing process longer or disrupt it altogether. National and local experts agree that housing and supportive services end homelessness, while encampment evictions make it worse. Everyone needs a safe place to sleep, and encampment evictions take that away. DMHHS is moving forward with encampment evictions in the context of a proposed local budget with no new housing vouchers, decreased funding for street outreach, and cuts to DC's social safety net. There are not enough shelter beds for those being displaced, and many individuals were already displaced from McPherson Square, underscoring that there's nowhere else to go. If DMHHS moves forward, they will be clearing encampments without any resources to offer residents. News non-congregate shelter provides a safe solution to unsheltered homelessness. A small, dignified, non-congregate shelter, the Aston, was scheduled to open close to the encampments in question last fall, but has been delayed until at least August. Clearing encampments when there's a non-congregate shelter solution just months away from opening and just blocked away is particularly egregious. We urge the Office of the Deputy Mayor of Health and Human Services and this council to address health and safety concerns in encampments without evicting residents, to stop evictions until the Aston opens and every resident is matched with a housing or other solution that meets their needs, to address barriers to DC's larger shelter system and expand non-congregate shelter, to shift DMHHS's financial and personnel focus away from evicting encampments and towards connect residents to housing. And finally, to fund programs and services that end homelessness, such as permanent supportive housing, street outreach, and more. No matter our race, our income, we all need a safe place to sleep. Homelessness is increasing across the country as more households struggle to make ends meet. And clearing encampments and threatening arrest will make homelessness worse and make it harder for people to get and keep a roof over their head. Thank you, and I'm happy to answer any questions.
Thank you. Joshua?
Good morning. My name is Joshua Drummy, law graduate from the Washington Legal Clinic for the Homeless. DMHHS continues to weaponize immediate dispositions to clear encampments. While normal encampment engagements have a mandatory 14-day notice period, immediate dispositions allow DMHHS to clear encampments without notice, as long as they pose immediate risk to health and safety. Specifically, immediate dispositions don't require notice at the encampment site or DMHHS website. As of December, DMHHS's encampment response team has conducted 82 engagements, half of which were necessary immediate dispositions. It's important to reduce health and safety risk, but DMHHS abuses the health and safety risk language and wields it against encampments that are neither unduly obstructive nor health hazardous. Immediate dispositions are often used to remove one person from a site, precluding encampment residents from adequately preparing for a clearing. Encampment residents often receive little to no outreach before clearings, and posted signage may not be visible. Once clearance begin, all or nearly all belongings are thrown away, despite DMHHS's obligation to store non-trash items. The seizure and destruction of belongings during immediate dispositions without notice or adequate notice, the requisite risk factor, due process, or post-deprivation proceedings are likely unconstitutional and may lead to unnecessary litigation. We ask that council evaluate the current immediate disposition protocol and create legislative policies that standardize definitions and requirements for encampment evictions of all types, establishing due process for encampment residents and minimizing opportunities for random or politicized encampment evictions. Council should evaluate how FD12s are used at encampments. I was present at a recent encampment clearing of a young pregnant woman. She tried to gather her belongings. She was confronted by a group of MPD officers who decided she was not leaving quickly enough. Before she could exit her tent, they began tearing it apart. They removed and handcuffed her. She requested to use the restroom, was prevented from doing so, and had to relieve herself while handcuffed in front of strangers. As if the circumstances were not humiliating and traumatizing enough, the DBH workers present, without any justification, requested she be involuntarily hospitalized for mental illness observation via an FD12. Thankfully, after a brief detention and intervention, attempts to hospitalize her ceased, and she was released from custody. By then, of course, DMHHS had already destroyed or discarded everything she owned. This is the systemic cycle of harm and trauma that DMHHS perpetuates. While DBH and MPD were responsible for unjustifiably detaining the woman with threats of involuntary hospitalization, those threats were used to further DMHHS's goals. This committee recently introduced legislation to make changes to the involuntary hospitalization process. Any updates should prioritize clear standards, increase training for making determinations, and evaluation and investigation of how and when involuntary commitments are applied. The legal clinic would like to see a suspension of all encampment clearings. Instead, DC can conduct trash-only cleanings, provide additional trash cans at encampments, and maintain portable bathrooms and hand-washing stations. Additionally, ending full encampment clearings saves DC money. The decision was made to propose critical cuts to critical human services in the FY25 budget. There's no justification for the nearly $2.5 million DMHHS has in the budget, but much of it will be used to unnecessarily clear encampments. Budgets are moral documents. We urge council to invest in care over cruelty. Thank you.
Thank you. Eric?
Yes. Eric Walcott here. Oh boy, let me see if I could put my camera on. Hey. Okay. Greetings, Chairwoman Henderson and members of the Committee on Health. My name is Eric Walcott. I serve as Executive Director of the District of Columbia Home Health Association. a business league made up of some of the long-serving home health agencies, providing medical, Medicare and Medicaid personal care services to a large percentage of the state Medicaid and EPD waiver population in the District of Columbia. It is with much honor and consideration that I bring testimony before you on behalf of my executive board members, my general body, and for the most part, the entire home health sector. I want to recognize some of my other long-term care coalition members from whom you'll hear shortly on similar concerns raised by them today. Therefore, I may echo what may be said by others by virtue of the fact that these other long-standing concerns are worth addressing by council and the mayor. My testimony today will be directed towards recognition of efforts of the Department of Health and that of the Department of Healthcare Finance to address the key priorities of some of the home health sector around workforce pressures and achieving a competitive wage model that would allow long-term care partners to recruit and retain direct care workers in a very changing environment. In the context of the changing environment, long-term care workers providers are no longer are available in the numbers that they were prior to COVID-19 period. To be sure, more than 20% of the workforce has disappeared, lost to various factors, and will not be returning. Hence, the challenge for us as a coalition is what do we do to both retain existing workforce and attract new workers in the job market. While this is a complex matter, what we do know from the agile initiatives of other jurisdictions around the country is that government and private sector must work even closer together. For example, in some jurisdictions, the state Medicaid office has championed this effort with long-term care industry to partner with local higher education institutions to recruit college students in the job market. These individuals can be utilized to address weekend hours that are often very difficult to fill. Additionally, there are various models that are apprenticeship programs, rising high schoolers that can be introduced to the partnership with DCPS and the Board of Nursing. What is clear is that the workforce needs that we are experiencing requires a multi-pronged approach and ought to be supported through budget priorities of the city. While DCHHA and the long-term care partners are diligently working with the Deputy Mayor for Health and Human Services and the Director of the Department of Health and other senior staff, as well as with the State Medicaid Director, Deputy Director in Finance, it is the belief of this industry partners that there needs to be more enhanced approach for coordinating these efforts, because without such high-level coordination, the city will be working in silos and will achieve very little gains. And by the way, the Department of Health must find a way to maintain overtime hours for PCA services for individuals in the certain circumstances. This is not only the way forward, given the rather complex cases that exist within the District of Columbia, coupled with existing workforce challenges. This must be part of the built-in as part of the tools, measures for the program, and home health agencies simply cannot be allowed to shoulder the burden alone in the risk of going out of business. This was a lesson learned from the COVID-19 period. HHS reported that they could not survive the support and existing levels of PCA services without the use of overtime pay. And Madam Chair, I do not see anywhere within the budget where overtime is addressed or considered. Now, I do know that there was provision offered by CMS by the state Medicaid for state Medicaid directors, but to my knowledge, this was not pursued by the DHCF state Medicaid director. But if not through this Schedule K, then how else is this vital need to be addressed? Madam Chairwoman, I'm aware that existing programs for training for home health aides, supported care workers currently are required that you must be district resident. I appeal to you to reconsider, look at it more closely, because most of a large percentage of the home health workers in the District of Columbia do not currently live in the district. By modifying such requirement, the District of Columbia will be able to increase the workforce significantly. Thank you very much, Madam Chair, and I appreciate the opportunity to give testimony before you.
Thank you, Mr. Walcott. Thank you so much to this panel of witnesses. Hillary Kaiser had another meeting, so she's submitting testimony for the record. And I hope that all of you will submit testimony for the record, because as I said before, we are missing written testimony from quite a few of you. Ms. Brown, I'll start with you. Thank you so much for being here. I think, though, some of the testimony that you were raising was with regard to the Department of Human Services, not necessarily the Department of Deputy Mayor for Health and Human Services. I was a little confused when you started at the top, when you were saying, oh, there's 148 million in DMH. I was like, whoa, wait a minute. I didn't know that DMH just had that money. Hold on. But there is some overlap in terms of the concerns that you raised around, what happens with DHS most certainly impacts the rest of the Health and Human Services cluster. Similarly, Laura and Joshua brought up some issues also related, that cross-cut between DHS and DMHHS, and we'll certainly ask some questions, particularly around the encampments. and the progress in terms of the Ashton. But thank you so much for being here. Mr. Walcott, we addressed a couple of the issues in terms of home health aides in the Health Occupation Revision Act that could address some of the issues that you raised around increasing the pipeline. There's also funding in another part of the budget in the Committee of the Whole that with the Office of the State Superintendent for Education, there's an advanced technical center, a second center that they're going to be opening that will allow for high school students to specifically train in health fields. And now that we've lowered the age for CNAs to 16, hopefully we'll have some folks who are 16, 17, 18 who are graduating with their CNAs and able to sort of help in terms of the workforce issues as well. But we'll ask some questions about the overtime. I didn't see it in the budget, but perhaps it's there and missing. But thank you so much again to this panel of witnesses. We're going to move on to the next panel.
Thank you, Madam Chair.
Which is also moving on to the Department of Healthcare Finance. There are two, so yes, this is hybrid. We've got some virtual, we've got some in-person, but we have two virtual to start. And James Jean-Claude and Kevin Moats. Again, you need to affirmatively accept our invitation to become a panelist. Okay, I see James. So James, when you're ready.
Is Kevin able to go first or?
Kevin's not here, so it's all you.
Okay. Okay, well, I apologize here. I apologize for my video appearance, but essentially the problems with the home aides situation has been outlined by some of the speakers before me and some who will be speaking after me. But one of the things that I want to convey or ask the, I guess, council to consider is looks like we're going to be setting the standard for the DMV for pay for home aides, which will help increase the number of people in the pipeline, which I'm all for and I totally support. But if we're going to be paying top dollar in the DMV, I also suggest that we maintain high standards. I know one of the things that was impressed upon me when a friend of mine who is blind and I spoke is they said that we use desperate people to take care of desperate people. And I thought about that. I was like, wow, that is so true. You know, so many people who are working in this field come from desperate situations. They came, overcame many hardships to either come to this country or the hardships to get trained in, et cetera. But we shouldn't lower our standards. When I heard from the last hearing that Maryland doesn't test applicants to see how well they absorb the training, that to me seemed outrageous. And the fact that Virginia doesn't do background checks, that also seems outrageous. And so I hope DC doesn't lessen its standards for either one, that we do require testing and that we do background checks, because both those elements are important. And I hope that we don't lower our standards when it comes to that with the new aides. Also, in terms of competence, if we're going to be paying top dollar for aides with taxpayer money, we have to make sure that they're very competent. I've had I have some aides now that are a couple aides that are still very good. I'm still trying to fill the third slot. But there have been times where I've had aides who tried to wash me without soap. I was like, oh my God, how could you do that's you've washed me without soap? That's not washing, that's rinsing. But they said that some patients like it that way. I was like, that is not hygienic. And I don't know who's told you that, but soap should always be used when cleaning a patient. And then there's been some aides who've been sent to me who've never changed diapers before. And I was shocked. I was like, well, I'm bedbound and use a wheelchair. And how could they send you here knowing that I use diapers, but if you've never changed diapers before? Also, the English level. There have been on a couple occasions where the English level of my aide was not up to par, and they could not understand all my instructions or all of my requests for care or to fulfill my needs. So there should always be at least a conversational level of English. They don't need to be put. Yeah, they should have at least a basic level to do the job. Also, lastly, some have to be physically capable enough. Some can't. Some couldn't hear well enough to hear me when I was calling for them. Some were not fragile or not strong enough. Some were slow to react to emergencies. Some were sleeping on the job. Some couldn't do range of motions. Some had. I've experienced every type, from bullies to religious fanatics to sexist and misogynistic aides. And I'm not saying all aides are like this at all. It is a small minority. But I just hope that as we move forward, we maintain our standards. And I thank DC for being an example, shining example for the nation on how to treat home aides and people who need them. Thank you very much.
Thank you, Mr. Jean-Claude, for your testimony. And I think I remember you testified at a different hearing as well about some similar issues. And so some of the licensure things that you raised, we won't be handling in this budget bill, but we will be taking it up. And we've been having ongoing conversations with the Department of Health, as well as the Department of Healthcare Finance, about some of the licensure issues. But thank you so much for being here today. Appreciate your testimony.
Thank you.
All right. So we're going to move to our in-person witnesses. Again, I have 4 seats, so we're just going to call and see who's here. Mary Katherine West. All right. Leah is here. Dr. Freeman. Don't see him. I don't see Destiny. I don't see Terrence. Catherine Crossland. Ooh, all right. Hang on. Some folks who requested to go as a panel, so we're gonna skip you. Sal. Sal's here. Derege. All right. Okay, Miss West, when you're ready.
Good morning, Chairperson Henderson and committee staff. Thank you for the opportunity to address the committee today. My name is Mary Katherine West, and I am the chair of the DC Home Visiting Council, program manager for Early Childhood at DC Action, a member of the Under 3 DC Coalition, and a Ward 1 resident. Today, my testimony focuses on supporting home visiting programs and the families they serve through the Department of Healthcare Finance, including the Nurse Family Partnership Program and the Medicaid reimbursement legislation. First, we want to thank the mayor and the Department of Healthcare Finance for the addition of a recurring $225,000 home visiting grant that will support the Nurse Family Partnership Program. NFP is an evidence-based home visiting model that matches parents who are expecting their first child with registered nurses. Families enroll in the program prenatally, and their nurse delivers high-quality visits and interactions through the child's second birthday. The Nurse-Family Partnership has been operating successfully in the district as a pilot program over the past 3 years. My written testimony shares the positive health outcomes that have come from this program. Supporting these health outcomes is vital as the district works to combat maternal and infant health disparities, especially in the context of high adverse birth outcomes for Black women and their babies compared to other demographics in the district. However, as the program has completed its pilot phase, it needs an additional funding of $475,000 in fiscal year 25. Without additional funding, the district is at risk of losing the program. Nurse home visitors have committed to serving district families who face some of the greatest barriers to accessing resources, and they would have to terminate care if the program is not funded. We cannot afford to lose vital resources meant to ensure that low-income parents are safe, healthy, and supported. For the additional investment to be one-time, the council must begin implementation of the Medicaid reimbursement bill to provide a pathway for sustainable funding for NFP and other home visiting programs. Through leveraging of federal resources, Medicaid reimbursement is an opportunity for the district to maximize impacts for families and achieve long-term stability for home visiting programs budgets so they can best serve families. We believe that the OCFO has overestimated the cost of this program. We appreciate the coordination with the council and the OCFO over the past several months to reconsider this analysis. To support critical services that home visiting programs provide the district families, we ask the council to fund the Nurse Family Partnership's $475,000 funding gap, to update the FIS for the Home Visiting Services Reimbursement Act of 2023, and to fund the Medicaid reimbursement for home visiting based on the corrected estimates. Thank you so much for the opportunity to testify today, and I welcome any questions.
Thank you. Leah?
Good morning, Chairperson Henderson and staff. My name is Leah Castas. I'm a policy attorney at Children's Law Center and a resident of the district. Thank you for the opportunity to testify today regarding the mayor's proposed budget for DHCF. DHCF's Perinatal Mental Health Task Force identifies home visiting as a critical support in the continuum of care to address perinatal health concerns. We agree. As of FY23, there are 17 home visiting programs throughout the district. One of those programs is Mary Center's Nurse Family Partnership First Time Mothers Home Visiting Program. In 2021, Mary Center piloted NFP to address a gap in populations being served in current home visiting programs. NFP focuses on supports for first-time mothers facing financial barriers. Since the launch of NFP, Mary Center has seen many positive outcomes for its participants. We are grateful for the council's continued support of NFP in the district. In FY22 and FY23, DC Health local funds were used to support the launch of NFP in the district. Mary Center secured the necessary additional funding through private philanthropic dollars. In FY24, funding shifted from DC Health to DHCF, and NFP was awarded one-time grant funding of $225,000 to continue to support their work while waiting for Medicaid reimbursement for evidence-based home visiting services to become available in the district. Unfortunately, all the funding for NFP, local district dollars, and philanthropic dollars are set to expire at the end of FY 2024. We were therefore very pleased to see that the mayor's proposed budget includes a reoccurring investment of $225,000 for home visiting grants. Unfortunately, it is not enough to close the gap needed to maintain NFP in the district. NFP costs $800,000 per year. This cost covers staff, all of whom are registered nurses, training, services and resources for families, and supervision. Based on Mary Center's current fundraising strategy and the proposed FY25 budget, we are asking this committee to invest one-time funding of $475,000 in NFP in FY25. The one-time funding for NFP is only possible if the committee also invests in the Home Visiting Services Reimbursement Act of 2023. We are grateful for this committee, its members, and its staff who have worked with the OCFO to lower the FIS for the act, so it is reflective of the true cost of implementation. Investing in this act at this lower FIS means that the district will be able to strategically leverage federal Medicaid dollars to support NFP and other evidence-based home visiting programs beginning in FY25. Difficult budget years like this one highlight how unstable grant funding is. Grants can easily be cut or repurposed, leaving programs unsure of their futures. Medicaid funding is more stable and ultimately allows the district to move away from heavy reliance on local dollars to fund programs. We therefore ask this committee to also invest in the Home Visiting Services Reimbursement Act. Thank you for the opportunity to testify. I welcome any questions the committee may have.
Thank you. Sal, it's good to see you in person.
It's good to be seen in person. Good morning, Councilmember Henderson and staff. My name is Sal Saggio, and I'm a member of the DC Coalition of Long-Term Care. I'm here today to provide testimony on our current lack of a sufficient healthcare workforce, which is becoming amplified as DC's population becomes older and more in need of their services. From attending these hearings and listening to the needs of other groups who testified before you, I've come to appreciate the difficult and important decisions you and other governmental officials need to make regarding how to spend our tax dollars. In deciding how to allocate our resources, it is most important to remember that it is our first duty to protect the welfare of our most vulnerable populations. You've heard from individuals whose lives depend upon the availability of trained healthcare workers to help with their most basic activities of daily living. Their ability to be fed and have hygienic services are not optional. When trained workers are not available, these folks must depend on family members or friends who many times need to take off from their work. Or
Sal,
worse.
I'm sorry to interrupt you, but can you move the microphone closer to you?
Certainly. Okay, is that fine?
Lean in. Hug it a little. There you go.
I'm a married man. Okay. The sorry, Andrea. The ability to be fed and have hygienic services are not optional. When trained workers are not available, these folks must depend upon family members or friends who many times need to take off from their work. Or worse, they are left unattended for hours to suffer the physical and psychological consequences. The solutions needed to rectify our healthcare workforce crisis are complex. I'd like to highlight a few keystone issues. The first one is providing a reasonable wage. You've been provided data from surveys taken from employers of direct care workers documenting that the pool of qualified healthcare workers in district is shrinking and doing so at an alarming rate. There are many reasons for this, but the driving factor is that when potential workers decide whether to take a job that will compensate them enough to feed their families and pay their bills, and one does not, that choice is not difficult. I have heard the argument that these potential workers would enter the field anyway because of their deep desire to help those in need. I'm sure that this is a motivation, but as has been seen by their exodus from the healthcare workforce, the practicalities of life will trump altruism. The second keystone issue is to create educational pipelines to ensure that we will have a sufficient number of potential healthcare workers. With our district population shifting to the older demographic, this is something that needs to be addressed now. Students need to see these occupations as skilled careers that will provide adequate compensation, have potential for advancement, and give meaning to their work by helping others. Finally, the DC government needs to realize that this healthcare worker crisis will require a multi-agency approach, with a department or agency given the authority to coordinate and initiate solutions. A successful approach will need to have a clear and realistic vision of what can be accomplished with available resources and the desire to break through the bureaucratic barriers that a project of this scope will encounter. I want to thank you and your staff for your efforts that have kept this issue front and center, and I'm happy to answer any questions.
Thank you. I butchered your name the first time, so.
Okay. Dr. Deidra Brown.
Dr.
Yeah, I'm a dentist from Southeast Washington.
No, just say your last name for me again.
Dr. Deidra Brown.
Beretted.
Mhm.
Beretted. Okay, go ahead.
Yeah, I'm just like I said, I'm here to testify today. This is something I really want to do, or have, to tell you the truth, I've never done it before. But the situation is so real, and I decided to come. And over the last 2 years, I'm trying to ring the bell about the healthcare, oral healthcare discrepancy in Washington, Ward 7 and Ward 8. I have served that community for the last 23 years, my entire adult life, pretty much. We reached to the point, it's becoming, I call it a crisis. We have massive shortage of healthcare workers, as he mentioned it. When I took over, at one point I had nearly 8 offices, I'm sorry, 6 offices in Southeast Washington, DC. When I took over some of the office from the old doctors, the rent was $500-600. Today I'm paying $12,000. I used to pay for a doctor's about $500. Today we pay as much as $1,500. And the flight of healthcare workers is amazing, but when it comes to dentistry, it's beyond anything. I'm trying to ring the bell. I had a meeting with Councilman Trayvon White. I have a meeting with Deputy Mayor, and a year and a half ago, I literally screamed and told them this is a very serious issue. The city spends millions and millions of dollars over the last 20 years and achieved a lot of milestones. Now, all those milestones are gone. Today, I'm starting seeing a lot of issues when it comes to massive problems. I'm talking about kids with a lot of cavities. For the last 7-8 years, we have never seen it. Now, literally, it looks like the city, whatever the city invests and get again, is losing it now. My hope is, what I'm trying to tell you was that the city has never visited this issue. I think when it comes to reimbursement, we had fee schedule change about in 2007. Since 2007, hasn't changed any, even if it went worse. Today, we reached to the point like we can't be able to provide any services. Like I said, at one point, I have 8 doctors, now all gone, but 2. The second one is about to leave. She gave me already a notice. So we're gonna end up me and another doctor. I don't know what the second doctor may leave. At one point, I have nearly 30 employees. Now it's way down to less than 10. The situation is really serious. Unless the city do some kind of measure, we're gonna have a very serious crisis pretty soon coming under our way. Thank you.
Thank you. Thank you so much to this panel of witnesses. I'll start with you, Dr. Brady. You know, how we treat oral healthcare and eye healthcare different than we treat the rest of the body, I think is sort of actually central to a lot of the issues in terms of, you know, people, they'll have health insurance, but they won't have dental insurance, or they won't have insurance to see an optometrist or an ophthalmologist. And so it kind of becomes sort of this secondary issue, if you will. We could ask healthcare finance in terms of the reimbursement schedule, in terms of dentists. The reimbursement schedule has been, I think, a barrier in some of the other types of equity issues. You know, we addressed it in terms of mental health, right? I didn't have enough, and I still don't have enough psychologists or social workers or otherwise who are taking patients with Medicaid because of the reimbursement is so low. And as you sort of point out, the reimbursement is not matching now the costs on your side, from like the idea that you went from paying what $500, $600 in rent to $12,000 for rent for a dental office is just astonishing. So we'll ask some questions in terms of that. Sal, thank you so much for your testimony and for being here as well. You know, this is an issue that we're continuously working on and trying to chip away at. But it's always good to have it elevated as we continue, particularly around the wage piece that we're still going to work to try to tackle a little bit. Mary, Catherine, and Leah, I wanted to ask you some questions about the Nurse Family Partnership funding. So obviously I've met with the Nurse Family Partnership and heard some testimonies in terms of the excellent work that they do. So I just want to clarify, you guys are saying 475 because Mary's Center believes they have the ability to fundraise the delta of the 800.
Yes, that's correct.
Okay. All right. And you're saying one-time money.
If we fund the Home Visiting Services Reimbursement Act, because then we could start drawing down the Medicaid dollars this year, and we won't be back next year because we'll be utilizing Medicaid dollars. So
Okay.
it's kind of a twofold approach, but we believe that we just need one-time funding this year, plus a little bit to get the Medicaid rolling. DHCF has said that they won't get that rolling unless it's in this budget.
Okay.
So that's kind of the twofold approach, but then we wouldn't need to continue to give high grant amounts to Mary Center or many of the other evidence-based home visiting programs. We could really start to rethink home visiting funding in the district.
Okay. And Mary Catherine, just for the record, so people know the difference, and you explain the difference between the home visiting grant programs that we have versus Nurse Family Partnership.
In Could you repeat the question? I'm sorry.
The difference between the two programs. So obviously there's about, I think, what, 200,000 or so in recurring dollars for home visiting. And you're asking for this additional, but this is a different type of program, home visiting, but slightly different.
Yes, so currently the Nurse Family Partnership is the only home visiting program in Department of Healthcare Finance. So that recurring grant that is in Department of Healthcare Finance will support the Nurse Family Partnership program.
Okay.
Would you like to expand on like the fact that Nurse Family Partnership utilizes registered nurses
Thank
to
you.
provide? Okay,
Yeah.
sorry. So do my, okay, fill in for me if I miss anything, but just for the record, the Nurse Family Partnership Program is the only home visiting program in the district that uses registered nurses to provide the home visiting services. The others are utilizing folks with their bachelor's degree that get specific training in other types of programs like Parents as Teachers or Healthy Families America. And we also have some really great homegrown ones like father-child attachment. Georgetown University has a homegrown program that's actually working towards a Parents as Teachers certification. So there's some distinction there in terms of the who's providing the home visiting services and then also the populations that they're serving. And so NFP is very focused on first-time mothers, where other home visiting services are focused on children ages 0 to 5 oftentimes. And so that can be a range of populations.
Great. Thank you. Thank you so much to this witness panel. I just want to say, Dr. Brady, I got a note that says Healthcare Finance is currently reviewing the dental fee schedule now. So hopefully we'll have an update on this soon. Yeah, correct.
I just closed one of my offices at the beginning of this year. The second office is going to be closed at the end of this summer. I'm going to end up only one office and one doctor. We headed to that way. The reason why I stayed the last 2 years was because I had a loan from the SBA loan. That money is ran out now. Hopefully some kind of relief comes. Without that, I'm going to be ended up with one office and one doctor, just me, from 8 to 1. That's where we headed to. And if you come to my office in the morning, you'll be seeing there is a lot of emergency patients lined up outside. They have nowhere else to go.
Yeah.
Literally, I'm the only one in Ward 7 and Ward 8 accepting emergency walk-in patients. They're becoming, it's unbearable now to the point.
Got it. Well, thank you. Thank
Thank
you.
you.
Thank you for your work and thank you to all of you for being here. Okay. Ruth Pard, Kelly Sweeney McShane, Jessica Boyd, and Tolly Elliot. Okay, hello. Ms. Pollard. There you go.
Good morning, Councilmember Henderson and Committee on Health and Staff. I'm Ruth Pollard, President and CEO of the DC Primary Care Association and Executive Director of the DC Connected Care Network. Thank you for the opportunity to provide testimony regarding the work and budget of the DC Department of Healthcare Finance. I'm joined on the panel by 3 dynamic FQHC leaders with decades of experience serving patients in need of robust, effective, and connected primary health care. Our testimony today focus on the opportunity for healthcare transformation driven by our FQHC clinically integrated network, the DC Connected Care Network. In pursuit of greater quality and better outcomes for DC residents, DCPCA has partnered with 7 FQHCs to establish the DC Connected Care Network. The Connected Care Network heralds a new era in provision of high-quality comprehensive primary care that integrates with acute care settings and addresses behavioral health and health-related social needs. All district residents deserve to thrive. DC Healthcare Finance leadership and resources are needed to ensure the CCN can realize its unprecedented promise in reaching that goal. Participating health centers are Breadford City, Community of Hope, Family and Medical Counseling Service, La Clínica del Pueblo, Mary Center, Unity, and Whitman Walker Health, whose CEO Naseema Shafi is also here today. The CCN provides structure and resources to support coordinated care that prevents avoidable hospitalizations and readmissions, minimizes duplication of services, and addresses gaps in care. Combining the services, partnerships, and practice culture of the member FQs, the network establishes a continuum of care that addresses the diverse needs of each patient. Primary care is the cornerstone of any developed healthcare system, providing crucial curative care, preventive services, chronic disease management, while bridging gaps in racial and ethnic disparities. DHCF has the opportunity to realize the benefits of high quality and comprehensive primary care by implementing the following recommendations. Invest in infrastructure for the federally qualified health centers and the DC Connected Care Network. Support comprehensive primary care models with a strong focus on team-based care. Require the managed care organizations to develop primary care-centric, value-based contracting models and integrate social care into healthcare system transformation. The CCN is dedicated to improving the health of DC residents through comprehensive patient-centered primary care that incorporates innovative technology and team-based care, leverages value-based contracting, and integrates social care to deliver the best outcomes for patients. We are grateful for our strong partnership with DHCF, and we urge DHCF to invest its dollars in the FQHC and the Connected Care Network, where transformation and outcome improvements will derive and where cost savings will be reinvested in the people and the communities we serve. Thank you.
Thank you. Kelly.
Good morning. I'm Kelly Sweeney McShane. I'm CEO of Community of Hope. I'm also here today in my role as chair of the DC Primary Care Association Board and a member of the board of the Connected Care Network. My testimony will focus on the need to invest in team-based care. Despite its importance to overall health and well-being, primary care spending nationally is in the single digits compared to spending on specialty and hospital care. My written testimony includes data about both of these factors. As the health system confronts the shortage of primary care providers, we must increase investment in team-based care that coordinate and integrated care between non-physician providers and other support staff. Team-based care is associated with greater quality of care, responsive to change, and ability to adapt team roles. The Connected Care Network is an opportunity for all of us to work together to improve care coordination, care management programs, and outreach and engagement strategies. Network members can access shared information systems and data, shared best practices, and enhanced capacity as a collective body versus as individual FQHCs. At Community of Hope, we have invested heavily in team-based care, primarily through DC government grants and philanthropy, which is definitely a theme of today. For example, we are implementing a community health worker model through a DC health grant that ends on September 30th. We've also deeply invested in perinatal care coordinators and other wraparound support services for the perinatal program. And I know we've discussed this model, and there is a graphic in our written testimony about what that looks like at Community of Hope. We are seeing excellent results as a result of this care. For example, Community of Hope is rated in the top quartile of FQHCs nationwide with regards to patients with controlled hypertension and diabetes. And I have some additional data in my written testimony about excellent results in these areas. In terms of maternal health outcomes at Community of Hope, the percentage of newborns with low birth weights dropped from 11% in 2022 to 9% in 2023. And this is in comparison to 14 to 15% for residents of wards 7 and 8. Preterm birth rates also dropped from 11 to 10%, and that's in comparison to 13.3% for Black birthing people in DC. And as you know, these are very hard metrics to move, so we were very pleased by these outcomes. Unfortunately, these innovations are all covered by grants, and we need a sustainable funding mechanism that would allow all providers to scale these interventions. You'll hear the same echo that you just heard from Ruth in terms of what our recommendations are for investments, direct investments in the CCN and FQHCs to help build team-based care, looking at the 1115 waiver as an opportunity, a state plan amendment that facilitates sustainability for community health workers and perinatal navigators. There are some CMS primary care focused initiatives. We're talking about alternative payment methods for federally qualified health centers, and a managed care quality strategy that requires reporting on and increases in primary care investment. We appreciate the department's consideration of all these vehicles to best align with our shared goals to increase primary care at capacity, improve access, and support health centers' delivery of high-quality team-based care. Thank you so much.
Thank you. Dr. Boyd.
Good morning. I'm Dr. Jessica Henderson Boyd, President and CEO of Unity Healthcare. Unity's mission is to reach people wherever they are to provide compassionate, comprehensive, high-quality healthcare that's accessible to all and advances health equity in Washington, D.C. I'm here today in my role as the chair of the D.C. Connected Care Network. Unity has invested significant time and financial resources in the CCN because we believe it's the path forward for rightly centering primary care as the cornerstone of our health system. The district's health centers, which together serve nearly 200,000 people, many who face health inequity, have formed a provider-led organization, the CCN, to strengthen our ability to meet the service needs of patients and improve outcomes. As the cost of care increases and outcomes remain disparate, the CCN needs the support and engagement of DHCF and our MCO partners to engage in proven strategies for value-based care that create capacity for care management, coordination across the care continuum, and the capacity to address social needs at the point of primary care delivery. Specifically, we need a model that financially invests in the right care for the right patients in a way that transforms care and drives value to patients to address health inequities. I had a recent 12-year-old patient with asthma, and it was out of control, and he was missing more than 20 days of school. He needed a plan for an ENT evaluation. He needed a nutrition consult to help him navigate his obesity. He needed a social work consult to help him identify food resources. And he needed a partner to think through how he could exercise in a community that was riddled with violence. This kind of patient-centered care requires a payment system that supports outcomes and really fosters innovation. Our framework for values-based payment that drives resources to beneficiaries and communities includes shared savings based on total cost of care performance to bring the right level of investment to providers and build the capacity to impact outcomes and assume risk. Aligned quality program metrics, upfront infrastructure and administrative payments to build the infrastructure and the administrative capacity to coordinate care, monitor network performance, and identify the highest value opportunities. And it requires aligned MCO contracts with the CCN on behalf of the FQHCs. DC Healthcare Finance has the power to both invest in primary care and hold MCOs accountable to improving the well-being of high-priority district residents who have struggled against economic and social oppression. The CCN's success in achieving shared savings means investment in the very communities that need those resources the most. FQHCs are mission-driven to use those dollars for the benefit of the communities and the people that we serve. We are DHCF's best partner to work together to end the persistent and pervasive inequities that drive disparate health and well-being in the district. Thank you to the Deputy Mayor and DHCF Director Wayne Turnage and his team of leaders. I'm confident that our shared commitment to improving outcomes and equity aligns us as partners in the very important work towards primary care transformation.
Thank you. Dr. Elliot.
Good morning. I'm Dr. Tyler Elliott, President and CEO of Mary Center, also an OBGYN. Mary Center's mission embraces all communities and provides high-quality healthcare, education, and social services to build better futures. I'm here today as the Vice Chair of the DCPCA Board of Directors and as a member of the DC Connected Care Network contracting team. My testimony will focus on the need to integrate social care into healthcare system transformation and the way in which the 1115 waiver renewal can support the Connected Care Network. Mary Center recognized early on that only caring for the patient's physical health concerns was simply not enough. To facilitate patients and their families on a path towards better health, stability, and economic independence, we knew we had to look at every part of their life and offer the appropriate combination of healthcare, education, and social support. All our fellow FQHCs in the CCN have similarly innovated to make whole person care core to their models. The Community Health Center model itself has been anchored in this approach since its inception during the Civil Rights Movement. Now, the entire healthcare system is recognizing the importance of social drivers of health, otherwise known as SDOH, and health-related social needs, HRSCNs. The conditions in which people are born, grow, live, work, and age, which are shaped by the distribution of money, power, and resources, drive more than 80% of variation in health outcomes. We applaud DCHF's draft 1115 waiver renewal that will provide resources to address these health-related social needs. We urge the following recommendations to leverage the waiver to invest in primary care. Support direct contracting between Medicaid and the DC Connected Care Network to meet care coordination goals and ensure community social services are integrated with clinical care. Leverage FQHC's already strong relationships with key social services partners. Invest in care teams, peer navigators, and community health workers to achieve better outcomes. And drive resources at the provider level closest to the beneficiaries. We appreciate the department's consideration of these recommendations to integrate social care into healthcare long-term, and we look forward to further progress in this partnership. Thank you.
Thank you. Thank you to this great panel of witnesses. Familiar, at least for the direct care folks, familiar with your organizations and the work that you all do. I want to ask first about the community health worker. So I just want to confirm, you guys had some additional funding for community health workers, and does that funding end at the end of fiscal year 24?
It does. It's just it was a 2-year grant. So September 30th, it's ending.
Okay, so were you able to privately fundraise to perhaps fill in that hole?
I am working on that, but it is not yet in place.
Okay. And how much was that?
I'm going to say about $500,000 a year, but let me check. It's also, I believe, Community Hope and Whitman Walker were the 2 grantees.
Okay. If someone can just get back to us
Sure.
on that, that'd be great. In terms of the things that you raised around, direct investment in FQHCs and the 1115 waiver, which is an ongoing conversation, although someone told me that there's a draft. Yeah, there's a draft that exists out there on the interwebs. Yep. And there are hearings. So please comment and provide feedback on how we can use that as a great tool for sort of what we should do moving forward. I don't have any additional questions right now, but should we have some additional questions? We'll certainly follow up with you guys. If you can all submit your testimony for the record, though, because we don't have any of your written testimony, and that would be great. So thank you. Thank you for being here.
Thank you.
Thank you.
Thank you.
Okay. I'm trying to figure out our next panel here. Unfortunately, I'm gonna have to split you guys, so sorry. Well, let's see. Is Sally White here? Great, Sally's here. Claudia? Not that Claudia, this Claudia. Sorry, Claudia. Claudia Bog. Okay. All right. Jackie Bowens, and then we'll do Dr. Argas, and then we'll have the other hospital executives go after that. Cool. All right, Ms. White.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Sally White. I'm a member of the DC Coalition on Long-Term Care and the Leading Age DC Board of Directors. I've been an advocate and leader in organizations for older adults in DC for close to 40 years. I'm here today in support of funding for the direct care workforce caring for the district's most vulnerable older adults. As you well know, we are faced with a critical shortage of direct care workers, the majority of whom are home health aides and certified nursing assistants. According to the Board of Nursing, we lost 30% of this workforce at the end of 2023 when 4,489 individuals did not renew their license to work in DC in 2024. Solving the crisis requires work on many fronts, including expanded training opportunities for residents who want to be HHAs and CNAs, developing a reciprocity practice so that Maryland and Virginia residents can easily and safely work in DC, and achieving the additional goals outlined in the Direct Care Worker Amendment Act, which you introduced and which must become law and funded as soon as possible. Of all the needs stated in the Direct Care Workers Amendment Act, the most urgent is the need for higher wages. Until wages are increased, the exodus will continue, and more older adults and those with disabilities will suffer. During his testimony on the act, Director Turnage expressed that he's not convinced that wages remain a serious issue, at least in part because most providers are not turning in audit reports to DHCF showing that funding is not adequate. I have several concerns about this approach to the issue. The first is that the audit expense reports are not required, but optional. So perhaps agencies don't understand the potential impact these reports may have on their reimbursement rates. Secondly, and more concerning to me, is how exactly those reports would show that the reimbursement rates are not high enough. Can DHCF glean from the reports how many staff have left in the past year? Will they be able to see how many staff slots are proving impossible to fill? Do the agencies have to show a significant deficit to be considered for a higher reimbursement rate? How can they remain in business if so? If difficulties attracting and retaining staff are the primary impacts of low reimbursement, then I don't think the financial audit will give DHCF the information they say they need to make a decision about increasing reimbursement. Vacancies, high turnover, aides telling employers that they are leaving for higher paying retail jobs, non-renewal of licenses, the turning away of potential clients because of understaffing. These are measures of low reimbursement rates which must not be ignored. We urge the council to fund reimbursement for direct care workers serving older adults and adults with disabilities at an average wage that is 135% of the living wage. The 17.58 million estimated annual price tag for this increase is critical to the future of this city for young workers and older care recipients alike. Thank you.
Thank you. Ms. Blog.
Chairperson Henderson and staff, thank you for this opportunity to testify. My name is Claudia Bog. I'm an Assistant Director of Research with 1199 SEIU, United Healthcare Workers East. We're the largest healthcare union in the country with 400,000 members across settings in New York, New Jersey, Maryland, the District of Columbia, and Florida. And in the district, we represent thousands of healthcare workers in hospitals, clinics, skilled nursing, and assisted living facilities. I'm submitting this testimony on behalf of all the healthcare workers who are struggling to survive on poverty wages, while the consumers who depend on them face the impact of these staffing shortages, and our members who frankly cannot leave their residence today to be here. We second this urge upon the council to identify funding in the district's budget to support the goals of the Direct Care Worker Amendment Act. We appreciate your dedication to attempting to solve these problems. We recognize the challenges of this budget, but the failure of this proposed budget to include money to address the wage gap will exacerbate this documented care crisis. So you've heard about this astonishing number of aides who are no longer who have chosen to quit this work. This data is reflective of the lived experience of our members who work in long-term care congregate facilities. Workers, every single one of them, are exhausted. They're caring for increasing numbers of residents with complex medical needs, while these workers are unable to pay their bills and they're leaving the healthcare industry. Meanwhile, this reverberates throughout the healthcare continuum. Our members in other post-acute settings, such as FQHCs, have personally described to me how they see the impacts of this staffing crisis on their patients. One of our members at Whitman Walker, who will be submitting written testimony for the record, described to me how patients regularly miss their medical and legal service appointments because they had no aid to get them there. Patients are also seeking additional legal services because they're not receiving the number of hours of care that they were approved for. So we have to raise these wages high enough to be eligible for funding by OSSI for training. You know, you've seen the written testimony supporting the MIT living wage calculator at 24 an hour. I just want to note that I've submitted lengthy written testimony identifying states across the country that are tackling these same problems. And there's no one size fits approach to this problem, but every jurisdiction that's trying to address this is looking at wages. They're including strong investment to create a stable healthcare workforce. And the approaches all include strong government executive level engagement characterized by multi-agency collaboration to enable industry reform. So I'm going to stop there, and I'm available for any questions. Thank you.
Thank you. Ms. Bowens.
Greetings, Chairperson Henderson and members of the committee and staff. I'm Jacqueline Bowens, and I am the President and CEO of the District of Columbia Hospital Association. I'm joined this morning by Dr. Gregory Argas, who's the President of Washington Hospital Center and the Chair of the DCHA Board of Directors, Ms. Anita Jenkins, CEO of Howard University Hospital, Mr. Tony Coleman, CEO of Cedar Regional Medical Center, and Mr. Aldwin Lindsay, Executive Vice President, CFO of the Children's National Hospital. And we all very much appreciate this opportunity to present testimony at the Department of Healthcare Finance's FY25 Budget and Oversight hearing. As many of you have noted, this is the most challenging budget we've seen in recent memory. We appreciate the efforts of the mayor, Deputy Mayor Turnage, and the council to ensure that the Department of Healthcare Finance's proposed budget continues the vital investments in health of the district residents and the providers that serve them. Included in the FY25 budget is a Medicaid Managed Care Direct Payment Program. Through this initiative, the district will be able to join at least 39 other states in securing additional resources to invest in the health system, residents, and most importantly, beneficiaries. Through a provider tax, which is voluntarily imposed on hospitals, this comes with no cost to the district taxpayers and is borne completely by the hospitals. In fact, this program would free up to $32 million in local funding within the district budget that can be reinvested in the Medicaid program. When matched with federal funds, this means over $100 million would be available to be invested in Medicaid beneficiaries. This new funding will provide district hospitals with the opportunity to make strategic investments that will improve patient outcomes, expand access to services, and support Medicaid beneficiaries. As part of the district payment program, hospitals will be required to report quality metrics to the district and CMS on several measures, including maternal morbidity, social determinants of health screening, transitions of care, and the flow of information from one level of care to the next. These efforts taken together are aimed at improving maternal morbidity and maternal health, care coordination and treatment, and placing with laser beam focus on quality and equity that meets the patients where they are. The directed program is a once-in-a-lifetime transformative opportunity to advance healthcare in the District of Columbia. Additionally, hospitals will make individual and combined investments totaling nearly $30 million annually in workforce development, maternal health, care transitions, pediatrics, improving patient throughput, along with other initiatives that are focused on the social determinants of health. Let me be clear. While this investment will help meet some of the increased costs incurred as a result of the pandemic, this funding is to move the needle and invest in the medical care and health of Medicaid and Alliance beneficiaries. It is not designated to pay more for the same services that they provide already today. I want to thank you very much for allowing me to testify. The hospital leaders will provide additional perspectives on the department's budget and the directed payment program, and I'm happy to answer any questions you may have.
Thank you. Dr. Argas.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Dr. Gregory Argas, and I am the DC Hospital Association Board Chair for 2024, co-chair of the Association's Equity, Diversity, and Inclusion Collaborative, and president of MedStar Washington Hospital Center. The hospital center is a 912-bed major teaching and research hospital. We are the largest private, not-for-profit hospital in the nation's capital, among the 100 largest hospitals in the nation, and a major referral center for treating the most complex patients. We are the busiest hospital in Washington, D.C. and the surrounding area. Our services help our community's residents get and stay healthy and help to improve patients' quality of life managing chronic illness. I appreciate the opportunity to present testimony at the Department of Healthcare Finance's FY25 oversight hearing. The FY25 budget presents a lot of challenges, but also great opportunity. As Ms. Bowens mentioned, the district's hospitals have been at work over the last 2 years to create a transformative opportunity through a directed payment program in the district. State direct payments provide us an opportunity to invest in the care of the city's Medicaid beneficiaries to receive and to address long-standing challenges that hospitals have faced. At the hospital center, this additional funding will allow us to, first, continue our work on identifying and addressing social determinants of health, such as food insecurity, housing insecurity, transportation insecurity, and interpersonal safety. Second, it will allow us to continue our work on maternal mortality and morbidity by expanding the services provided by our Safe Baby, Safe Moms program. We will improve communication at the time of transitions of care so that safe and seamless care can be provided across the entire healthcare continuum. And finally, continuing to address the overcrowding in our emergency departments, we will continue to expand utilization of our community health advocates to improve patient and family education and optimize utilization of the most appropriate level of care. All of these investments are being made possible with no local funding. The district's hospitals are funding this opportunity through 2 provider taxes, and the program is designed not to have a financial impact to the city. Importantly, it impacts all of the district's private district hospitals and United Medical Center. Additionally, the district hospitals are committed to funding a community impact fund through the Hospital Association, which will provide nearly $15 million to invest in maternal and infant health, workforce development, transitions of care, and again, addressing those social determinants of health. I thank you for allowing me to testify today, and I'm happy to answer any questions that you might have.
Great. Thank you so much to this panel of witnesses. Thank you, Ms. White. It's good to see you again for testifying. Ms. Bowog, I wanted to ask, well, Baylog, my bad. Thank you for being here. I want to ask about some of the wage gap issues, and we'll certainly look at your longer testimony about this because before you had mentioned, I have a longer testimony with, X, Y, or Z. I'm curious if you guys have looked at the pay disparities just within I'm going to call us a tri-state area, DC, Virginia, and Maryland, in terms of is there something that Maryland and Virginia that they're doing that's different than ours from a pay perspective, that they are doing better in terms of the recruitment of this workforce than us? Turn your mic on.
No, unfortunately, no. I mean, there are challenges in addressing these pay gaps in Maryland, Virginia, and the district. And certainly the district is going to testify that in the area, the district's wages
are higher.
But
our cost of living is also.
Our cost of living is also puts us, according to PHI, it puts us at the bottom of the list here. There is really no way for care workers to live in the district on the current 117% of the living wage. It's impossible.
Yeah. I would definitely love to see how other jurisdictions are kind of tackling this. It has been very refreshing to see that the Biden administration has now turned to this particular issue. I'm like, hey guys,
yeah,
glad to see you. Thanks for catching up. And not just around home health aides, but just the care workforce in general. And, I think this, right? We've been trying to tackle this we started with childcare workers. Now we got to fix some things that the mayor's trying to roll back. But in our exchange, and it was interesting, I was referring to the healthcare for childcare program that we have that are specifically for childcare workers. And we've been having conversations around, again, how do we think creatively around how do you provide healthcare access for a group of individuals for whom the business is too small to do it, and they might qualify for some other things. And it was a little disheartening to hear, well, we can't do it for the childcare workers because we're not doing it for the home health aides either. And it's like, oh, okay. So since we can't do it for everybody, nobody gets healthcare. I'm very confused by how we are doing this. But I feel like this is a particular issue that's going to require us to sort of dig deep in terms of our creative thinking. I keep thinking about Mr. Jean-Claude, who testified earlier, and he always gives really poignant testimony as let's say a participant, but a person who is receiving direct care service, that we use desperate people to take care of desperate people, which I feel like it is sad, but it's also a reflective of the reality of how we have sort of set this up. And at the same time, right, I look at the census numbers, we need the care workforce. We need the care workforce. And, I don't want folks to then just turn to it when they need it themselves, or to start advocating for it when they need it themselves. And so I can't make promises on the funding piece for this year, but it is definitely top of mind in terms of a priority issue that I know that we have to solve here in the District of Columbia. And I'm happy for us to be a nation leader in that conversation about how we do that. So I look forward to working with you on that.
Thank you.
Ms. Bowens and Dr. Argas, I feel like I did just see you guys last week. So good to see you. I want to ask a question about the payment that's included in the BSA. A lot of people don't focus on the BSA topics, but they are here. And I'll ask the next panel this as well. But so in my understanding in terms of this voluntary tax payment, is that this needs to make up the dish payments or the former dish payments that the hospitals would have received otherwise. So how much of this additional, I would say, forecasted funding that you guys are going to be receive makes up for dish versus going to other initiatives within the hospital's realm?
Well, I'll have Ms. Jenkins can speak specifically around Howard University Hospital, who is our primary dish hospital recipient.
Okay.
So there will be a significant portion for that hospital in particular that will be bridged. There will also be the resources which we talked about relative to addressing some of the systemic issues. But in addition to that, we are looking to use the funding that I noted to focus in on specific social determinants of health services or throughput issues. So it's the combination of all of those things that the funds would be used for.
Okay. And I try to practice good habits myself on timing, but I'm not here because I want to get this for the record. This is not the first time that DC has tried this.
Correct.
And I want you to speak to sort of the delicate negotiation amongst our hospitals to get to this place.
Yes, as was mentioned, we've been working on this initiative, this particular directed payment initiative for close to 2 years now. The hospitals have had a tax probably in excess of 10 years. It's a smaller tax, and what that tax has done is, again, at the hospital saying that they will tax themselves in order to bridge the gap in payments and on the outpatient side and the inpatient side. So that's a tax that's been in place for in excess of 10 years. This would be an additional tax that would allow the hospitals to basically be paid closer to the commercial rate. It is something, as I noted in my testimony, 39 other states already have been approved. And I would say the last tranche of states are in the process right now. And again, this opportunity allows the hospitals to tax themselves, that then leverages additional dollars, which frees up local dollars for the government. Now, it has taken a while because obviously, while everyone certainly is 100% committed and recognizes that there are some gaps that we need to address, trying to get everyone on the same page with respect to that, rightly so, has taken some time. And it is a very fragile agreement in the sense that we wanted to make sure that first and foremost, it was equitable. Also that the district has what it needs. And so anytime you pull a piece away from that, it could break down the whole system. So we believe that we've come to a model based on utilization that not only is good for making sure that we are in compliance. And that's another matter I want to make sure we've worked from the very beginning to ensure that this model is consistent with what CMS will approve. Because at the end of the day, CMS has to approve it. All the hospitals and the district are all in alignment. And if there are any shifting to the left or to the right, it could potentially not only break down the agreement, but also put us in a place where we're not potentially compliant with what the regulations say.
And how long do you all anticipate a CMS review will take?
It all depends. We're planning it in the sense that everything can be in line with that, but it could range from, a minimum of 90 days to, if we mess with the model, it could be potentially even longer and put it at risk. So a minimum of 90 days is when that we would see it happening. Our goal is to hopefully have it done by October, assuming that everything goes through the council and the mayor. If that happens, and if not, we would hopefully be retroactive to October 1.
Great. I appreciate that. In terms of one of the focus areas is around maternal health. You guys know that is very important to me. And I didn't actually get an opportunity to ask you this at the DC Health hearing, but there is another BSA subtitle that the mayor included with funding at the committee's asking to address something that was raised I think it was actually in this very room, hearing from some of your providers around the emergency childcare needs of women who either are birthing or having some sort of emergency, because we had heard from doctors that you actually have patients who were declining care because they didn't have any place for their child, the already born. Thank you. I was like the kid that's already here.
The other children.
The other children. And so we have an opportunity. There's some money that's included in the budget for us to sort of pilot what this might look like. And I'm curious, have you all had an opportunity to talk to some of the birthing hospitals around what this could look like potentially?
No, but we certainly will take that into consideration because we are extremely proud of the efforts that we are looking at beyond the hospitals, this whole consortium of providers to kind of work to what is our best practices. So certainly my team members from the PQC aren't here. So I'm saying I have not, but they most certainly probably have, and we will continue to elevate that. So appreciate your raising it. So I will follow up to make sure.
Great. Thank you. All right. Thank you so much to this
Thank
panel.
you very much.
Please upload your testimony. We need it. All right. We're almost there, guys. 2 more panels. Well, in person and then the virtual. Aldwin Lindsay from Children's National Hospital, Anita Jenkins from Howard University Hospital, Tony Coleman from Cedar Hill Regional Medical Center, and Amber Recky from Children's Law Center. Mr. Lindsay, when you're ready.
Thank you. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Aldwin Lindsay. I'm the Chief Financial Officer for Children's National Hospital. Children's National has delivered care to the district's pediatric community for over 150 years. We firmly believe that every child deserves the chance to grow up strong in mind and body and are inspired by their hopes for their future and their limitless potential. I appreciate the opportunity to present testimony at the Department of Healthcare Finance's FY25 oversight hearing. The directed payment program included in this budget will allow hospitals to supercharge their efforts to serve Medicaid beneficiaries as well as residents of the District of Columbia. The enhanced reimbursement is especially important to Children's National. As you know, last year's budget included Medicaid rate cap on hospitals' reimbursement that disproportionately impacted Children's National. While the directed payment plan is not the final solution, it effectively mitigates the more than $17 million cut to payments for the care we provide to our children. At Children's National, we recognize that the health and the well-being of our children and families goes beyond the care within the 4 walls of our hospital. This program will allow for further investment in our community. We are dedicated to addressing health inequities and their root causes by focusing on social determinants of health. Through our patient-level screening, referrals to social services, educational programs, and community partnerships. We care for and connect children and families to needed resources with the goal of improving health outcomes. The directed payment program will help us expand our response to the community health needs. This work is specifically focused on the social factors that impact health outcomes. In our last community engaged process, we learned that workforce development and employment, food insecurity, and early childhood education are areas that would benefit from an investment. We also know how important it is to improve health literacy among our patients and staff. Children's is committed to the collective hospital investment of nearly $15 million per year as the health sectors work together to address the needs of our community. Finally, it is significant to note that none of these investments rely on local funding from the district. The hospitals are making this investment through provider taxes. Moreover, these investments allow for DSH hospitals to move away from DSH payments and to be supported through utilization. For HSC Pediatric Center, this means they will no longer be eligible for DISH by design. Thank you for allowing me to testify today, and I'm happy to answer any questions you may have.
Thank you. Ms. Jenkins?
Greetings, Chairperson Henderson and members of the Committee on Health. My name is Anita Jenkins, President and CEO of Howard University Hospital. As you know, Howard has a rich tradition of providing uncompensated care to the residents of the District of Columbia. Approximately 90% of our patients are Medicare and Medicaid, and we have a distinguished 162 years of delivering the finest primary, secondary, and tertiary care services. Howard University Hospital has become one of the most comprehensive healthcare facilities in the Washington, D.C. metropolitan area, and we are a teaching hospital and designated level 1 trauma center. I am pleased to be here today with my colleagues to testify in support of the Department of Health's Finance FY25 budget and to support the Medicaid MCO Directed Payment Program plan and included with it. The Directed Payment Program will allow the district's hospitals to make strategic investments in the vital services provided to their patients and, as a result, improve quality and outcomes to those we serve. For Howard University Hospital, this means allowing the hospital to move away from the Medicaid disproportionate share hospital payments, as was mentioned, the DISH program, which are considered risky as they are targeted for congressional cuts, to a more predictable, stable funding model based on utilization. In short, these funds will stabilize our funding and allow Howard University Hospital to continue to provide much needed specialty care such as women's, infants, and services, breast cancer care, chronic diseases, and cardiac care for the underserved in the city. You asked the question, and we've got you asked, what do these fundings do? It replaces nearly $47 million of DISH dollars without cost to DC into the DPP program. So that's the quick answer. In the area of workforce development, this funding will help us recruit and train the next generation of hospital associates. This year, our hospital will be launching an apprenticeship program to address critical work needs within our workforce, and additional funding will help us expand our work in creating a workforce pipeline and career advancement opportunities for the residents of Washington, D.C. As Ms. Bowens said, this is a transformational opportunity for the district, and I'm excited for the new doors that this will open for our patients and our hospitals and the stabilization it will bring to Howard University Hospital's funding. Thank you for allowing me to testify today, and I'm happy to answer any questions.
Thank you. Mr. Coleman.
Good morning, Chairperson Henderson. I'm Dr. Anthony Bernard Coleman, for the record, and CEO of, is that better? Yeah. CEO of Cedar Hill Regional Medical Center, slated to open early 2025. I'm the newest member of this the DCHA, and I want to speak on the experience that I had in my last hospital. I was the president and CEO of a community hospital in Des Moines, Iowa, also member of the Iowa Hospital Association Board, and we went through this process for directed payment. I was happy to see it through, and also happy to report that the hospital that I left in Iowa received their first payment, and it has literally transformed the way that this community hospital provides care to the poorest community in Polk County in Des Moines, Iowa. So I am a fervent proponent of the DPP because I have seen it work. I have been through the process, and I'm happy to answer any questions that you may have.
Thank you. Amber.
Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to testify today about the fiscal year 25 budget for DHCF. My name is Amber Recky, and I lead the Path Forward project at Children's Law Center. Our clients often have significant behavioral health needs. According to the AAP, behavioral health is the largest unmet need for youth in foster care nationally. Their greatest obstacles to services are A, the lack of behavioral healthcare professionals practicing in public programs, and B, the challenges of navigating between and through services and across agencies. This is why we have been invested in DHCF's recent projects to better integrate behavioral health care with other services, specifically the carve-in of such services to managed care organizations. Research links pediatric integration models to improved behavioral health outcomes in children. With built-in care coordination and value-based purchasing, managed care could help the district move toward the triple aim of better care, better outcomes, and reduced cost. We hoped that the carve-in, though not a panacea, would get DC closer to this vision. As you know, DHCF halted the carve-in 5 weeks before it was to finally begin. We understand revenue constraints, and we know we have testified that providers were woefully underprepared for the administrative transition. However, we are frustrated that the years-long cooperation of providers and advocates who have participated in good faith from the original waiver application through the many delays, who had remade entire processes to participate, that this cooperation has not been honored or repaid with clear answers about the future. For our part, CLC has predicated years of our own work on the premise of the carve-in. It feels like we've all been running a marathon only to have the race called off at mile 25. So we want to take this opportunity to ask DHCF, what will be the fate of our community's work to integrate behavioral health care as part of whole person health? DHCF has not communicated clearly enough about walking away from the carve-in. In fact, its website still heralds April 1st as the effective date. Future meetings of the Public Forum on Integrated Care, where stakeholders received updates and provided input, have been canceled. One of the key areas we hoped the carve-in would improve was network adequacy by sharing this imperative with MCOs. The reality is DC has an insufficient number of perinatal and child-serving behavioral health providers and facilities. If the carve-in is no longer happening, it becomes even more critical for DHCF to more intentionally cultivate and enforce network adequacy. The foundation of an adequate network is to pay adequate rates for services in hospitals, health centers, primary care, and private practices. As of this month, about 63% of billing rates are still lagging more than 17% behind inflation. In conclusion, we hope to see the district continue its ambitious and desperately needed projects to improve the public behavioral health care system. Thank you for the opportunity to testify. I welcome any questions.
Thank you to this panel of witnesses. Amber, I'll start with you. I have questions for Director Turnage about what's the future of the behavioral health carve-in. Also, how our price tag was so far off from what we thought it was going to be. And you know, I still think that there is some value in what we were trying to do. And perhaps we can get an updated timeline in terms of what the plans are, but also what the communication is going to be with both the provider network as well as with advocates who are working on this. So thank you for being here and for your work. Mr. Coleman, the newest kid on the block, but they're already putting you to work. I wanted to ask about, you know, your past experience with DPP in terms of how this funding affected workforce issues or not. You know, I know that you said your former hospital recently received their first payment, but I'm curious if you've heard from them around how it impacted workforce, but also what was the most transformational piece of having that funding?
Absolutely. I can tell you in anticipation of receiving the funding, I gave staff 4 unscheduled raises in a 12-month period.
Oh.
Carried that loss because we felt so strongly about DPP, and I was happy to know that it went through because here in DC, I felt a bit of guilt leaving without that being resolved. So to know that the DPP was approved and that hole was shored up made me feel good. And there was also some raises across the board for management and for physicians. We at my hospital, at that hospital, we employed 98% of our physicians, and they had not received a raise in, I think, 4 years, and they were starting to grumble. So that was one of the first things that the interim administration did once the dollars actually hit their bank account.
Okay, so that is hugely transformational, just being able to retain your workforce. I've been to Des Moines. I think I've flown in, flown out. No, I'm kidding. Please, any Iowa people who are listening, I really don't want the smoke. It was a joke. Miss Jenkins, I gotta ask. So, you know, we get the BSA and I'm reading through and I'm like, okay. And Jackie's like, everybody's on board. And then I was like, is everybody on board? Why is Howard a part of the exempted crew here? St. Elizabeth's made sense. Some of the Bridgepoint made sense. So I want to give you an opportunity for the record to say why, because I also don't want the smoke from the bison coming at us around why is Howard not part of this? So why do you want to be exempt? Why did the university hospital?
Exempt from the tax, we're not exempt from DPP.
From the tax.
So right now, Howard is unique in that its payer mix, of course, is 90% governmental payers. And so that tax would be an additional burden. And so we were the ones that were getting most of that those dish dollars.
Right.
As that goes away, and hopefully things improve there, you know, we would be right there with our peers. But for now, DPP is very, very necessary for Howard University Hospital to be to maintain its to maintain its standard of care.
Okay.
Definitely all of the hospitals were on board, and this is the way that when you have high dish hospitals, this is a bridge that we go through. I know it seems odd, but for one hospital not to be on that tax platform.
Oh no, I mean
much.
Yep. I mean, we had a really good meeting sort of explaining you know, because it's about utilization. It varies, right? I don't think you know, I think so the public doesn't necessarily see all of the utilization that's going into all of the various hospitals. They just see sort of the shiny outside. Should they have to use it, you as a patient, and that's it. So I understand in terms of like, you know, it's an interesting mix and calculation. This subtitle also has a sunset date though. So is the anticipation that we're going to kind of see where we are in a couple of years?
More than likely. We went through a robust RFP process. And so all of DCHA.
Oh, no, you're on. You just got to lean in.
All of DCHA, we have looked at it when he talks about how this process moves through and this nationally recognized process. We look at this and then we look at the future as well. So yes, we anticipate that all hospitals will be on that same motion in the future.
Okay. All right. Mr. Lindsay, good to see you. All right. Any specific questions? It's, you know, we don't have to row with children's like we did last year in terms of the.
And thank you for your help last year.
The budget pieces. But thank you for being here. Ms. Jenkins, this wasn't a question that I had that's on my list, but again, sort of thinking about the BSA subtitles, this is separate and apart. There's another portion of funding for Howard University Hospital around the new hospital construction. So I just want to ask, you know, how's it going?
It's going very, very well. We are so close to making some announcements about the progress. There are plans every week, and we certainly will let you know first when we plan to put a shovel in the ground. Let me say it that way.
Okay. Yeah. I had like maybe 2 weeks ago, I met with the director of DDOT, Department of Transportation. And
absolutely,
I was like, so we have some things going down in Shaw. Let's rethink perhaps bus lanes and some other construction projects, et cetera. And I encouraged DDOT to reach out to the hospital to sort of understand what your timeline is, especially as we talk about the one-way streets that traverse the new construction.
I would love to give you a personal update on the latest information on where and how that hospital construction will be implemented, and it will start very soon.
Okay, great. I would love to follow up on that.
Absolutely.
I don't have any further questions for this group.
Thank you.
Thank you so much. Okay. Ms. McLoud, it is your turn. Mary Proctor, it is your turn. Ms. Dunn and Ms. Schlossberg. Okay. Is there anybody else in person who is like hoping to testify in person? All right. Okay. After this panel, we'll switch to virtual. I'm telegraphing for our agencies who are listening in. I don't entirely know how much the virtual is going to take, but for Department of Healthcare Finance and the Office of the Deputy Mayor for Health and Human Services, Anticipate that we will take a 20-minute break in between the public witnesses and then you all joining us. Whenever that is, but just anticipate that. All right. All right, Ms. McLeod, if you just hit the button in front of you. There you go.
Good morning. My name is Blanche McLeod, and I'm here because I'm so disgusted with healthcare finance. I am a senior, and we are just been so totally disrespected. 4 questions. 1, the Medicaid process was a fiasco. And when I get a letter with a lie, and then you turn around and send me another letter the next month with another lie, and then I get a 3rd letter. So it wasn't done. I got an apology for an inconvenience. I don't need an apology. I'm not an inconvenience. I'm a whole human being. And when my services were cut off, it was detrimental for me. I couldn't go to 2 of my appointments because I had 3 that day. However, I only had money to only go to pain management at the forego my OT and PT, which is my only treatment for pain because I'm allergic to all pain medication. Secondly, someone decided to change my health care, and I went ballistic. But this has been going on with seniors for over 2 years. No one had the right. I made my insurance choice, and I know open season, and I know when it closed December the 7th. Someone decided February 1, I never did my Medicaid, and then you're gonna turn around, cancel my health, change my health insurance without my permission. And it was a whole bunch of mess. My 3rd thing, my dentist stopped taking Medicaid because healthcare finance required her to give her Social Security number. I first contacted the Committee on Health in November 2021. I, as of today, still haven't gotten an answer. And I feel that seniors, they are looking at us as once we get a certain age, we have all this sudden mental incapabilities. That is not true. They get upset, cry. I'm gonna get upset, but I'm not gonna cry. And I physically came down here February the 1st and February the 16th, dragging and all that pain because I had to put a face. I'm not a number. I am not a statistic. I'm a whole human being, and I can read and comprehend the English language very well. I don't need anyone to hold my hand, but they keep treating us like dirt. My last big issue, kidneys. Now, I have 1 kidney. I lost my kidney because I never had a kidney function test. I also called several times. So the last time I called and spoke to someone in your healthcare committee, I was told they can't tell the doctors what to do. What I learned when I lost my kidney, number 1, I didn't know because that's my everyday pain. So I couldn't receive both of my shoulders being reconstructed, both of my rotator cuffs fixed. So I have to be in excruciating pain for the rest of my life because I'm allergic to all pain medication. However, the National Kidney Foundation states on their website that diabetics should have a kidney function test every year, and that Blacks are 3 to 4 times more likely than any other race to get kidney disease. I got my first kidney function test in 2016, and I found out 5 minutes in the urologist, Miss McLeod, if you have 20% function of your left kidney, I won't take it out. That's how I found out. But when I keep calling and screaming that what they're doing, they're lying. When they tell you, you go in that office and they take your blood, that's not a kidney function test. That's a screening. Kidney function test is done in nuclear medicine. And the doctors don't want it. Last year, I had to put all of my religion in the closet, on the shelf, close the door and lock it, and had to literally cuss the nephrologist out because I had 1 kidney and I'm fighting for the life of my 1 kidney. You're going to give me a kidney function test. but we're not doing it. But yet all these dialysis centers are popping up because we are not being diagnosed. And the person in your office that had the nerve that that's to tell me they can tell the doctors, I'm not saying that. But we need to know. Look at the money that you're spending. And I told them, oh, I guess it's more economically feasible to keep open of the dialysis center and getting the tax money.
Okay. Thank you for your testimony. Ms. Proctor?
Good afternoon. Is it afternoon? Not quite. Morning, you're fast. Chairperson Henderson and members of the Committee on Health. My name is Mary Proctor, and I am also a member of the Workforce Subcommittee of the Long-Term Care Coalition, which you will hear about. I'm here to advocate for equitable budgets of the care of the elders and the disabled. At the beginning of the DHCF budget portion of the hearing, two people, James Jean-Claude and Kevin Moats, testified virtually on how their health and lives suffer when home health aides do not come or who come ill-prepared to care for them. Neither is ambulatory, and both need hands-on assistance to take care of their most basic needs. They represent hundreds of hidden voices who cannot come to the Wilson Building to testify in person or wait many hours to testify virtually. I am very grateful for their testimony. Both my husband and I are 82 and creeping towards the age when we will need direct care workers at home or in a nursing home. We want to stay on the hill as we age, ideally in our own house where there are no stairs to the entrance. My husband and other CHV Capitol Hill Village members are alarmed by the following aspects of the current outlook for direct care workers. One, as you've heard, there's been a sharp drop in the number of direct care workers from 2022 to 2023. Almost 4,500, 30% of direct care workers did not renew their certification and evidently left the direct care workforce. Two, AARP ranks DC last among US states in paying wages that compete with easier DC minimum wage jobs, such as working for Walmart. Three, training for jobs earning less than $23.13 an hour cannot receive money from OSSI, the school superintendent, or other federally funded programs that only fund, quote, good jobs. Even the highest paid direct care workers would not be eligible for such training. So what is equitable for DC families? This past week, Council Chair Mendelson decided to use $217 million in funds currently earmarked to replenish a DC reserve fund to restore the mayor's cuts to the 2021 Pay Equity Fund to raise wages for childcare workers. From a family's point of view, there is no difference in needing childcare or elder care. Full equity for elders and direct care workers that are access to training would cost less than $18 million. The decent lives for elders and the disabled and their families are as important as decent lives for parents and their small children, and they are less expensive.
Thank you. Ms. Dunn?
Good morning, Chairperson Henderson and the members of the Committee of Health. My name is Pilsky Dan, and I'm the President of Health Services for Children with Special Needs, also known as HSCSN. We are a Medicaid health plan licensed in DC and part of the HSC healthcare system, a subsidiary of Children's National. Thank you for the opportunity to testify today at the Budget Oversight hearing for the Department of Healthcare Finance. HSCSN partners with DHCF in serving over 5,000 special needs children and young adults with disabilities from birth up to the age 26 in DC through the CASA program. We provide specialized benefits and services for some of the district's most vulnerable children. Continuity of services with HSCSN is key to ensuring that our enrollees and families receive specialized care they need and supports they deserve. With the unwinding of the PHE in late 2023, we became concerned with the number of enrollees set to lose Medicaid eligibility in the district when their determination process resumed. Nearly 500 enrollees were identified as at risk of losing their healthcare coverage. In partnership with DHCF, We were quickly able to implement interim solutions to ensure service continuity and avoid disruption in healthcare coverage, alleviating concerns of caregivers and families. We thank Deputy Mayor Turnage and Director Byrd for their continuing support and partnership in addressing these eligibility concerns that uniquely impact our enrollees and identifying policy solutions. That said, the availability of home care services in the district continues to be the area of concern. What is more, the matter of limited home care agency capacity can present further risks to the FY25 budget pressures linked to healthcare spending. Over 10%, more than 500 HSCSN enrollees require home care services, which include personal care aid services to support ADLs, nursing care, and also services such as PT, OT, and speech therapy. As such, our ability to deliver on pediatric-focused home care is key component in many of the personalized care plans we develop for our enrollees. As we continue to partner with DHCF to develop innovative payment solutions to enhance home health care delivery, such as value-based care, we ask DHCF and the Council's consideration and support towards exploring opportunities with the State Health Planning and Development Agency, SHPTA, to increase pediatric network capacity in the district. Potential opportunities include establishing expedited process to modify existing certificates of need of existing agencies to increase pediatric care hours, as well as expedited review and approval of new entrants. Other areas of opportunities lie with policy and benefit expansion, such as alternative long-term solutions to expand access, such as caregiver payment program, which offers direct payment to caregivers and or family members, such as benefits offered under the EPD waiver. In closing, we're committed to being a valuable asset in the District of Columbia in supporting children and youth with special healthcare needs. Thank you for your leadership on the health of district residents. HSCSN looks forward to continuing the ongoing partnership with the HDF.
Thank you. And Ms. Schlossberg.
Thank you. Good morning, Chair Henderson and members of the Committee on Health. Can you hear me? It's okay? Lower. Okay, there you go. Okay. I am Claudia Schlossberg. I am a 45-year resident of Ward 1 and serve as chair of the DC Coalition on Long-Term Care's Committee on Workforce Development. For the past 4 years, our #1 priority has been to raise awareness of the growing shortage of direct care workers. The number of direct care workers, as you have heard multiple times, have been leaving their jobs in astounding numbers. Last year, as my colleague and additional member of the coalition has just testified, the workforce of direct care workers shrunk by 4,489 workers, a loss of 30% just from the prior year. The primary reason why workers leave is low pay and burnout. Not only does this leave seniors and people with disabilities without quality care, it places additional burdens on family members and threatens the viability of critical long-term care services. It will also undermine DHCF's admirable efforts to develop new value-based payment models for home health and other long-term care services. Last year, DHCF used ARPA funding to raise average wages to 110% of the living wage, and effective January 1 of this year, wages were raised to 117.6% of the living wage in conformity with the Direct Support Professional Payment Act. However, as the Board of Nursing numbers show, these wage increases have not been enough to stem the tide of workers who are leaving the district's direct care workforce. The pipeline of new workers is also shrinking. We can only replace a fraction of the workers who are leaving. The gap between the number of workers needed to meet current demand and future need continues to grow with no discernible strategy to address it effectively. Given these facts, it is concerning that DHCF's proposed FY 2025 budget includes no increase in the wages for these workers and no new initiatives to address the workforce shortage. Further, except for the living wage inflation adjustment factor, wages for direct care workers based on the BSA titles will remain stagnant for the foreseeable future. As you know, Chairperson Henderson, CNAs and HHAs in DC must pay training costs that reach nearly $2,000, complete 125 hours of training, pass an exam, take continuing education credits, recertify every 2 years. Yet even after DHCF increased support through ARPA funding, and direct care workers make on average about $4 an hour less than comparably trained and certified child development associates, based on the standards established by the council under the Pay Equity Act. We fully support the goals of the Pay Equity Act and wholeheartedly support you and other council members for committing to restoring its full funding. But as Mayor Bowser noted when she testified before the Committee of the Whole, the district has not made similar investments in the direct care workers who care for older adults, as well as Ms. Dunn has pointed out, children with serious disabilities. Both AARP and PHI have noted that wages for DC direct care workers are not competitive with other comparable jobs in this labor market. Our ask is simple. We know this is a very challenging budget year, but it's critical we find a way to raise the wages of these workers who care for a growing population of older adults and people with disabilities of all ages. While it may not be feasible to fully fund this increase in 1 year, we must move in this direction, or more and more seniors and people with disabilities will go without care. Thank you.
Thank you. Excuse me. Thank you. And thank you so much to this panel of witnesses. Ms. McLeod, I'll start with you. You raised 4 distinct areas and issues. So I'll start with the dentist issue. You heard testimony earlier from the physician who was here about the challenges that he's faced in terms of keeping up all of his offices and also finding workforce issues. And we heard from healthcare finance that they are relooking at the fee schedule for dentists. So hopefully that will.
The problem is they want her social security number. And she said no, because she has a taxpayer ID number and she has her medical license. However, she doesn't take Medicaid anymore because of the issue. You know, it's, you know, she's still in business, but she approached me because she knows I'm very vocal, I speak out. And for this whole issue to be ignored for almost 3 years. But she, not only, she's a female, but she's a Black female dentist who's been on Benning Road over 30 years. And so she doesn't take Medicaid.
We can ask Department of Healthcare Finance about that. That's interesting in that, I mean, we don't require your social security number in order to get a medical license. So why would we require it in order to be?
And that's why
Now, it could be a federal requirement, which is the other end of Pennsylvania Avenue, not us, but we can ask.
In almost 3 years, could someone at least let me know or let her know?
Well, so I think you said 2021.
Yeah.
Okay, I wasn't the chair of the health
I know,
committee then.
I know.
And so whatever email you sent then.
No.
Lost in the ether, but we'll follow up with you on that particular issue. And then you raised some other issues. In terms of the PCA services, you said that was resolved with healthcare finance.
Well, that was resolved. It became an issue because even though they had my recertification package, they never processed it. So on February the 1st, when I was working with the ombudsman's office, and they knew I had 3 appointments. I have a lot of appointments that I go weekly because I can't take medication. 8:15, I called and said, oh, we have to come up with a plan. I hung up the phone and called Uber. So they are reimbursing me for all the money that I had to spend. But the issue is when someone decided, and it was really laziness because they knew January 2023, that January 31, 2024 was coming. And my understanding from my case manager was that they had continually given themselves extensions, but not for January. And so that affected my transportation. And then I got a call that my evening aide couldn't come back. And in the same tone, my weekend aide wouldn't come in because I didn't have Medicaid. My transportation, that even after they did it on the 5th of February, they still didn't update it in the system. So it actually took between the Medicaid and my health insurance plan, because they didn't do what they were supposed to do then. March the 8th is when everything finally got resolved, and that's unconscionable.
You are right about that. And it also demonstrates too that at least what we have been hearing about the Medicaid redetermination process isn't actually happening in full. What we have been told is that once someone submits their paperwork, that it essentially puts a stay in the system so that your insurance continues even while they process. And you are not the first person who has come to us to say, no, my stuff has been cut off. And you had to know who, well, you had the knowledge to know who to call to sort of get it resolved. But for some people, they might give up in that process and not completely fill it. So we'll ask some questions on that as well. And then the last piece that you raised around the kidney function test and otherwise, I recently read an article that was talking about something that you sort of alluded to around kidneys and Black Americans and just sort of in general, the number of dialysis centers that we have around. And so there's a lot of more work that we need to do there that I want to kind of uncover.
The issue.
I know the kidney function test being required. Yeah.
That will give you an accurate account, and they keep lying when they say that it's too late. Last year, my kidney function test said 98%. And what I keep screaming, I am fighting for the life of my right kidney, because it also comes along. The reason I have to stay, my shoulders are broken. My bones stick up. I have calcium deposit. Pain management said they've never seen shoulders like this. However, I can't take pain medicine. But had I had a kidney function test, they would have caught the kidney stone. I didn't know I had a kidney stone because that's my everyday pain.
Got it. All right. Well, we'll ask some follow-up questions there. Ms. Proctor and Ms. Schlossberg, thank you again for your continued advocacy, not just on behalf of seniors, but also Ms. Dunn, you know, you being here too to talk about what people don't realize is that there are a number of children and other persons with disabilities in the city who also are in need of personal care services and home care services as well. Ms. Dunn, this is not budget related, but I'm going to ask you because I keep hearing about HSCSN from clients who are also constituents, et cetera. Do you guys have a patient portal online?
We don't have currently a patient portal. We're working on implementing a patient portal that will be live by the end of, fingers crossed, by the end of the summer.
Okay. All right. End of the summer. That's been the biggest.
Yes.
People want their documents and all the stuff, and they always have to call or be on hold and those kinds of things. And I just was like, well, I feel like most of our insurance companies and all of our MCOs at this point have an online patient portal. So glad that you guys are working on that. Okay. All right. I don't have any further questions for this panel. Thank you so much for your time. Please submit your testimony for the record. We are going to go to our virtual. I'll do panels of 7. See where we go. Susan Sedgwick, Fernanda Ruiz, Travis Bailey, Ian Perigal, Mark Lavoda, Makita Vanderpew, and Christy Respres. Again, you have to affirmatively accept our invitation to become a panelist. Give it just a minute. All right. I don't see Susan or Fernanda or Travis, but I do see Ian. Ian?
Great. Can you hear me? Is everything working?
Yes, go ahead.
Okay. Chairperson Henderson, I'm Ian Perigal, and I serve as the Executive Director of the DC Coalition of Disability Service Providers. At the outset, the coalition is pleased that there were no planned cuts to the DHCF portion of the funding for the IDD community. However, there were cuts to the HCBS waiver portion of the IDD section through the human care agreement, specifically a 50% reduction in the administrative funding amount of $1.4 million, which directly impact IDD providers. While we recognize that this is not a DHCF cut, it is a reduction in funding from a governmental unit and will have an impact on IDD services. Just so you're aware, on March 4th, this past year, the disability provider community received a communication with less than 1 month's notice that DDS would reduce payments for administrative and residential costs by 50%. This notice served as a unilateral alteration of the IDD provider human care agreement. And providers were were advised that failure to sign and approve this reduction would result in DDS seeking new placement determinations for persons presently receiving services. Needless to say, this forced FY25 administrative fee reduction with less than 1 month's notice prior to implementation is having an adverse impact on providers. Now that the providers are faced with this continuation of this 2025 fiscal year, this same continuation in the mayor's budget. According to DDS, this reduction amounts to the nominal $1.4 million in savings, but the harm it's having on the provider world is substantial. I know you know about the unrelenting turnover and vacancy rates in the industry because, we just don't have the money. But the IDD providers were using this administrative fee funding that is being eliminated to offset the growing costs of our staff. And it only pushes our human service providers further behind. What we're asking for here is your committee, the Committee on Health Support, in the event that the Facilities and Family Services Committee recommends this 1.4 be reinstated in the budget. And I know over the last few hours, you've heard testimony from other panelists about other elements discussed within the bulk of my written testimony. However, just to summarize, they touch on the continually mounting staff turnover and vacancy rates, that service providers, they need some accommodation for additional funding to account for the overtime, wage compression issues, which are causing mid-level staff and supervisors to vacate their supervisory positions because they can earn more with overtime as a direct care worker, the need to fund IDD providers so they can pay their nurses at least a competitive market rate, and what we've talked about just recently, the need to support the modified goals of the Direct Care Worker Act and at least have the average funded wage for a DSP reach the base of the child care worker industry for FY25. And lastly, DHCF and DDS are conducting a rate study of the expenses within the IDD service community. And we're hopeful that those recommendations that are made by the contractors that are conducting the studies will be thoughtfully considered by DHCF and the mayor for the FY26 budget, and proper funding allocations for services will be forthcoming. Thank you, and I welcome any questions.
Thank you. Mark?
Thank you, Chairperson Henderson and members of the council. Thank you for the opportunity to testify today. My name is Mark Laboda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illness, substance use disorders, or both, including the 32,000 district residents our 33-member organizations serve annually. Financing behavioral health services for district Medicaid beneficiaries is one of the many important responsibilities held by the Department of Healthcare Finance. My testimony will highlight efforts to update the payment methodology for assertive community treatment, provide context regarding updates to multiple other service definitions and payment rates, and continue to urge the establishment of a more permanent rate-setting process for community behavioral health services. I express gratitude to Medicaid Director Melissa Bird, as well as DBH's Director Dr. Gazran, for working with the provider network to address several of the concerns shared during performance oversight about implementation of the new assertive community treatment monthly billing process. I'm grateful to DHCF and to DBH for their efforts to extend the on-ramp period as ACT provider organizations build capacity to meet new requirements, and I appreciate adjustments to some of the requirements in response to meaningful operational and workforce constraints. I express gratitude to DHCF Senior Deputy Director Angelique Martin and her team for the effort that they've undertaken to implement recommendations from DHCF's Community Behavioral Health Rate Study, undertaken in conjunction with the service definition review by DBH and DHCF. As Ms. Martin shared in February, over 20 behavioral health service lines have been reviewed and are in the process of having payment rates updated. Payment rates for many services with previously established rates have seen increases of 20 or 30%, and in some cases, literally hundreds of percent higher than previous rates, reflecting long overdue adjustments that catch up payment rates to at least a 2020 cost basis. It's important for the council to understand that these 20+ adjustments do not include any adjustment for community support services, which account for 63% of all the services delivered by DBH provider organizations. Despite DBH and DHCF desire to make changes to community services, asking the provider network to continue to bear the inflated cost of these services until such adjustments are made places an undue burden on the DBH provider network. Let me also note that the rate study did not appear to include rate setting for youth substance use residential treatment. This is a disappointing omission, and I hope DHCF will provide a separate update soon to offer a path for Medicaid billing for these services. The DHCF rate study third-party consultants finding that DBH provider network services were underpaid at approximately the rate of overall medical inflation or higher confirms the need for establishment of a more permanent rate setting process for community behavioral health services. Nothing that's been shared about the rate study findings indicates that a requested framework for these updates was completed. Policy updates undertaken to implement the rate study recommendations do not include regular inflationary adjustments. This committee should consider what adjustments to the DBH or DHCF budgets are needed to begin to incorporate annual inflationary adjustments for the DBH provider network in routine rate setting beginning in FY25. Thank you again for the opportunity to testify today. I look forward to answering any questions you might have.
Thank you. Makita? Oh, you're on mute.
Thank you. Good afternoon, Chairperson Henderson, members of the Committee on Health. Thank you for your time and attention today. My name is Makita Vanderpoy, and I am the Executive Director of Leading Age DC. We represent mission-driven organizations serving older adults, such as assisted living, nursing homes, affordable housing, senior villages, home and community-based services, and life plan communities. And I'm also a Ward 5 resident and an active member of the District of Columbia Coalition on Long-Term Care's Workforce Development Committee. I'm testifying in support of funding in the proposed fiscal year 25 budget to address the direct care workforce crisis. We applaud the commitment of the Department of Healthcare Finance to make targeted investments in provider rates in the proposed budget, especially for our mission-driven nursing home providers who are facing surging costs and increasing demands. And I also commend Chairperson Henderson and the 7 co-sponsors of the groundbreaking Direct Care Workforce Amendment Act addressing the direct care workforce crisis. And thank you for your leadership. When enacted, which we urge Council to do as soon as possible, this act has the potential to enrich the lives not only of direct care workers, but also of our elders and the community at large. While we recognize that finding or creating revenue to fund much needed pay increases for our direct care workforce and workforce training is challenging, this is an investment in the health of our residents that we cannot afford to overlook. The decision by Chairperson Mendelson to redirect $217 million from the Reserve Fund to restore cuts to the Pay Equity Fund highlights the importance of equitable wages for child development workers who care for our youngest residents. In an equitable district, this prioritization naturally applies to the workers caring for our eldest residents and their families. The estimated cost for an increase in wages for the 7,723 direct care workers who are registered to work in DC is approximately $17.58 million. And I've got a table in my written testimony that I'll submit that says more. Direct care workers deserve a living wage that supports their families without needing to rely on overtime and public benefits to make ends meet. Older adults need access to timely, quality care to support good health and manage health challenges before they become more costly. Our mission-driven providers ought to be able to serve those in the community who need care while keeping their employees paid well and their facilities safe and open. And young people and those looking for a career change should see professional caregiving as a fulfilling career with potential for wage growth and professional advancement. Our elders have so much to contribute to our communities, and Leading Age DC members are committed to providing quality care services and supports that empower aging residents to live with meaning, purpose, and dignity. And to do so, they need your continued support, as well as a coordinated all-of-government approach to finding long-term solutions for this workforce crisis, as well as reimbursement at a level that allows them to cover costs and pay a fair living wage to direct care workers. Leading HDC is really ready and willing to support the committee and partners in realizing this future where all district residents can age well and thrive. And I welcome any questions.
Thank you. Is Christy Resperson? Okay, don't see Christy. Okay, well, thank you so much to this panel of witnesses. The joy, but also hard part of going sort of at the end of the hearing is that a lot of the things that you guys have already raised, other earlier witnesses have also raised it as well. Mark, I did want to ask you though, I think you mentioned in your testimony about incorporating, annual increases into the rates. And I'm curious, when you have raised this with Healthcare Finance and Department of Behavioral Health before, what has been their sort of feedback that they've given?
Well, verbally, they often indicate that they're willing to do something like that. And then unfortunately, we don't actually see it when policy updates are made. And so really, I think this is just about figuring out how to get them to meet their own verbal commitments that that's something that they think should happen.
Okay. All right. And in terms of the behavioral health carbon, like we heard testimony earlier, have you heard any thing in terms of next steps from DHCF?
I think the only thing that we know is that DHCF thought that it would cost something like $13.7 million in additional administrative fees to implement those changes in FY25. And there's no money in the FY25 proposed budget to fund that $13.7 million. So at least for FY25, DHCF doesn't appear to plan to make that happen. When I had a discussion with Deputy Mayor Turnage about this at a recent provider association gathering, he said that, of course, the budget is subject to revision as the district updates its revenue forecasts, and clearly they will look for when rates of growth for district revenue overall exceed the 2% that's expected, and they continue to look forward to an opportunity to fund the transition.
Thank you. I don't have any further questions for this panel. If you could please make sure you have your written testimony uploaded on our website for the record. Like, don't close your computer, just go do it now. dccouncil.gov/hearings, click on the hearing, click upload. That'd be great. Thank you. All right, we'll go on to our next panel. Marie Morales Black, Patricia Ohunge, Felix Hernandez, Adrian Thompson, Cheryl Dondero, Dr. Takesha Presson, Dr. Edward Brown, and Dr. Cheryl Baptiste. Oh, and it will add Kirk Gallagher to that as well. Let's see what we get. Again, you have to affirmatively accept our invitation to become a panelist. All right, let's see where we are. Marie? Are you on? Okay, don't see Marie. Patricia? Patricia on? Okay. Okay. We see some folks who have their hand raised in the waiting room. Again, you have to change your Zoom name, otherwise we're not going to promote you. Felix Hernandez. All right.
Hi,
Adrian.
yes. Apologies. Can you
Yes.
hear me?
Yes, I can hear you. Go ahead.
All right, thank you. Good afternoon, members of the committee. My name is Felix Hernandez, and I am here on behalf of Home Visiting Programs to urge this council and committee to fund the Medicaid reimbursement bill at the adjusted FIS rate so that NFP and other similar programs can begin to draw down Medicaid funds to support the implementation of programs. Static, constrained investments into home visiting that do not adjust with inflation are effectively pay cuts to staff and weakens the potential of these programs. Relying on the mayor's good graces to allocate the necessary investments into home visiting is not sustainable for programs who support parents over years at a time, depending on need. Home visiting should rely on braided funding streams, as other states have exemplified, so that programs like NFP can keep their commitments and promises, and other programs can receive the funding that will allow them to implement the program to their maximum potential. Funding the Medicaid reimbursement bill for implementation in fiscal year 25 is necessary to make sure participants can continue to thrive in a city where investments in policing have been the priority over prevention. As of 2022, 28 other states have already implemented Medicaid reimbursements for home visiting. Delaying the funding of this bill at the correct FIS adjusted rates means that the commitments our program makes with participants will be severed. Home visiting is a unique strategy that has wide-reaching impacts to health and achievement outcomes, and many are tailored to the varied context of the population. NFP is one such program that targets first-time mothers and provides key support and resources to make health outcomes better in a city whose 90% of pregnancy-related deaths are of Black folks, and as of 2022, have been comprised only about 50% of all births. Many here today will speak on the social determinants of health. NFP is the kind of program that should receive immediate resound support with Medicaid reimbursement funding, as it is a potential antidote to the material challenges families navigate throughout their pregnancy. I'll share quick excerpts from a participant testimony who could not be here today. For me to have this support in this moment is so important to my life. It's been very valuable, as I am a first-time mother and I did not have any experience, had tons of questions and very few answers. However, thanks to this program and Home Visitor, I began learning step by step how to care for myself and my child during and after my pregnancy. Having a home visitor in this stage of my life has been impactful because the program is uplifted by capable, experienced, trained people equipped to support pregnant folks like myself. I can confidently rely on my home visitor and ask any questions that arise because I trust in their expertise. In the future, I'd like to always rely on this program. I would appreciate DC Council in providing support to home visiting programs and especially home visitors so that families like mine can receive this vital support. That makes the total of my testimony, and I welcome any questions. Thank you.
Thank you, Felix. Adrian Thompson. All right, no, Adrian, okay. Cheryl Dondero.
Hi, good morning. Good afternoon, actually. Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Cheryl Dondero, Director of Government Affairs for Gadenzia, the Regional Addiction Prevention, Inc., better known as RAP. Thank you for holding today's FY 2025 Budget Oversight hearing on the Office of Deputy Mayor for Health and Human Services and the Department of Healthcare Finance. While I am new to DC, my first time testifying here, I am not new to this world. I've previously been the single state authority in Pennsylvania, the counterpart of Dr. Bazran, also at the county level in Pennsylvania, and was also on the board of our behavioral managed health care payer. So I'm not new to the area, but I'm very new to DC. I'd like to begin my testimony by offering a sincere message of gratitude to the Office of Deputy Mayor and DHCF in recognition of their exceptional team of professionals led by Deputy Mayor Wade Turnage. I'm pleased to be testifying on behalf of RAP, which for more than 50 years has been an indispensable provider of substance use disorder treatment services to the district's most vulnerable residents. Indeed, today, RAP is the only entity that provides the full continuum of SUD treatment services in the District of Columbia. Now's the time to think creatively about the use of our existing resources while planning for better days. To that end, RAP is open to additional areas of collaboration and innovation with the government as we collectively confront the opioid crisis gripping the district. At RAP, we believe that a critical part of addressing the opioid crisis and the accompanying deaths is providing safe and effective substance use disorder treatment, including residential treatment. Increasing costs for supplies, difficulty in recruiting and retaining high-quality personnel, and residual fears associated with seeking residential SUD treatment have imposed serious challenges on the operating budget of the district's residential SUD providers. In the past few years, as you know, 2 of the district's 7 residential providers ceased operations and closed. Safe Haven Outreach Ministries and Salvation Army's Harbor Lights. More would have closed without the incredible efforts of DBH's director, Dr. Barbara Bazron, and its chief operating officer, Mr. Michael Neff, in securing additional funding for the remaining providers. During FY23, RAP served over 860 individuals. Our clients are predominantly Black or African American, 86%, 74% males, and 61% are over the age of 45 years. Additionally, 62% of the clients we served were experiencing polysubstance use, using 2 or more illicit substances. More than 1 in 2 clients are experiencing homelessness, and at least 1 in 10 is HIV positive. This data does not begin to capture the percentage of clients with a diagnosed co-occurring mental health disorder. Indeed, RAP serves the very population most at risk from opioid-related fatal overdose. Going forward, we would very much like to work with the mayor and council on a few select initiatives we believe will strengthen the district's residential SUD providers. These include addressing the challenges of recruiting and retaining SUD providers in safety net settings, focused coordination between the sobering center and residential treatment options, consideration of regulatory flexibility related to establishing new services, and a review of existing SUD residential rates to ensure their adequacy. Finally, if additional financial resources become available in FY25, we respectfully request that the council consider a Budget Support Act language to target improvements in safety net residential SUD services. Chairperson Henderson, thank you for the opportunity to testify. I'm happy to take questions, but I will more likely be getting back to you with answers.
Thank you. Thank you. Dr. Preston.
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Dr. Takesha Preston. I'm a native Washingtonian, deeply invested in the dental health of our community. As the owner of Dimples Dental Suite, a proud certified small business in Ward 6, for over a decade, I've dedicated myself to providing top quality dental care, prioritizing individual attention by avoiding double or triple booking patients without prejudices of insurance. Today, I come to you not just as a dental practitioner, but as someone who has witnessed firsthand the evolution of Medicaid management since becoming a credentialed provider in 2009. The highs and lows of this system have not gone unnoticed, particularly in how they impact access to dental care. I stand in solidarity with constituents, my colleagues, and local dental societies to shed light on the growing dental health care crises access. According to DC Healthcare Finance, approximately 50% of DC residents rely on Medicaid, reflecting the program's goal to provide quality care on an economical scale. However, this is commendable. It is hindered by the shortage of dental providers and specialists combined with very low reimbursement rates. Moreover, the current system allows Medicaid managed care organizations to pay well below the established Medicaid dental fee schedule, which can be up to 70% lower than the usual and customary fees for the district, according to the American Dental Association survey of fees. This further exacerbates the financial strain on dental practices like mine, making it increasingly challenging to sustain quality care for Medicaid enrollees. During the pandemic, I made the difficult decision to continue servicing Medicaid enrollees at Dimples Dental Suite, despite the financial strain it placed on my practice. The combination of low reimbursement rates, increased operating costs, and a lack of access to local grants due to our professional service status and location outside of a federally designated low-income service areas, my business fell deep into financial hole. As a result, I had to suspend services to new and inactive patients, becoming one less provider available to a growing community in need to ensure Dimples Dental Suite has continuity. The repercussions of this crisis extend beyond my practice financial struggles and mission. The lack of access to dental providers and specialists has had a profound impact on the Medicaid population of the District of Columbia. Many individuals face barriers to receiving timely and comprehensive dental care, leading to exacerbated oral health issues and decreased quality of life. While I understand the budget constraints facing Medicaid for this fiscal year, it's crucial to recognize that without prompt action, we risk further loss of dental providers and specialists, closure of businesses, decreased employment opportunities, corporate tax contributions, and more. Failure to address the underlying issues now could exacerbate. Again, it's imperative that we prioritize sustainable solutions to ensure continuity and continuation of dental care for Medicaid enrollees in our community. I urge the council to consider the challenges faced by the providers and myself, and I will present my formal testimony in writing for your review. I thank you for listening to me and the opportunity to speak.
Thank you so much. Dr. Brown. Dr. Brown, I see your box.
Can you hear me?
There we go. We can hear you.
All right, good. So my name is Dr. Edward K. Brown Jr. I am the co-owner of the Terrell A. Waters Community Dental Center located in Southeast Washington, D.C., Ward 8. As a specialist in prosthetics or prosthodontics, we specialize. I think Dr. Baptiste had spoken earlier.
Dr. Brown, your bandwidth is a little bit low. Maybe if you turn off your camera, we could just hear you.
Let me try that. Let me try that. Okay, turn off my camera. Can you hear me now?
Yes, we can hear you.
Okay, good. So, like some of my colleagues that spoke earlier and denoted that the Medicaid reimbursement fees are poor. Even though they may be some of the highest in the country, they are poor. And as a specialist, it is very difficult to participate in this program with the fees being as low as they are. As healthcare providers, we are charged with the mission to do no harm. That is our first mission. And in doing so, we should do no harm to ourselves. And a lot of times, my colleagues have been doing harm to ourselves at the expense of quality care. So
Dr. Brown? Okay.
can you hear me?
Okay, now we can hear you.
Now you can hear me. I don't know the last part that you did hear, but the fact of the matter is my colleagues have all very succinctly demonstrated the challenges as low as they are. It gives me great joy to be able to treat this population, to be able to provide the highest quality of care, to make sure that poor people do not get poor healthcare. And for the most part, that's what I wanted to convey to this meeting and convey to this testimony to the group, and just to make sure that everyone knows that there are a lot of us out there that
Thank you so much, Dr. Brown. You're going in and out, but we look forward to reviewing your written testimony.
Okay.
All right. Dr. Baptiste?
Good morning, or sorry, good afternoon, Honorable Chair Henderson, members of the DC City Council, Deputy Turnage, community and staff. I'm Dr. Cheryl Batiste, a lifelong resident also of Washington, DC, and a dedicated advocate for equitable health care access. I live in Ward 5, I work in Wards 3 and 7. Today, I come before you to address a critical issue facing our community, the need to increase the DC Medicaid dental fee schedule, which has not increased since 2007. Our costs have escalated, and our salaries for our employees have skyrocketed, especially since the pandemic. As a dentist with deep roots in our community and this city, I have witnessed firsthand over my 40 years in dental practice, the vital role that dental health care plays in our residents' overall health and well-being. In the late 1970s, my late father, Dr. Roy L. Baptiste, established the dental benefits for the DC employees and their families. We currently have very high utilization of DC Medicaid, both children and adult patients. With 80% of my patient population covered by DC Medicaid, I have dedicated my career to serving our most vulnerable communities. However, Despite our best efforts, escalating costs and inadequate reimbursements have pushed my practice to the brink of closure, which it will be done by the end of this summer. I will no longer be in business because of the reimbursement rates. In addition to increasing the Medicaid fee schedule, I also urge you to consider providing special consideration for grants, as was mentioned, for providers whose DC Medicaid patient population exceeds 30%. These providers should shoulder a disproportionate burden of care for most of our most vulnerable residents and deserve support to continue their vital work daily. As we hear from patients daily who call us that their providers of dental care have dropped their Medicaid plans. Furthermore, I ask for consideration regarding property tax relief for dental practices serving the DC Medicaid population over a certain percentage. These practices often operate on tight margins and face significant financial pressures. Providing relief on property taxes for those who own our building businesses would help to alleviate some of the financial strain that we face. Additionally, I urge the council to provide financial assistance for electronic records upgrades, including new servers for Medicaid providers. We had coverage and good help back in 2012. But since then, because of changes with the service, we have to remain in compliance and had to buy new servers. So these electronic health records mandates are essential for patient care and confidentiality. Yet these costs associated with these upgrades can be prohibitive for most of the practices, especially those serving DC Medicaid patients. Dentists need to be on the panels that determine our future. Procedures, costs, and what incurred in them needs to be explained by those who are ones who practice, not by those who don't know and who control our income. Our malpractice insurance premiums are higher because we accept dental Medicaid. DC Medicaid. We are told that we have to schedule our DC Medicaid patients within 2 weeks of them calling for appointments. We have patients who need dental clearance for organ transplants, joint replacements, cancer treatment, and other surgical procedures. With dental providers and specialists dropping DC Medicaid, that has brought an undue strain on our practices. As was stated accurately before by one of the members of the public, we do have to file using our personal Social Security numbers instead of our long existing tax ID numbers. I am a leader in organized dentistry, and I receive a lot of complaints and input from those who are echoing these challenges. I'm currently the president of the District of Columbia Dental Society, which is our local American Dental Association Society. I am the immediate past president of the Robert T. Freeman Dental Society, which is the local National Dental Association Society, and I am the president-elect of the National Dental Association. We must ensure that all residents have access to the quality dental care that they need and deserve. Increasing the DC Medicaid fee schedule is critical. Thank you.
Thank you, Dr. Batiste. Kurt?
Good afternoon, Chairperson Henderson and members of the committee. I'm Kurt Gallagher, Executive Director of the DC Dental Society. I'll make my comments brief. You've already heard some really impassioned comments and testimony by dentists who are practicing in DC and who are struggling with the challenges that they've all highlighted. As I testified back in February during the oversight hearing on DHCF, there is a crisis in Medicaid funding for covered fees for covered dental procedures. The fees, as had been mentioned, haven't increased in mass since 2007 when the adult benefit was established. And imagine that if you went for 17 years without a pay increase. It's just untenable for the practices that are caring for our Medicaid patients. I recently had a discussion with some of the leadership at DHCF, and I really welcome the dialogue, the outreach from them. We're preparing to provide information that actually addresses, I think, one of the comments you raised earlier in the hearing, Chairperson Henderson, about the analysis that DHCF is engaging related to the codes for billing rates for Medicaid procedures that are covered for dental procedures. And we are working to actually provide input in response to that request. But I do want to highlight that there is a caveat to the work that DHS has initiated in this respect. They asked us to highlight a number of priority procedures. And really, that's not practical given the way that the Medicaid fee schedule is structured. And instead, I encourage the agency to consider categories of care. For example, fillings. For fillings alone, there are at least 16 different Medicaid codes, depending on the type of tooth that's treated, whether it's a canine or a molar or an incisor, whether the front or the side of the tooth is treated, and whether you're treating just the top or the side or 3 sides of the tooth. So these rates can become very complicated, and increasing and improving the situation does require swift action to increase the fees that are paid now, but also longer term. The reality is that DC is one of the most expensive markets in the country to operate, as Dr. Preston and others have testified. The ADA has surveyed dentists and their practices and the costs that they incur to operate. DC is in the 95th percentile in our region. So that means practices need to charge 95%, the 95% highest price in order just to break even. For some of the codes that Medicaid reimburses, the rates that dentists receive are 43% or lower than what they would get if they were charging a fee-for-service schedule. In other words, if someone came in off the street, they weren't covered by Medicaid, they weren't covered by insurance, and they just paid out of pocket. So that's a huge disparity between what Medicaid dental providers are receiving from Medicaid versus what they could receive if they decided not to accept Medicaid patients. That discussion with DHCF leadership started by outreach about how we can help them increase provider enrollment. Well, unless these fees are increased, that's just not going to happen. Think about it. If someone came to you and said, here's a great deal, why don't you enroll in this program and we're going to pay you 4 cents of every 10 cents you'd get if you were collecting money directly from the patient, how many would take that offer? Not very many. And unfortunately, too many providers are looking to get out of the program. And sadly, as we've heard today, some providers are actually getting out of business. So thank you for hearing our comments, and I'd be happy to answer any questions that you may have.
Thank you. Thank you to this panel of witnesses for your testimony and for being here. We heard from a dentist colleague of yours earlier today, and sort of, at least for the last bit of this testimony, is sort of hearing some of this very similar themes. As I mentioned before, I think some of this it stems from our decision to sort of treat oral health and eye health separate from all the rest of the health of the body. But similarly, I'm not surprised, in the same times I have had questions with, say, the Board of Psychology, for instance, of like, how do I get more of your providers to participate in the Medicaid program? They point to the Medicaid fee schedule. So I'm not surprised to hear from you all pointing in the same direction. It is good to hear, though, that Healthcare Finance is working on this process with you all. And I'll ask some follow-up questions to them as well about their piece of things. Mr. Hernandez, thank you so much for raising the home visiting program. Like I said, we've heard some earlier testimony about that. So we'll ask some questions in terms of that. Interestingly enough, separate and apart, right? So the home visiting programs that we're talking about now are from like the birth to 5 range. But a couple of weeks ago in a conversation with DCPS, they do home visiting for their school age for elementary school students. And what they have found is that home visiting programs actually helps in terms of attendance. So there's some continuity there in terms of us trying to continue those programs. But I don't have any further questions for this particular panel. Thank you so much for being here. If you could please provide your testimony for the record, and we'll follow up on that. All right, with that, we're going to go to our last panel of virtual witnesses. And again, just sort of forecasting for folks after we finish with this panel, we'll take a 20-minute break, and then we'll hear from the government witnesses at that point. Rajan Thomas, DC Home Health Association, Veronica Sharp, the District of Columbia Health Care Association, Abby Goldstein for the Nurse Family Partnership Nursing Supervisor at Mary Center, Jody Avaca from Access Youth, and Vanessa Lopez. All right, I see Rajan. Mr. Thomas, when you're ready. If you just unmute yourself, Mr. Thomas.
There we go.
There you go.
Okay, thank you and good afternoon. I'm pleased to be able to testify again before this committee and before Chairperson Henderson. My name again is Rajan Thomas. I'm the president of the DC Home Health Association, and I'm also the CFO of HMI Home Health Agency. HMI Home Health has been serving district residents for 35 years now, since we got our license to do so. And we are very pleased that we are part of this very important service. Testimony has been given with statistics and analysis in this and other council hearings about the mounting staffing challenges that home health agencies are now facing in order to provide the level of care needed for our aging population. The reimbursement rate for home care agencies for service provided for DC Medicaid funded services is tied directly to the hours of service performed, and therefore it's very critical that these are adequate. We request Deputy Mayor Turnage to accept our support of the pending Direct Care Workers Amendment Act of 2023, which included the provision to increase the DSP base wage to 100% of the living wage in determining reimbursement rates. The current proposed budget provides just an average of 117.6%. Under this scenario, many will be paid just the minimum, and some could be paid at the higher levels. But increased wages, however, by itself will not address the total shortage of home care aides. Just a very brief history over the 30 years that we've been providing. Initially, most of the caregivers were DC residents and substantially older caregivers. Now most are Maryland residents, younger, with various challenges that they face, childcare and other issues that they face as being younger and responsible for the care of their families. And so we need to definitely increase the pool of healthcare workers in this field. And again, as with other initiatives and other legislation, we encourage the following additional measures: providing grants for schools, providing grants to organizations for free training, and scholarships for high-need workers. And health aides definitely fit into this category. Once again, I appreciate the opportunity to testify this afternoon and willing to answer any questions that the chair may have. Thank you.
Thank you. Ms. Sharp?
Hi, good afternoon, Chairperson Henderson. My name is Veronica Sharp. I'm the president of the District of Columbia Healthcare Association, representing all the licensed nursing facilities and several assisted living communities in the district. On behalf of DCHCA facility members and the over 3,000 district residents who rely on them for essential care and services, I must say that we are extremely grateful to the mayor, her budget team, Deputy Mayor Wayne Turnage, and Senior Deputy Budget Director Angelique Martin for recognizing the need and funding increased rates for skilled nursing providers in this extremely difficult budget position. We are grateful for what is being done. And I think that it's important that council also knows that in increasing the rates doesn't come without a price tag to the provider community. In order to support the increased rates, the nursing home provider tax will be raised 0.5% to reach 6.0%, which is the highest allowed by CMS. And we are happy to do this to be a part of making this happen. As I reviewed my FY 2024 budget testimony, I was not surprised to be reminded that my testimony focused specifically on the healthcare workforce crisis that we are facing in the District of Columbia. The majority of the costs that will be funded by our increase are due to the ever-increasing wages that direct care workers and nurses are demanding providers pay to stay competitive in the market. In Deputy Mayor Turnage's presentation of the DHCF budget, there is a slide that shows that DC pays direct care workers the highest rates in the region. He would be correct in saying that, but that's not who we're competing with anymore. We're competing with employers that can offer similar or often better wages, better benefits, free training, and safer and less stressful jobs. Direct care workers, as you heard, are leaving the industry, and there's proof of that in the Board of Nursing numbers. You've heard that number multiple times. Also, in Mayor Bowser's testimony before the Committee on Health, the mayor stated that the district had not made a similar investment in direct care workers that care for older adults. The time to start moving toward comparable wages found under the Pay Equity Act for Child Development Associations is now to begin laying that groundwork. We agree with what Chairman Mendelson and the Council's methodology and commitment to restore and fully fund the Pay Equity Act, and ask that Council look at similar solutions in the future to fund the direct care workforce and establish pipelines to engage individuals in seeking this type of work. The only other area of the DHCF budget that I will comment on is that DHCF needs to fund improvements to the DCAS system so that it can be more transparent and easier to track or take actions on the provider side. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. Abby?
Good morning, Councilmember Henderson and members of the Committee on Health. Thank you for the opportunity to address the Council today. My name is Abby Goldstein. I am the Nursing Supervisor for Mary Center Nurse Family Partnership Program and a resident of Ward 4. I want to thank you for the support you have given to DC's Nascent Nurse Family Partnership Program. It was instrumental to our initiation just 3 years ago, our continued growth, and our success to date in building our program. I am testifying today about the extremely time-sensitive need to provide one-time gap funding of $475,000 to ensure the program continues. Additionally, we can secure long-term sustainable funding by lowering the fiscal impact statement in order to implement and fund the already unanimously passed Home Visiting Medicaid Reimbursement Act of 2023. At a 70% federal dollar match to just 30% of local funding, we can bring in significant outside funding to benefit our families in DC with only a small investment from our limited budget. One of the most striking things we see with clients is a lack of social support. Just to provide a glimpse of the numbers, in just 3 years, NFP has worked with 146 families, including 105 children. Of those clients, our assessments have shown that 1 in 3 report loneliness, isolation, depression, anxiety, and/or mental health issues. The saying that it takes a village is not a luxury the majority of our clients have the benefit of harnessing right as they're entering a critical time for themselves and their new families. Unfortunately, most come with a history of trauma, significant challenges, lack of support, and repeatedly fractured relationships with those they should be able to depend on. A nurse home visitor comes alongside families to provide non-judgmental support when they're looking to be a secure base of safety and attachment for their newborns. As they navigate this unique time period and work to set a pattern for their children, families benefit from the nursing expertise in not only physical and mental health assessments and medical education, but also in areas that touch on social determinants of health. However, with our work at risk of funding cuts, not only would we not be able to support future families in this manner that is proven to improve outcomes for both parents and children, but we would be forced to terminate services to those families we are currently working with. This means that it would be just one more broken relationship in their lives, one more person or system to allow them to fall through the cracks after offering the promise of something different. Simultaneously, it would lay waste to all of the resources we have all invested in training the excellent team of RNs over the past 3 years that are now experienced in the NFP model and consistently practicing at such a nuanced and high level of implementation. This cannot be easily replaced. With this connection to the nursing home visitors, families are able to gain increased self-sufficiency to bridge the gap in pre-existing lack of access, knowledge, skills, and information to be able to address the needs of their families in a way that not only encourages their progress, but also prevents greater deterioration of their social, emotional, and physical needs. With significant yet relatively small investment from DC government, we can not only continue to provide these evidence-based programs like Nurse Family Partnership to current families, but also ensure it is available for families of our newest DC residents. Thank you so much for taking the time to learn more about home visiting and Nurse Family Partnership. I hope we have the opportunity to continue to serve as a crucial support system for families throughout DC.
Thank you. Jody Aveka? Let's see, Jody. Vanessa Lopez?
Yeah, hello, here.
Go ahead when you're ready.
Awesome. Hi, my name is Vanessa Lopez from DC Action. I am speaking on behalf of Jennifer Vega, a home visitor who was unable to attend due to her work schedule. Good afternoon, Chair and committee members overseeing the Department of Healthcare Finance. Thank you for the opportunity to address the council today. My name is Jennifer Vega. I'm a nurse home visitor. I am testifying for the continuation of the home visiting program, Nurse Family Partnership, and for the funding of the Medicaid reimbursement bill that will help us survive and continue to support first-time expectant families navigating new pregnancy in the district. According to NFP research, mothers in NFP improve their diets and reduce their use of tobacco, alcohol, and illegal substances. They also learn how to effectively care for themselves and their children and recognize their children's developmental milestones, along with educational resources. Parents in NFP learn about children's behaviors and develop positive approaches and nonviolent parenting techniques. They also develop a vision for their future and find ways to stay in school, seek employment, and plan future pregnancies so they can achieve economic self-sufficiency. According to gathered data by NFP, in this program, 48% children are less likely to suffer child abuse and neglect, 56% in reduction of ER visits for accidents and poisoning, 67% are less likely to experience behavioral and intellectual problems at age 6, 72% of fewer conviction of mothers, 35% of fewer hypertensive disorders of pregnancy, and there's an 82% increasement of mothers employed. NFP nurses play a critical role in the lives of first-time mothers and their children. We visit the families in their homes, help moms and their partners through their pregnancies, birth, postpartum, up until their children are 2 years old. During these visits, we talk about a wide range of topics such as following a healthy and safe pregnancy, breastfeeding, newborn care, childhood development activities, and parenting skills. We also focus on helping them identify their personal strengths and guide them to achieving a better future for themselves and their families. I would like for NFP to continue to expand throughout all the states in the U.S. NFP is currently serving in 40 states, including Washington, D.C., the U.S. Virgin Islands, and some tribal communities. In Washington, D.C., we have a team of 4 NFP nurses with a caseload capacity of 25 participants. It would be greatly beneficial to our community if this committee funded the Medicaid reimbursement bill that 28 other states have already implemented to make sure programs like mine have the resources to keep our commitments to families. It is essential that DC supports and invests in prevention programs like home visiting if we would like to see our community thrive. Prevention is key. It is our duty as members of this community to assist with building a brighter, safer, and healthier future for all those around us, and you're in a position to make this possible. Please fund this MRF bill and make sure the NFP team can continue to make healthy pregnancies possible for our neighbors in DC. Thank you.
Thank you. Fernanda Ruiz.
Hi, good morning, Chairwoman Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Fernanda Ruiz, and I'm the Commission Director at Mary Center, a member of Under 3 DC, and a district resident from Ward 4. I am here today to provide testimony regarding Mary Center's new partnership with DC Healthcare Finance to implement the Nurse Family Partnership Program and the sustainability of the program. As you are aware, Mary Center was awarded this fiscal year $225,000 from DC Healthcare Finance for the 2024 First-Time Birthing Person Home Visiting Grant. We are grateful for this investment in the Nurse Family Partnership Program, and we are glad to see this funding as recurrent in fiscal year 2025. As I stated previously, NFP is a widely researched and proven evidence-based home visiting model that supports first-time mothers facing financial barriers. Piloting NFP in the district was made possible through seed funding from the DC Council and DC Health in fiscal year 22, with a funding award of $150,000, and Mary Center securing an additional $2.2 million through private foundations. The community has received well the NFP program, and we're happy to report that NFP has supported 146 mothers and welcomed more than 106 healthy births in the 3 years of being piloted. We're excited to continue to partner with the district and offer NFP to mothers and their children in the district. However, despite the success of the program, NFP is at risk of not being funded. As I stated during the oversight performance hearing for DC Healthcare Finance, all private funding for NFP ends with the fiscal year. Mary Center is raising funds and pursuing other grant opportunities, both federal and private. Yet, the only secure funding in fiscal year 2025 is the $225,000 from DC Healthcare Finance, which is 30% of our operating budget. For this reason, it is imperative that the district invest in long-term sustainability strategies, such as leveraging Medicaid, and continues to support NFP. As we have discussed, the Home Visiting Reimbursement Amendment Act of 2023 provides a clear pathway for long-term sustainability. We appreciate the unwavering support the DC Council has demonstrated for the bill. However, without funding attached, the bill would not be implemented. On this note, we appreciate the involvement and support the Council and DC Healthcare Finance have demonstrated in working with the Office of the Chief Financial Officer to review the fiscal impact statement they provided for the implementation of the bill. In the most recent version shared with us last week, the fees estimations have been revised. However, they continue to include programs that the advocates do not anticipate participating in the Medicare reimbursement, and the projections remain higher in comparison from the ones provided by the Home Visiting Council and under 3DC. Last year, Mary Center incorporated Medicaid reimbursement for our home visiting programming in Maryland. From experience, we know it takes time to roll out Medicaid and to incorporate billing. We are concerned Medicaid reimbursement will not come soon enough to save the NFP program. Funding NFP and other evidence-based home visiting programs through Medicaid is not only cost-effective, it also promotes better coordination of care and services for pregnant persons and babies who are enrolled in managed care. Mary Center continues through our social change model to be committed to the health, education, and safety of families in the district. We hope we can build from here to continue our shared commitment to serve families in the district with the goal of improving maternal and child health outcomes. Thank you for the opportunity to testify today.
Thank you. And thank you to this final panel of witnesses. Again, like I said, usually we come at the very end of the hearing. A lot of the issues have already been raised around direct care workers, nurse-family partnership, and home visiting, but we appreciate so much all of you presenting your testimony today. If you could please make sure we have a copy of it for the record. And with that, we're going to take a 20-minute recess, and when we come back, we'll hear from Wayne Turnage and his team. Thank you so much. And we're back. Now have before us Deputy Mayor Wayne Turnage, who is the Deputy Mayor for Health and Human Services, as well as the Director of the Department of Healthcare Finance, to provide testimony to the committee. Before you present your DMHHS testimony, why don't we just swear in everybody at one time, and then that'll hold for the duration of the hearing. Okay, so if you and anyone who might speak today, if you could raise your right hand. All the people's great. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. All right, Director, when you're ready, just turn your mic on.
Good afternoon, Chairman. It is my pleasure to report on the mayor's proposed fiscal year 2025.
You gotta lift up the mic closer to you. There you go.
The mayor's fiscal year 2025 budget and financial plan for DMHHS, and later we will discuss the Department of Healthcare Finance. Despite the rather significant challenges in the formulation of a proposed budget, there can be, in my mind, little doubt about the mayor's commitment to sustaining the district's critical healthcare insurance safety net, a commitment that is clearly evinced in her allocation of significant funding to the Human Services Cluster. It has been well documented, and I won't belabor the point that the mayor formulated her fiscal year 25 budget proposal in the headwinds of the most difficult economic forecast that the city has seen in over 15 years. And due to the pernicious interplay between the persistency of remote work, a deteriorating commercial real estate market, and the erosion of sales tax growth rates, the predictions for future revenue growth have been significantly dampened. And so when you lay that reality on top of the city's pre-forecast expenditure patterns, the mayor was left with an enormous $4 billion problem to solve. My initial remarks today focus on the small budget for my office at DMHHS, which is capably managed by my outstanding Chief of Staff, Kiana Creighton, who joins me at the table along with our AFO. They work on the budget together. As is always the case, except for DHCF, I am not prepared to comment on the budgets of the other agencies, so I will leave that to the responsibility of those directors in their capable hands. So with that, I'll turn your attention to slide 4. I think it's slide 4. This shows our agency office. The core functions have not changed. We have a policy team that's led by Brian Harrison and Jane O. We have age-friendly DC functions handled by very capable by Gail Cohn. Jamal Weldon leads our encampment team, very challenging responsibilities, some of the most difficult jobs in the city. And Teresa Silla runs the Interagency Council on Housing. We manage her budget, but we make no effort to restrain her considerable advocacy. I will close my very brief remarks, as I promised, by taking you to slide 7, which line items our very significant, but small agency budget. As you can see, we have a $2.4 million budget, and it is spent mostly on personnel services. And the other items are listed below. So if you, I don't have any other remarks about the agency's budget, but certainly we are available for your questions regarding the 2.4 million.
All right. I feel like that was a record.
Yeah, that was quick.
I want to document this for our moment together.
I'll make a photo on the back end with you.
All right. So for those who are listening, these questions are just very specifically focused on Deputy Mayor for Health and Human Services. Director, as you sort of alluded to in your slides, in addition to supporting the agencies in your cluster, DMHHS leads 3 programs: Age-Friendly DC, the Interagency Council on Homelessness, and the Encampment Response Team. While these 3 initiatives certainly require an interagency approach, there are some other cross-sector issues that are hugely important, such as substance abuse or public benefit processing times that perhaps could benefit from a more active role from DMHHS. Have you all ever considered scaling up your budget allocation to be able to actively take a lead in some of those particular issues within the cluster?
I can't say that we have. I think there's an expectation that in my dual role that I will bring to the city administrator's attention those issues that require interagency coordination beyond what is identified in our budget. And I try to do that, and it's not easy. Those issues are very complex. But you know, I rely on the directors of those agencies to bring me into the fold and bring Kiana and my policy staff and Gail into the fold when there are issues that require greater attention than we may have dedicated to in the agency at that time.
Okay. I guess I'm asking, or let me put a more finer point on it. I'm asking you to engage more on, particularly on substance use disorder issues. You know, I think that just sort of in general, we have a second stabilization center that's opening. There was sort of this kerfuffle a little bit, I guess this in the last couple of weeks, because there was supposed to be a community meeting, bringing together DBH, DGS, the ANC for that particular area to sort of talk about some of the issues. And I think my colleague might speak about this a little bit later, but you know, they were anticipating sort of a rollout carpet, if you will. By that, a presentation explaining this is what we're doing, this is how things are going. Here, we're making, you know, the persons available to answer those questions. And they were kind of told by DBH, oh, that's not really we don't really do the large community outreach piece.
Well, that's not.
And the DGS sort of felt as though we're not the lead on this project. We are just executing in terms of the client wishes. But in some cases, some would say maybe DMHHS should be the one who is sort of coordinating the community outreach here about this.
And we should. I did not know about that meeting. I would ask that when there are meetings that involve DMHHS that require interagency level of coordination, that they start with me or Kiana. Okay. We can be certain that you won't get a response like you got from DBH or DGS. That was not appropriate in my judgment. And had I known about the meeting, we would have certainly made sure that a proper program was put in place to make it worth people's time and to show some of the good work that's being done.
Okay. Yeah. I don't think the meeting has happened yet. I think it had to be rescheduled. I think it's like maybe Thursday. Unclear. We'll get back to you on that. But it was just one of those things where it's like, okay, you have two distinct agencies. This is a very important issue for the city, a project that we all want to see move forward. We just don't want to be very lackluster in our communication, because I feel like that's when narratives start to fester.
Right.
Where rumors and all kinds of stuff. Oh, did you hear the city was planning, even though that's not even what we were trying to do.
Well, I do have an in-office meeting scheduled with Dr. Basban on Thursday, but I will make sure, we talk all the time, and we have a very good relationship. I will make sure I have a conversation with her tonight about that meeting on Thursday, and we will get a detailed plan, a run of show. It would be helpful to me if you have particular questions, you or your staff, that you would like addressed, if you give them to me, we'll make sure those are addressed.
Okay. We'll have to check in with the Ward 1 council member and the ANC and who's organizing. Okay. Age-friendly DC is now developing its 2025-2029 strategic plan. You know, what are we leaning towards in terms of our main priorities for making DC more age-friendly over the next 5 years? And what budget recommendations does age-friendly DC have for accomplishing these priorities beginning in the fiscal year 25 budget?
Well, we didn't, you know, I hate to keep referencing the very dismal budget situation that we faced in fiscal year 25. As you will see when we go through the enhancements at DHCF, we were very constrained with offering new enhancements. We could offer them, but in most cases, because of the funding situation, they were not accepted. That does not prohibit Gail and Kiana from working together on a plan that we can certainly revisit. One of the things that the mayor has said is that if the financial situation improves, in which we fully expect that it will, then we can re-engage on some of the things that we wanted to do in 25, maybe even re-engage mid-25, depending on what the numbers look like. But certainly, budget formulation starts to get in the fall for 26, and I'll be certain to talk with Kiana and Gail about their, whether or not they have issues that even if they have a price tag on them, that we need to consider as a part of the new plan.
Okay. The proposed FY25 budget reduces the human support operations NPS funding by 126,000. How will this impact encampment outreach and cleaning programs?
Well, like I said, Kiana manages the budget, so she can answer, but I will say up front, we get most of our money for encampments from other agencies. So if you see a reduction on our budget, it will likely have very little impact on what we do with encampments. And Kiana, you can add anything on it.
Thanks, Dan. Good afternoon, council members. So most of our daily functions that the encampment team does are funded through a MOU that we have with DHS.
Okay.
And so when we were going through and trying to provide reductions to meet our mark, that was the best place to do it, especially because our budget is also limited from an operational component as well. So it should not have any impact on us being able to provide services.
Okay. DMHHS will have 4 fewer FTEs in FY 2025. How will this reduction affect the work of the staff in the office? What programs might have to be reduced or paused due to the loss of those FTEs?
So I believe you're referring to the vacancies. And so what we did, there were a couple positions that were previously funded also via MOU that will not be funded via MOU beginning in fiscal year 25. And so what we did was we essentially were trying to repurpose those funds to ensure that the other positions that are currently filled will be able to stay filled. So those, and Adrian, please correct me if I believe it was just those 4. And so the MOUs will sunset with those other agencies, and then we will fund those positions ourselves going forward.
Okay, so the 4 FTEs were funded originally through MOU with other agencies. That funding has gone away. They were vacant.
2 of them, correct. 2 of them were, for 2 others, they were positions for the ICH that have been vacant.
Okay.
I do know, and Teresa wasn't able to be here today, so we can provide direct follow-up on those positions. She plans on hiring for those positions, and I believe actually that for at least 1, if not 2 of them, she already has potential offers in place for those positions.
Okay, so they're not going away. You're just doing some reshuffling.
Correct.
Yes, just doing some reshuffling, and 1 position is being reshuffled to another agency.
Okay. Speaking of ICH, in response to the pre-hearing questions, DMH has just stated that 173,000 in NPS currently budgeted for ICH support in FY25. It's for the development of Homeward DC 3.0 plan. But I think in your slides and testimony, you stated that you intended to repurpose it from NPS to PS to fund a community outreach specialist. Can you say more about that?
That might be an error because there was funding that we were going to repurpose if possible. And I'll double check with Teresa on some of the specifics in our pre-hearing questions. But essentially the issue is that the ICH doesn't have any funding outside of their FTEs for their operations.
Okay.
And so historically what we've been doing is we've just been, from DMHSS, been paying for any of the functions. So when they're having their full council meetings, any other engagement. And so recognizing the fiscal environment, what we were trying to do was identify within our budget what we would be able to cover. Some of the things that she mentions in here are being able to have some type of a firm help with some of the work for the development of Homeward DC 3.0. And then some of the other aspects are just for the operations of the office. So some of the systems that they need to have access to for their planning, and then also for actual renting out of space for when they have their engagements as well.
Okay.
Yeah,
Is that normal?
Homeward DC 3.0 will proceed as planned.
Okay.
There'll
But
be no problem with that.
my question though, has that always been the case where ICH's money has just mainly been in personnel and they haven't had any NPS?
As long as I've been in the office, they've never had operating funds to be able to cover their day-to-day functions. But also going back about 2 years, the office essentially had a lot of turnover. And so then when Teresa was confirmed as the executive director and she was building out her staff, I think they now are aware of what they need in order to carry out their functions. And so I think it's both a combination of whether or not they had the need before, but then also just the direction of their overall management of their working groups and the full council.
Okay, so for the FY25 budget going forward, how much MPS money will ICH have?
So right now, I believe, Adrian, it was 170,000. Is that correct?
That is correct.
So 170,000 will be for MPS for ICH.
Yes.
Correct.
Okay, great.
And if there's additional follow-up, council member, I can work with Teresa and provide that after the hearing as well.
Now, in the pre-hearing questions to kind of indicate that even the 170,000 is not sufficient to adequately support the ICH budget. But you're saying we're going to move forward with the Homework DC work anyway. So where are they going to get the extra money?
We'll find it. It's a big government. We got a lot of people. We will, Homework DC, that's a major priority. It will not.
Well, no, I know. I'm saying like Homework DC not only sort of it requires a certain bit of community engagement
Right.
to sort of put it together. And I don't know, there are some people in the community who come out for the goodness of their heart, but you still need to provide them like with water
Oh, we can,
and a place to sit and maybe a cookie. So like you need money for that.
if necessary. DHCF has a $4 billion budget. We can find money at that level.
Mm-hmm. Oh, you remember this, Adrian? When we come asking for dollars for our little pinch in our bucket.
I can feel Angela and Darren's eyes on my back right now.
So I was like, everybody remember this conversation.
If I could add as well, council member, depending on, we try not to go back to the same CBOs, of course, but we usually try to rotate those types of responsibilities between other district agencies and CBOs to provide water, snacks, et cetera, when we do have the full council meetings as well.
Okay, okay. All right, so DMHHS included in its FY 2025 KPIs, supporting agencies in meeting the exit criteria of consent decrees. How many active consent decrees do we have right now within the cluster?
That's a good question.
So Sakina should be, I can't tell actually if she's online still. So if she is online, if Sakina
Our
Thompson,
lawyer.
our.
Oh, do we need to
Counsel.
promote someone? Ashley.
Thompson.
Sakina Thompson. Yep. Can we just promote her?
Okay. I
Ms.
think
Thompson, yes. The
Yes.
question was, how many active consent decrees do we have within the cluster?
we have the Salazar consent decree at DHCF. And I believe that is the only one. I will double check that and correct the record if there is another, but I believe Salazar is the remaining consent decree. Yes.
Thank you.
Mhm.
Okay, so only having one, not bad. There was a time when there was like 30 or however many, but that's good to know. Okay, so, you know, I know, Deputy Mayor, you often say you're here to support the other agencies in the cluster. I gotta ask some questions just overall. As I was kind of talking about in terms of the substance abuse piece. So as you know, DBH recently published Live Long DC 3.0, which provides interagency strategy on opioids and substance abuse. This new version continues to be very heavy on the use of naloxone. It doesn't have any other sort of big substantive changes, despite the fact that OCME reported again historically high rates of overdose last year. I think over 500 lives lost, and we're already on track this particular year. What needs to happen to change here in terms of our strategy? And I'm asking you and not necessarily Dr. Bazaron, because it's just not a DBH issue. This goes into DHS, this goes into DC Health. It kind of cuts across, as well as FIMS and judiciary, et cetera. Your mic is.
The loss of lives to the opioid epidemic is stunning. And I will say stubborn. The district's experience is only marginally different than what you're seeing across the country. Unfortunately, there's a perfect storm associated with opioid addiction. You have a long-term population of heroin users who often use in their homes and are often unaware of the lethality of fentanyl that may be in their drugs. And as a result, they are disproportionately killed. It is very difficult to fashion a strategy that breaks through that set of barriers. I know the folks at DBH work exceptionally hard on trying to attack those numbers. And they, some of the areas where they're having success, I guess they have to do a better job of reporting it, because one thing we don't effectively publicize is the number of overdose reversals that are made through this widespread program of through crisis making or getting to people who are using on the street and overdosing and reversing their addiction and reversing their potential overdose. They've made a lot of success. They've had a lot of success in that regard. It does not offset the fact that over 500 people have died, but it does tell you that were it not for those efforts, that number would be even higher. I'm not a substance abuse expert. I don't make any claims to be, and I know it is all I know is that it's an enormously difficult problem, and I rely on the experts. Unfortunately, I think the Opioid Abatement Commission is challenged. I don't think, for any number of reasons that I won't detail here, it has not been that productive. And, I'm not going to offer my reasons as to why, because that'll just add fuel to the fire. But we have to come up with a better method of moving that commission in a way that can have some impact. But even then, this notion of funding programs that have traditionally been used to tackle abuse, just not effective. We got to find a way to do something different. And my hope was that the Opioid Abatement Commission would be sort of create a marketplace of ideas about how to attack this, but instead we get, a lot of counterproductive meetings that leave a lot to be desired and leave a lot of people frustrated. So we have to do better because people are dying, and that's just, I don't have the answers, because like I said, I'm not a substance abuse expert, but this problem is confounding people all across the country.
No, I hear you in terms of the desires to see, this issue's hard.
Very hard.
But I think that the desire focuses to sort of see it as an elevated issue around, like, we're bringing the agencies together and we're having these conversations. I don't think the Abatement Commission is that place. There's just far too many people there.
I agree.
In order to kind of have that type of swiftness that I think we need to sort of address some of these issues.
Well, I mentioned that Keon and I are meeting with Barbara on Thursday.
Okay.
And that is top of the agenda. What's next with the Opioid Abatement Commission, and how do we make it more effective? I will say, I don't go to the meetings because, you know why I don't go to the meetings.
Yes.
And it would not be helpful. So we will have a long discussion with Barbara on Thursday, and I will share with you at the end of that discussion what we are thinking about as a way of making the commission more effective, or in fact, maybe sunsetting, I don't know.
Okay. There was a couple of witnesses we had who testified earlier today about encampment clearings.
Right.
I know it's sort of budget related, semi. What they said was that there are 7 encampment clearings that are planned for May. When I went to your website, I saw 3 listed, so I have to assume that the other 4, if they are federal MPS?
That is correct. And the reason they know about the 7 is because I've gotten probably 500 emails from the community, and I've responded to them with the details of what we have planned, and that includes a count of the number of sites. Now, even if MPS is closing an encampment, we have an agreement with them that we would provide the social services. So that's why 7 are listed, and 4 is MPS, and 3 are the Deputy Mayor's office.
Okay, so, I mean, in the, one of the witnesses raised the fact that a couple of these sites are in very close proximity to the Ashton shelter.
Right.
What's the timeline? Are we on schedule? What are we doing?
That's a good question. I don't think we are, and Kiana may know the details. I don't think we are about to cut a ribbon. But this won't be done in time for us to rely on the Ashton to relieve some pressure in the shelters to make more beds available. We're going to have to bring additional beds online to effectuate these closures at 7 sites.
Okay. Okay, you said a lot there. You said we need to bring more beds online.
Shelter beds.
Shelter beds online in order to effectuate the closure of these
That's
7
correct.
sites.
That's correct.
I think one of these closures is planned in like 2 weeks. So what's our plan?
I talked to Laura over the weekend, and she will have a sufficient number of beds online by, I think it's May 15th is the MPS dates, to handle the initial closures that we plan to work with MPS on. So we're not going to close a site without offering a shelter bed. In the past, we have offered apartments and shelter
hotels.
beds.
Yeah.
We can't do that this time because of a range of budget issues. Some of the residents, and I went to the encampments and took a census last week, and some of the residents have
Vouchers.
Not many, but some 6 or 7, I believe, have vouchers, and they're waiting for apartments. So what we will offer them is look, we have to close this site for a number of reasons, number of very good reasons, and we have a shelter bed if you would like until your unit becomes available. So that's what the plan is. Now, all 7 sites won't close on May 15th. It'll start with MPS.
Okay, so are you saying though you will not move forward with encampment closure if you don't have a shelter bed?
We have to have a bed.
I know you're saying you have to.
Yeah,
what I'm saying is,
look, let me
procurement is what procurement is.
Yeah,
So
let me put it differently. I don't think I have staff available that will close an encampment without the offer of a bed to the people who are impacted. They're not going to do it. They will be defiant, and I understand why. You can't, I've told people I've been working for 40 years. This is the most difficult thing that I've ever done, and it is hardly the most rewarding. And I don't have people who will go out and shut down an encampment site and tell a person who was homeless that, okay, you on your own, you don't have where to go. I don't care if you have nowhere to go. So we have to get the beds online. And if we don't, we'll tell MPS, hey, look, you need to push your date back a little bit because we don't have the beds available to absorb the folks at that site yet. And MPS will work with us. But right now, unless Laura tells me something differently between now and May 15th, we plan to go forward, let MPS know we have the beds to accommodate the closures at their site. And if we don't, I mean, as late as the day before, we can tell MPS, look, I know you got everything lined up, but we don't have the beds, you got to pull it back. And
will MPS acquiesce?
Oh, we have a very good relationship with them. I think I think they will acquiesce. We hope it does not come to that. We don't expect it to come to that. We're not building new shelters. These are we're gonna bring some beds online and 2 existing shelters. And Laura told me the names of the weekend, and I can't remember. But again, my staff are not going to close an encampment without the offer of a shelter bed, at least.
Okay. But again, to go back just to the Ashton real quick, like,
and it will probably
spring? Are we summer?
It's August.
August.
Yes.
Beginning of August or end of August?
We can double check. And actually, Sakina has been going to the community advisory team meetings on that. But also I will say that while there will be a late summer opening, that part of those engagements with the community advisory team and with the ANC have also included a staggering. And so the full capacity likely won't be online come August.
Right.
But then also because of the gap between the opening of the Aston and then also the closures, which is why for the two other shelters of expanding capacity at those two locations instead, and just recognizing the abilities that we'll actually be able to offer people.
Okay. So let me just ask, so for the 25th in Virginia, how many people are we talking about? This is one for May 15th.
The MPS site,
25th in Virginia, I think that is MPS, maybe?
if MPS has about 10 or so on their site, and then if you step across the sidewalk, then that's our site. I think that has like 16 residents there.
Okay.
And so
What about,
the rest of the sites are all very small in terms of the number. There are total, by my count on Friday, it's not the official count of DHS, by my count on last week, I think it was like 40. I counted about 40 about 40 residents
across all 7?
across all 7 sites.
Okay. So then someone would ask, if we were talking about such a small number of individuals, why clear?
Well, they're being cleared not because of the size of the size of the population. They're being cleared because there are a number of problems. If you go to 25th in Virginia, as I've done, there's a huge rodent problem. There have been fires. There have been tents that have caught on fire. There have been some assaults. There have been pedestrians who are threatened. And then some sites are situated in a manner that are a danger in themselves. Like one is sitting right over top of an overpass. That's not safe. And so there are a number of reasons that lead us to close a site, separate and apart from the actual size of the site.
Okay. All right.
But people look at these things in isolation. And I sent the data to everybody who sent me an email, some of them fairly nasty, as a matter of fact. There are 43 different encampment sites in Foggy Bottom alone. We're closing 7 of them. So it's not like we're sweeping through Foggy Bottom and just randomly and recklessly and arbitrarily shutting down sites. We're not doing that. We're looking at places where there are problems, where the location of the site is a problem. And we are, taking action as is indicated by our protocol.
Let's follow up and just as we get, we'll be asking questions as we get closer to the May 15th date in
Absolutely.
terms of our ability to have found places there.
It is, I get a lot of criticism about the city's use of shelter beds. And I don't really understand the criticism, to be honest, particularly when you compare a shelter bed to living in an encampment. I think shelter beds offer a safer environment. But the fact that we don't have vacancies right now in the shelters, we have over 1,200 people staying in shelters, and they're being managed by DHS. I think it speaks to, and that's a commitment. When you look at the cost of build plus the operation, the city has probably sunk over $100 million in shelters. I know the last time I checked it was like 91 million, and that's that is to build and to operate. It is unwise for leaders to spend that kind of money and then trash the concept. If the concept is that bad, then why put $100 million in it?
Well, I think it's a shelter meant to be temporary.
Absolutely.
As we build the housing stock for folks to move out of shelter. into
Absolutely.
homes. So I'm not trashing the idea.
I'm not saying
but-
you. I've had conversations with
No,
some
but
council members where
I
they were.
also sort of speak on behalf of, I don't know the type of emails that you get. I've read some excerpts and I'm sure some of them, they cross the spectrum.
Sure.
But just in general, I think there is a very real fear or frustration of people who believe that shelter beds seems to be our solution to a homelessness problem, as opposed to building up affordable housing stock so that folks don't have to, number one, folks don't become homeless, and number two, aren't choosing that system.
Yeah. Well, I'm not an expert on the impediments to building a housing stock in DC, but you know the challenges, obviously. But I speak very proudly about the efforts that this administration has made to create alternatives for housing other than shelters. They spend a lot of money, and they've housed a lot of people. Now, the numbers keep growing, but that's a function of a lot of things. When I went out to the encampment site at 25th in Virginia, I talked to 3 or 4 residents. None of them were from DC. One was from Appalachia, one said she was from Mississippi, and one came down from Philadelphia. I said, why did you come to DC? He said, well, here you all have a good housing program. So I don't think we're gonna be able to build our way out of this. And this has to be a national solution. The federal government has to say, it is a moral scourge to have people in this country living in the street. And it takes a lot of resources to fix it, and local jurisdictions cannot do it by themselves. And until they say that, it's gonna always be a game of, hey, we got shelter beds over here, we have housing beds coming online, we have people with vouchers waiting for housing units. And it's never gonna be a situation where you see that number of people who need housing go to zero, because the district is a local jurisdiction trying to solve a national problem, and they can't do it.
No, I understand that. Speaking of on that piece in terms of us, the parts that we can control, right? So you said that you spoke to folks who are in the encampments who have vouchers. That's a part that we can control.
Yes.
Are we at least going to be working to try to get those
I think
folks leased up or in a process?
Absolutely. They are and Laura was the one that shared the data with me on the number who had vouchers. But this is the challenge. There are always challenges and controversies. DHS rightly is very, they get very nervous when we talk about going and closing an encampment and putting everybody in the encampment in an apartment. And the reason they get nervous is because there are people in the shelters who've been waiting for apartments with vouchers for some time. And not even ICH, which understands the need to close some encampments, they tell us, or they have told me, we don't think it's fair that you prioritize folks for housing who are living in encampments over people who are in shelters who may have been waiting longer and who may be more fragile. So it's always a challenge. It's never an easy solution. And, Laura and her team are very skilled, but it is an enormous challenge.
We'll follow up and continue to closely watch this. Obviously, the DHS is in Councilmember Robert White's committee, but you're in my committee, and DMHHS, who's part of this process with MPS, is here. So we'll continue to follow up on this particular issue. I don't have any further questions on DMHHS related, but as with last year, when colleagues come in, they might jump back. So I don't know if Kiana, you want to hang out for the duration here as folks come in and out, but we can transition your folks to move on to healthcare finance.
Okay,
cool.
And I can invite Laura as a regular guest to these meetings if you like.
A regular guest to that's not necessary. She's got enough going on. All right. Thank you. Thank you.
Great.
Thank you, guys. Healthcare finance team.
Get right there. Get right there.
Alrighty, when you're ready.
Now, council member, I am joined by members of my executive team and the AFO, Senior Deputy Director and Medicaid Director Melissa Bird, Senior Deputy Director of Finance Angelique Martin. Both of these leaders bring significant healthcare policy expertise to this process. Darren has been the AFO at DHCF since before I got there. Does a wonderful job. Sometimes we get very mad at him, but he doesn't care. We have, I want to give a special thanks to Angelique's gifted team of analysts and those who work under the guidance of April Grady as well. These staff perform very, very sophisticated data analysis that we need and that Darren needs to support his efforts to identify the cost of each DHCF proposal. Along with those members, there are other administrators in DHCF's divisions that are here, and I've also asked additional staff from Angelique's finance team to attend today's hearing. They are James Sims, the Associate Director of Medicaid Finance, and Joseph Brennan, our actuary. Overall, this group, the discerning and penetrating insight of this collective group is the foundation of the proposals that we advance to the Committee on Health in a very iterative process before we get to the Committee on Health with the Executive Office of the Mayor. The outline for my remarks today is presented on slide 1. Since you are well informed of the fiscal challenges that the mayor wrestled with in this budget, I will begin my remarks on slide 5, which highlights the goals underpinning the mayor's formulation of DHCF's budget. I tell people all the time, it's like a broken record. If you have to take major money out of DHCF, and I'm talking major money, the only ways to do it, the only 3 ways: you can lower eligibility levels. We made such a proposal in this budget formulation process. You can reduce the scope of benefits. We made such a proposal. Or you could slash provider rates. We didn't make that proposal. As slide 5 indicates, the mayor chose to preserve these policies and to fund a provider rate increase for skilled nursing facilities. This reflects her commitment to finding money to preserve the health insurance safety net, which is a significant one in the district. If you look at next slide, I think it's slide 6. End of the day, mayor had a $20.9 billion budget. Human support services comprise 33% of that expenditure. $6.9 million, that's $6.9 million. Of that amount, 67% is allocated to DHCF. And if you go to slide 7, I asked my team to update the previous slide we had on this, and they refused, so I just told me to, in effect, do it myself. So I went yesterday and over the weekend and looked at the data on where we rank nationally based on the latest data, which Kaiser reports as of January 23. And so I built this graphic that shows you that if you look across the beneficiary groups, from adults with children to childless adults, pregnant women, infants, children 1 to 5, and children 16 to 18, we are either number 1 or number 2 in the country in terms of the level of Medicaid eligibility threshold that we set to give people access to care. So what does that mean? If you go to the next slide, it means that half of the people in the city are on either Medicaid or the Alliance program. And so I've said this a couple of times in previous briefings, that if you could evenly distribute everybody on Medicaid or Alliance across the city, that means every time you walked out your door, every other person you touch would be on fully funded public health insurance at no cost to them. Every other person in the city. That is a significant commitment to public health services, public healthcare services for persons who are living on the margin. The next slide, on slide 9, I'm not going to go through the details, but this shows you the scope of benefits or a snapshot of the scope of benefits that we fund and the cost of those benefits. And the mayor made no changes to the number of benefits that we offer through the Medicaid program. None. So I listened to the public comments this morning, and I don't, many of the pronouncements for or requests for more funding for more services I fully understand a lot of them. But I think what people lose sight of is how much we actually do. Those services that people are asking for additional dollars, in many cases, they're ancillary services. Some of them may have great potential. Some of them, we don't know if they have any efficacy. And we were willing to try well thought out positions if we can afford them. I think when you had a $4 billion problem, the fact that the mayor could do all that she did at DHCF, and you'll see in the next slide what we were looking at in terms of potential cuts and how the mayor helped us get through this without a significant slashing of our budget. It is to be commended. If you look at slide 11, this sort of lays out the process that Angelique and her team and Darren and his team go through, starting in roughly October to pencils down in what, February, March? So we started with a recurring budget in fiscal year 24 of $988 million. We are told we have to back out one-time funding, which we do. And then every agency has to take a 5% savings reduction to start the process. That created a baseline budget for 25 of $937.4 million. Now, with that budget, Angelique and Darren and all those folks get together and say, what would it cost if we maintain the existing programs from 24? That cost us $1.1 billion. So we give that information to the budget team, and they say, y'all got to take a $191 million cut. And we were like, whoa. There were literally a couple of nights that I didn't sleep well because I didn't know how we were going to find $191 million local dollars. And they seemed really serious because they were serious because the numbers were bad. And I talked to Angelique and Darren, we'd have these meetings, and I said, we got to find $191 million. And they said, Wayne, we can't do it easily. And so we made a bunch of requests to meet a $191 million mark. We made a $40 million savings proposal. And the mayor looked at it, and Kevin looked at it, and Jen looked at it and said, we can't do those things. They would be too harmful. So they instead of taking $191 million from us, they gave us $140 million back. Then they gave us another $6.8 million to fund, because they had no choice in that, to fund CMS's requirement that we have continuous eligibility for children. So the mayor's total budget adjustments came to $106 million. So at the end of the day, when you do the series of debits and credits, our local fund budget is over $1 billion for the first time since I've been in this city. That's $1 billion in local fund. DHCF's budget has never been that large before. And this comes in the midst of the worst economic forecast the city has seen in some time. If you go to the next slide, I'm not going to go through all the details because they're mind-numbing, but I urge you to look at the top of the first three bars in this chart. We spent $184.6 million on more coverage. We saved $31.1 million by shifting to expenses to non-local revenue sources. And then we took $46.4 million in cuts. Biggest one was DISH because of the ACR, which we'll hear more about later. And the other ones are listed. So this, I say all this to underscore how difficult and how thoughtful this process is at DHCF. And also how challenging it is for the executive office of the mayor. But we put a lot of work to try to help them deal with one of the most difficult budgets that they have ever seen. And I think notwithstanding some of the public comments, the product is outstanding. Now, I will say, I heard the comments about dental. I did not know that we were paying, 70% less than the fee-for-service rate? That's outrageous. We will fix that. So managed care companies are choosing, if I'm hearing this right, and if I won't, they'll call me tonight. They're choosing to pay dental providers 70% less than the fee. And our fee schedule needs to be updated. So they're getting hit on both sides. And so the young lady who spoke, I think she's a Howard graduate. She's very impressive. I asked my chief of staff to call her today and set up an appointment in her office. And I don't want her to take away from her busy time, so I'm gonna take my team over to her office, and we're gonna sit down and look at what we might be able to do differently, because it is unconscionable that they are providing dental services at those kind of rates. That's shocking. It was shocking to me. So we have to upgrade the fee schedule, which Angelique and her team will do in coordination with EOM. And then we have to let the health plans know that it is not acceptable for you to be paying those kind of rates. And we will do that. If you remember the last time managed care programs got in trouble, or DHCF got in trouble, it's when the agency, just before I got here, severely underfunded dental rates and ended up with a huge lawsuit. So we're gonna avoid that. If you go to the next slide, slide 14, I'm sure you've heard tons of stuff about it. I mean, you probably know more about it than I do at this point. Hospital provider taxes are a major critical component of the mayor's budget. And this table listed in red the provider tax that are included in the mayor's budget, and the amounts that the activities that they will likely fund are listed in the graph, in the bar chart on the right side. All of this is done to get the hospitals an average commercial rate. We have an actuary here to answer any questions beyond my presentation, but the average commercial rate is generally developed, as shown on the next slide, based on a survey of reimbursement levels. In this case, the hospital provider's top 5 commercial payers. We will structure this as a tiered percentage increase on top of the current reimbursement levels for inpatient and outpatient services, and we're going to work very closely with DCHA to establish this ACR. And then we're going to direct the managed care providers to pay inpatient and outpatient hospitals up to the average commercial rate. This does 2 things. First of all, it helps DHCF tremendously. One of the biggest fights we always have with health plans and hospitals is make sure they pay an adequate rate. And we get in big fights. I mean, some of them have exploded in your lap on many occasions. Now that's taken completely off the table. We set a base rate, and then on top of that, they're paid an average commercial rate. So we don't even have to have those kind of discussions anymore, but we need to make sure that they get this, the payment is made through the appropriate supplemental payment. Now, the other thing is, I want to make sure that people understand this is not giving hospitals a whole bunch of money that they earn by taxing themselves to do the same thing they're doing. They expect, and we expect, and we'll talk on this a little bit later, that they will do some different things that will improve healthcare in the city. If you go to slide 16, it shows you the math around this really neat policy, and I'm praying that CMS doesn't cancel this thing before we can get the preprint approved, because if they do, it's going to be a problem. But in essence, the gross tax is $127.5 million. We take away roughly $16 million for administration. That generates $368.7 million. You gross that up, you're talking about $496 million that they will get through a much higher payment, a supplemental payment to their current MCO rate. Slide 17 shows you how we will implement it. I'm not going to bore you with that, but if you have questions about it, you can certainly ask Joe. But I'll take you to slide 19, which basically shows you the benefits of ACR to the DC community. First of all, it allows the hospitals to reinvest into community health efforts. We will work with the hospitals and the association to identify a concrete set of investments designed to improve access to care. These payments can also be tied to quality strategies and initiatives through some, we're not going to do anything without the agreement of the association. We want this to be a collaborative process that works towards the benefit of all. And we recognize that the hospitals are their business. They're not ours. We can't run them the way we want them. We can make suggestions. And the biggest thing, not the biggest thing, but certainly a key benefit is that it shrinks the reimbursement gap between commercial and Medicaid patients. That gap it's stunning when you look at it, pre-ACR, and to think that the hospitals have been told for years, you can lose money on Medicaid in most cases, but you can cost shift to your commercial payers because they pay you more. That is becoming less and less available because commercial payers are getting quite stingy. So if you go to slide 20, this sort of lays out some of the things that will be a focus of these new payments. Maternal health, which I know is a big initiative that you push. Workforce investment. The hospitals know they have to improve emergency room throughput. They get mad at me when I say this, but you know, the couple of times I had to go to the emergency room, I called all of them. I said, look, how long will I be here? They said, bring your toothbrush. It was a Friday night, and so I had to go somewhere else. Some of the emergency room stays are just unbelievable. And what happens is that creates poor health outcomes because you have people on gurneys who are really sick and they triage as best as they can. But if they don't have the workers that they need, or if they have people who are sitting in beds who are not getting acute care, but they're holding the bed, some people be in the hospital 200 and 300 days and they're not getting any services. So if you have a shortage of workers and you have beds that are not available because you have a shortage of workers or people are in those beds when they shouldn't be, it clogs up the emergency room. And then what happens when FEMS comes to drop off more patients, they have to sit there for sometimes hours. And so those are the things that are at the top of mind for the Healthcare Association, and we want to work with them to improve those outcomes and certainly to improve the transitional care once a patient is ready for discharge. The timeline is listed on this page. We're going to continue to work with them in the rest of this fiscal year. We have to hope that CMS agrees with us on this legislation, and we will set the 2025 as the base year for all quality measures and milestones. Slide 21 just describes the legislative vehicles that are in place that you know about, and that covers the DHCF portion of the budget. I do want to mention, because Ben is in the House, and Ben Stutz has been riding herd on the hospital construction process on slide 23. Ben tells me, and I believe him, because I see all evidence when I go by the site that it is both on time and on budget, and they have hit all of their goals with respect. Well, that was a moving target. Now, I mean, we did more things. We added a floor. You know, you can't add a floor and not add more money. So it's on budget. You know, and I think Ben hopefully Ben will back me up on that. But we fully expect to open to patients in early 2025. We have a brilliant new CEO over there that Kim Russo has hired. He's a great guy from Iowa, I believe. I've had dinner with him. He's a nice man, very smart. I think they're going to do great things. They met all the CBE hiring goals, and I think there's a tour scheduled for the DCHA board in May. I run over there periodically, but I haven't been inside yet. My next trip, which will be this week, I think, I'm going to go over there and walk through the inside. So this is a huge event. I mean, I remember back to the days when we were trying to get the legislation through council, and I didn't think it was going to make it. And I think I even promised one of the council members that if you pass this legislation, the day that the hospital is built, I will resign and get out of your hair. Fortunately, she's no longer on council, so I don't have to resign. So, I'm just, this is one of the best projects I've ever been associated with. It's going to do wonderful things for Ward 8 and Ward 7. It will be the shining light on the hill. So with that, I in my remarks, and we are available for your questions.
Awesome. Thank you for that, Director. And thank you to your team for responding to the pre-hearing questions that we have sent. And again, for the public, if you want to see those responses, you can look on the council website. So we're just going to go through Okay. The proposed FY25 budget shows a $34 million increase in local Medicaid spending for utilization and coverage growth. Can you explain a little of the assumptions behind the utilization growth, given that enrollment has declined by 25,000 people over the last 6 months? Angelique or Darren?
No, go ahead. Whoever has the answer.
If you want to take it.
It's like hot potato.
Okay, I know. My apologies. And so when we formulated the budget, as Deputy Mayor explained.
If you could just bring the mic down closer to, there you go. And you know, move it close. It scoots. There you go.
Okay, there you go.
Yes.
When we formulated the 25 budget, while enrollment has gone down, there's also rate increases that occur. There's also other coverage that we have. And so we look at the utilization as well. And so when you look at our enrollment, while you see that it has declined, what you also see is that our MCO rates have increased, even though we're going to lower bound. When you look at how much they cost per rate sale, and you look at the expenses and the utilization, that's what really focuses the increase that we have when you see that increase in our provider services.
So wait, are we seeing an increase in utilization in the current pool?
Across the board.
Across the board.
On fee for service and in MCO.
Okay. What do we attribute that to?
That I cannot answer. Right.
I'm just curious, like, have you guys ever have looked at the billing data to see, okay, what's driving the utilization increases?
Yes, and so we do look at the cost drivers.
Okay.
We know that the rate increases have also been a part of it. We also know the cost of care has also been part of the reason why we have increases in costs. An example of that is the current nursing home rate increase that we did. In FY25, we knew that when we looked at the utilization of their current rates, it wasn't sufficient. And so we had to increase the funds by that amount, increase the rate rather, to ensure that we had enough funding to support their cost. We've also seen the increase in cost related to other fee-for-service categories that where when you look at the number of participants, they're the more expensive in our MCOs, they're the more expensive rates or the more expensive population. And so when you look at their costs going forward, you see that increase. We also had an increase in hospital cost as well. So we try to formulate and look at what we see in FY24. We focus on what those cost drivers are, and then that's what we forecast forward.
The way I try to think about it, if unit cost is flat, if the unit cost is flat, but your overall costs are growing, then that means you have probably more people using the service, more people coming into the program using the service. But if unit cost is growing, then that could be any number of factors. It could be the service has been more expensive, or people are sicker and using more services. So the cost per person is going up as opposed to just the overall cost of the program. But if that unit cost is flat, that generally means more people.
Okay. You mentioned in the opening remarks, and I noted this even on the slides. So the budget proposal includes a $4.3 million reduction in personal care assistance. Now, you all said that this is to align the service with a clinical standard instead of maximum allowed. Now, obviously, we've heard from lots of constituents around the changes that happen with PCA hours. What are we talking about here in terms of the difference between a clinical standard and a maximum allowed?
Sure, I'll start off, and Angelique and I will tag team as we need to. So when you look at the algorithm, when we do a long-term care assessment to determine level of care and services that are needed, specifically here, PCA services. And I'm just going to use a bunch of made up numbers, but they'll illustrate the point. So let's say I score a 16 on my assessment, and a 16 tells me I need PCA, and the way the algorithm works behind that, if you will, there's just like our MCO rates, there's a low, a middle, and a high. Okay. So I scored a 16 and I need PCA hours. What could clinically support me could be 4, 6, or 8 hours. The low being 4, the mid being 6. It probably would be better if it was like 5, 6, 7, right? Could be 5 hours on the low side, 6 on the middle, and 7 on the high side. Clinically, 5, 6, or 7 hours can support my needs. Our assessment currently is triggered to set right on that high number every time.
So 7.
It's going to be 7, even though I could be okay with 5 or I could be okay with 6. And so the adjustment we're making is bringing it down to the middle. So whereas today I might score 16 and that would automatically revert to or identify 7 hours of PCA, going forward after April, when we propose to implement, it would be 6 hours instead.
What if I really feel like I need that additional hour? Can I petition for the?
You can always appeal, and our folks understand that process quite well.
Okay, all right. Now you said that this would go into effect when now, April?
It's after April 1st. If you recall, we have the special home and community-based services ARPA maintenance of effort requirement right now, so we cannot make any changes in service levels, et cetera, rates that decline before April 1st, 2025. So this would not go in effect until after April 1st.
April 1st, 2025. Okay. Trying to gauge my emails of complaints. So April 1st of 2025. And folks will receive notice, adequate notice, if you're making a reduction.
Always.
All right. I understand that some savings in local dollars are also. Oh no, hold on. I think this is a repeat. You guys have already sort of said this one. Okay. Now, according to pre-hearing responses, no Medicaid beneficiaries have used the new coverage for fertility drugs thus far in FY 2024. Do you still believe now, when we developed the FIS for this originally, you all said that you felt like 250 people were going to use it in year one? That was what the budget estimate was for, and that's how much we paid for. Do you all still believe that 250 people are going to use it within the next 5 months?
That's a Darren question.
I would say we still stand behind the fiscal impact statement. The SPA was only approved in March, right? So the response is essentially saying that no one has used it in the last
month,
2 or 3 weeks. Yeah.
Yeah. Okay. All right. I can't remember off the top of my head how much money that was total, but we'll come back to that. I just want to determine if you guys still need, I think, how much do we put into that? $700,000. Do you still need that $700,000 in FY 24?
At this point, yes.
Okay, Darren. All right, we've been joined by Councilmember Brianna Adair from Ward 1. Marcia, if you could just put 6 minutes on my clock so I can wrap up my situation, and then I'll turn to her for some questions. So we were happy to see that the budget includes $6.9 million to support the 12 months of continuous coverage for children and families. But we understand that there's significant differences between this federal requirement and the requirements of the Childhood Continuous Coverage Act that we passed last year. Can you explain, just for the record, the difference between the two levels of coverage? So the CMS version of 12 months, and then
Sure, I can start with that. If there are fiscal questions, I imagine Darren will jump in. So the federal requirement is that when a child enrolls into Medicaid, they must have their continuous enrollment for the full 12-month period. So let's say I came in on January 1st. I'm a kid, my parents' income changes, or that would probably be the best bet. Those changes, what we call changes of circumstance, don't matter, if you will, for that period of 12 months. So their eligibility would not be impacted. Versus in the legislation that was passed by the council, if I recall correctly, it was looking for a continuous enrollment up to the 6th birthday through the first 5 years of life. So it's a much longer period of time. So if I came in on January 1st, under that legislation, then changes to my circumstances would not be applicable until my 6th birthday. So you're looking at a full 5 years of essentially guaranteed coverage, for lack of a better term, versus a year.
Got it. Okay. And the federal requirement goes to 18?
I think
17 and a half.
so. It's usually up to 18.
18 in a day.
But we'll have to confirm for you.
Okay. So how many children or families do you anticipate that this 12-month continuous coverage provision would affect? The CMS requirement.
I know it's all of them up to a certain age point. Because it's all children enrolled.
Okay. I guess what I'm trying to get at is I see value in both, but is it duplicative to have both?
Yes. Yeah, I don't know the added benefit of, the,
I mean, there's a difference, right? I
There's a
think
difference,
one, in
but-
terms of like, you're guaranteed health coverage for your first 5 years versus one, you're guaranteed coverage for your plan year or whenever year your parent is entering the program. And that's it.
I think,
Go ahead.
I was gonna say, I think, given the coverage levels in the district already and the, you know, what we're looking at in terms of the budget challenges already, I think having a year of continuous coverage is definitely the focus to be versus the 5 years at this point in time.
And the bottom line is, given those high coverage levels and the way that we determine whether or not kids are still eligible, the likelihood of, most of it's passive. So they don't have to fill out anything. So unless they notify us of a significant change, they will be passively approved anyway. So I don't know what it adds, to be honest.
Is the CMS requirement? It's not in law, so it's based on administration, yes? Is this an administrative decision, i.e., I don't know what's gonna happen in November,
This was CAA,
but
Yeah.
you guys tell me. What I don't want to do is go down a path of like trying to untangle the two and then come January, something different. And,
No, I hear you.
and then we're up a creek without a paddle. You know what I mean?
It is federal law.
Oh, it's in federal law.
What I thought.
Yes. Okay, I was right. It was the CA, the Consolidated Appropriations Act is what put it into law.
Okay, great. So we were happy to see the continued support with reoccurring funds for several grant programs that you all have, Produce RX, the Diaper Bank, and then also for home visiting. Could the $225,000 for the current home visiting grant be used to offset the cost to implement the Home Visiting Services Reimbursement Act of 2023? If council could identify the rest of the funds. So you already have funding for a small home visiting grant. There's a home visiting bill. I'm pretty sure they do the same thing. So my question is like the 225 that's already there, could that be used to address some of the cost of the bill?
Yes, it could. We would just need to know ahead of time so that we didn't start the process of issuing the grant for FY 25.
Okay. So healthcare finances, draft 1115 waiver includes produce prescriptions. Assuming that CMS approves your waiver, would the current 500,000 allocated for Produce RX be used to implement the waiver?
It is something that we could consider, but at this time we would be looking at FY 26, so that is a likely a future budget question.
Oh, okay. So anything that's currently in, well, I guess in the draft waiver, no one should anticipate that you would be implementing that in FY 25.
The two items in the current renewal, and we've been clear on this in our community meetings, are the continued support for the IMD payment. So for the 19 to 64-year-olds seeking psych services inpatient, and then the elimination of the $1 copay on the MAT drugs. For everything else, the intent for essentially the first demonstration year is to just make sure we have the authority secured through the waiver renewal to do whether it's Produce RX, et cetera. And then we will spend the first year of planning and implementation, looking forward to implementation in FY 26 if funding is available.
Okay. All right. And I'll be back. 10 minutes, Marcia, Councilmember Nadeau. Thank you for joining us.
Oh, thank you very much. Good to see you all. Thank you.
Hi, Councilmember.
So I was disappointed to see that the Home Visiting Reimbursement Amendment Act, which provides Medicaid coverage for home visiting services, was not funded. We heard public testimony this morning in support of these critical programs and sustainable funding for them. I appreciate you all working with us and the CFO to create an updated FIS. But as we heard today, it may still be too high. Are you open to continuing the conversation on an updated FIS?
Well, that's a Darren question.
Could you repeat the
Yes.
question? I apologize.
Yes, do you need me to start from the beginning? This is the home visiting program.
Understood.
So I was grateful that the Department of Healthcare Finance worked with us and the CFO on reducing the FIS for that. But we think based on the testimony today, it still may be able to be revised further downward. Is that something you'd be willing to work with us on?
I mean, I suspect the Office of Revenue Analysis would be willing to have a conversation. But I was part of the conversations that we had this past week based on some of the other data that the advocates and others brought forward. I felt like the revision that the OCFO has come to, recognize the additional information that the advocates put forward. So, I mean, I guess we're willing to talk, certainly.
Okay, thank you. I'm glad to see the $225,000 recurring in the budget for the home visiting programs. We heard testimony this morning that this funding could be applied towards the Medicaid reimbursement for these programs. And I think Councilmember Henderson could probably confirm that with you, but were any of these potential cost savings taken into account when developing the FIS?
The offsetting funds from,
Mm-hmm.
I don't believe they were.
Okay, so the reason I ask is so if I think about, the FIS for a bill where the mayor believes that funds are sufficient, she'd be looking at the line item that was already in the budget. So in this case, that line item for what is the same program would be applied toward the FIS, right?
I mean, it's certainly something we could look at.
Okay.
Is the existing grant program, would it go away if this new program?
I think it's just a
More
different funding stream for the same program. So it seems like that would make sense.
Yeah, that's certainly something we could bring into the discussion.
Okay, great. I know there's been some concern around the time it would take to determine appropriate reimbursement for each of the varied home visiting models. Is Department of Healthcare Finance prepared to implement this legislation if funded in FY25?
I think implementing an FY25 would be difficult. And I'll have to refresh my, the different pathways for how we would implement. There's some state plan options, which is a more direct, clearer path, usually more, just faster.
Yeah, I
but
think
then
that was
there's-
what your preference was, your stated preference.
Probably so, because
Yeah.
it is clearer. The other option is through an 1115 waiver, which is much more, it just requires a lot more, including budget neutrality, demonstrations, et cetera. So, but if we choose the state plan pathway, then the question is, can we get all the services as described in, like, for example, the NFP model approved by CMS? And then that's just something that we'd have to work through. Or, and alternatively, if not, then you try to get what can be approved by and paid for by CMS, and then use other funding resources if they're available through a braided method to have the full complement of services. So a state plan amendment, you have to, the developing the rate and stuff, I think would be probably, Angelique's gonna have to jump in, but usually at least about 6 months or more if we do a more inclusive stakeholder, and by stakeholder, I mean providers as well. And then when we submit to CMS, after a public comment period, they have up to 90 days formally. If they want to take longer, they have to issue a formal request for additional information, which can then make it more than 90 days. So that's just the kind of the nuts and bolts in terms of getting the right authority to do so. And then there's the making sure, some other providers like Mary Center, they're Medicaid billers, they're Medicaid providers, so they understand Medicaid, they understand claiming. If it's going to be a straight Medicaid payment from a lift, an operational lift for them, it should be easier. If they're going to have to look at how they're, bringing in different streams of funding from different sources, it could be potentially lift. If you're talking about community-based organizations that provide these services and they're coming into Medicaid for the first time as a healthcare provider, that is a bigger lift to be operationally ready. So what I'm trying to say is that on paper, probably still 9 to 12 months really to get a state plan, and that's all, that's pushing. But then you have the implementation piece that, depending on the, the maturity and the capability of the providers or the potential providers, takes additional time if they're going to be successful.
So if that's the case, doesn't that also change the FIS so that the majority of the funding that is now would be indicated it's for FY25 would probably be in FY26?
I don't know. I understand the question. The 225?
For the FY25.
Okay. So Darren.
For the fiscal.
So if if there's no chance of this being implemented in FY25, then that sort of pushes the FIS out.
It would also then, affect your earlier question about using
Correct.
the grant.
Yeah.
funding from
Because the grant funding would need to be in place for most of FY25 in order to keep it going while the state plan process unfolded. So what we would have to do is demonstrate funds for FY26 and beyond.
I mean, we can bring that into the conversation, certainly.
Okay.
The longer implementation.
Okay. I think the only provider right now is Mary's Center.
That's for nurse family partnership. And so if we do a home visiting service in Medicaid and it's going to be limited to that provider, one, we can't, through a state plan process, we can't limit the providers per se.
Sure.
We can say, here are the provider qualifications, and who meets those qualifications you can enroll.
So more
right?
people can enter the market.
They could possibly.
That's great.
Then you have to pay for it and the FIS goes up.
For sure.
Yeah. But then
there-
my understanding though is across the district, at least before, I think there's over 17 different nurse home visiting programs. So it's what nurse home visiting program are you looking to actually have covered under Medicaid?
Okay.
There are different age groups, different, things like that, I think was spelled out in the prior testimony.
Okay. Thank you. Yep. I want to turn to direct support professionals, which we've heard a lot of testimony about today. As you know, my bill, the Direct Support Professional Payment Rate Act, requires the Department of Disability Services and Department of Healthcare Finance to increase direct support professional wages to 117.6%. However, there's a proposed budget subtitle that delays this wage, and the subtitle notes that Department of Healthcare Finance plans to use unspent federal dollars to provide a lump sum to providers to make up the difference. Can you explain your reasoning for that amendment?
Yes, so the purpose in the amendment is to ensure that we're able to maximize the home and community-based ARPA funding. And so if we were to implement it within the rate in FY25, we would have only been able to use the HCBS ARPA funding through payments through March 31st. Because the rates are based on claim submission. So when the provider submits a bill, then they will get paid. So we can only use ARPA funding through March, and then we would have to use local for the local appropriated funds for the local share. So 30% of that cost impact. By us delaying the rate by delaying the implementation into the rate till 26, we're able to continue the separate payment that we're currently doing now so that providers will get it. But because we're giving it in a lump sum amount prior to the end of the ARPA period, we're able to use the ARPA funding to pay for the 12 months. So that means that we have a savings in FY25 of 6 months. Well, 9 months, and then in FY26, we actually have a savings of 3 months because the payment's based on the calendar year. So we have 9 months. We'll use ARPA for 9 months in 25, and then in the 3 months in 26 are covered under that ARPA payment. And then we implement it in the rate in January 1 of 2026. That change didn't increase the financial plan because we would have already been paying the rate in FY26. So it was a way to maximize ARPA funding.
It saves local dollars.
So you have no way to use that ARPA funding and get that money to the providers without delaying the law?
Well, if we keep the law as currently written, we can only use the ARPA funding through claims submitted, by March 31st, 2025. So if a service or a claim is rendered April 1st, instead of utilizing ARPA funds for the local share, we'd have to use local appropriated dollars.
Okay, I'm over my time. Okay, I have 3 more. You want me to just knock them out? Okay. Thank you. Thank you, Angelique. So understaffing of these professionals remains a big challenge for access to care in the district, in part because wages still remain too low to attract people to the tough jobs. I know Councilmember Henderson and I, along with many of our other colleagues, introduced the Direct to Care Worker Amendment Act last year to increase base wages to address this issue. And you've said implementation would be costly, but we've continued to hear testimony about worsening staff shortages and low payment rates. What is the department's plan to address these challenges without increasing pay?
One of the things that we're currently doing, well, I'll name 2. We're working closely with DC Health to figure out how we're able to work collaboratively to try and get more people in the field and how we can utilize funding that we have access to. But specifically to DHCF, one of the things that we're currently doing is the home health rate study. And that home health rate study includes all of the services that are provided by our home health agencies. So it's not only PCA services, it's also skilled care services. In the rate study, we're focused on the service array. Right now, we have a lot of utilization in PCA, but we're also looking at what other services are we offering or could we offer where it focuses on skilled. Some of the complaints that we've heard are requirements around beneficiaries who have behavioral health diagnoses, and that our rates don't include support in the cost for those. And so the home health rate study will help us figure that out and also align the payment methodology. So right now, when you're dealing with a workforce shortage, we have specific people who provide PCA service. And then to provide any type of skilled care, you have your LPN and your RN. The home health rate study, when we begin to include other services such as more utilization in home health aid services, we have it, but nobody utilizes it. Inclusion of medication management, having other services that we're able to include, increasing PT/OT and speech to occur in the home. All of these are cost, and looking at a payment methodology that allows the provider flexibility in which professional they're going to use, as long as they're meeting the DC Health requirements, that will help the workforce shortage. Because right now, only PCAs can provide PCA service, if you will, in the way that a home health agency provides services. But if you allow them the flexibility for the beneficiary who also has skilled needs, then they're able to utilize their workers across the board and also utilize, for example, PCA workers to do home health services. That's what they're licensed or certified to do. But right now they're only doing PCA. So the rate study will help us address some of the issues, but collectively it's going to take more than just rate increases. And so that's where the partnerships come into play.
Okay. Thank you.
With the home care agencies is the lack of uniformity on cost reports. We have, I think, 59% who submitted cost reports and the rest have not. I think that's the number. And the challenge that creates is, you know, if the true cost of providing personal care services by the home care agency is not visible to us, and we pay just increase the rates because we think these higher rates will draw, more workers. We don't have a vehicle to go back and evaluate whether or not we've overpaid. So, one of the things that we're thinking about doing is basically saying by date X, if you're not submitting the cost report, then you can no longer be in the program. Because without that, we'll never be able to, I personally am not going to sign off on, $26, $27, $28 proposals if I don't know what that agency's cost is of delivering personal care. I don't want to be in a situation of trying to explain to CMS, Or why are you paying them $28 an hour for personal care workers and you don't even know what their costs are? See, if they have cost reports, then even if we overpay, we can look at the cost reports and then we can adjust the rates going forward. Without a cost report, we never can make that adjustment. And we just have not been able to get cost reports from all of the home care agencies. So at some point, rather than continue on this merry-go-round, we just have to say, if you want to be a home care agency in the Medicaid program in the city, you have to file a cost report, like almost every other provider that we deal with, hospitals, nursing homes. We have cost, we have good data. And so one thing we don't fight over when we set rates with hospitals and nursing homes is what their costs are, because we don't know what the cost of home care agencies, home care aides are for home care agencies. We know that there's this constant drumbeat that we don't pay enough, but that's not something that we can, magically just set another rate and be satisfied that we have done our due diligence and we're being good stewards of the program. As I stated, even with the limitation that we have, the rates we pay are not bad. Now people say, well, you're comparing yourself to Maryland and Virginia, and their cost of living is high, and that is certainly true. But we pay a higher rate, and I heard one public witness said this morning, they don't pay enough for people to live in the district. Well, we can't ever pay a personal care aide a high enough wage that they can get a place in the district. That's not something we can do. I mean, that's beyond our capability. You got people, the district's real estate is just pretty expensive. And I believe the last time I checked, I forgot the number, a larger percentage of the personal care aides live in Maryland. They don't live in the city. I would love to be able to pay a wage that somebody could go out and get an apartment wherever they want and provide good care, because what they do is extremely valuable. But we need more information than we got from the home care agencies, and we need other than, a seat of pants guess about, well, this is what you all should be paying them, because that's all it is. And nobody knows whether that will drive or solve the the worker shortage or not. We don't know what that price equilibrium point is. But I think at some point we have to get everybody on board with cost reports.
When will the cost study be completed?
So we started, the contract was awarded October of this year. Our goal is to be completed by in 12 months with the original research. We're currently beginning to do beneficiary outreach, where we have a survey where we talk to beneficiaries at various community settings, as well as try to have phone conversations as well, to make sure we understand, one, what services do they feel that they need for their needs under the home health care services. We also want to make sure they understand what their current benefit covers and just what they would like to see. We'll have the same conversations with workers and providers, and then we'll have a second session where we have town halls with advocates and the associations that represent home health agencies in the Long-Term Care Coalition. We want to make sure that we're able to define what the service complement should be and then the payment methodology. So our goal is for the FY26 formulation process to present a recommendation as to what the new methodology would be and the cost associated with it.
Okay, thank you.
Mm-hmm.
I know that the director served on the mayor's healthcare workforce task force. The task force final report included the recommendation to raise the payment floor for healthcare workers to 120% to strengthen recruitment and retention of staff. Does the department agree with that? Is the study looking at that?
Well, we don't necessarily agree or disagree with any proposed rate. The question is, what we've tried to do is set up, in the absence of good data, set up a structure that allows workers to make more than 120% of the wage, but it's not a flat rate. We think that the system we have in place, a tiered system that's based on a rate of, I think, 117.6, that is a perfect system. And if you get good cost data, then you can adjust that 117.6, leave the tier system in place, and move everything forward. If you have data that says, you know what, this 117.6 needs to be higher. And I think if we have that kind of data and we can credibly make those kind of recommendations, there's no, there's no hesitancy at DHCF on making those recommendations to the executive office of the mayor. We just need, when we go in there with a request that'll cost 30, 40, $50 million, we got to have a basis for telling them how we got there. And right now, we don't have that basis.
Okay. What were the, what data was the task force recommendation based on?
It's been so long ago, I don't remember. I think it was just based on this notion that there needed to be a spread between the living wage and PCA workers. And that was just, a number that somebody pulled out, well, we need a spread of this amount. That may be accurate, but it may not. That spread may not even be sufficient. We don't know.
I was on that subcommittee, and that's exactly right. It was to differentiate with the living wage component.
Yeah.
Has, actually, no, I think I'm good. All right. Thank you, Madam Chair. Thank you.
Thank you. Director, I want to pick up a little bit of the conversation you were having with Councilmember Joe on long-term care.
Thought we were done.
No. No. Again, I said, this is up to you. I got questions. Your budget is over $1 billion. Anticipate more than 30 minutes of questions on it. Okay, so we heard for several witnesses this morning about the obviously importance for the crisis of wages. We were happy to see a $17.7 million increase for nursing facilities. Will that funding go towards salary increases at these facilities, or are there unrestricted uses for that money?
The analysis that we did when we reviewed their cost, so 22, we reviewed cost in 22 and 23. It was workforce related.
Okay.
And so when we increased the rates and we came up with the 13%, it was based on their routine care category, which includes all their nursing cost and workforce.
Okay, so workforce. So is somebody gonna get a raise, maybe?
I would hope so, because that's the expectation of why we're giving the funding to the nursing facility.
Okay, I want to say that out loud for the record.
Yeah.
It is the expectation that folks will see a salary increase.
Yeah.
Is
there's-
this?
I'm sorry,
go ahead.
there's also a requirement that CMS put forth that nursing facilities have to meet certain wage requirements in FY 25. And then in FY 26, they have to meet staffing ratios. So it won't only be from the district that expectation occurs. CMS has also required it.
Okay. Is this funding sufficient to ensure that direct care workers in these facilities are earning on average 117% of the DC living wage as required by law?
So currently, the DSPs that work in our nursing facilities are CNAs. And our CNAs range between $18 and $23, which is above the average of 117. The average of 117 is $17.50 to $23. So it's in the same area, but it's still, CNAs are above. The other thing is because skilled nursing facilities are on a cost-based rate methodology, if we see that they are paying in excess of $23, if they're paying their CNAs in excess of that, then we will adjust the rate accordingly. And their rates get updated in FY 26.
Okay. All right. So this is good. This is good news. And hopefully this will be impactful for the nursing home facilities in terms of the work that they are doing. All right. In the pre-hearing responses, you all said that you're developing, longer term plans to address some of our long-term care workforce challenges, including a career ladder, enhanced wage for DSPs, the home health rate study, which you talked about, collaboration with other agencies for workforce training. I think I know a couple of these places, but in terms of the career ladder, that's long-term. So there's no funding in this budget that lays the groundwork for that. Yes?
When we speak of career ladder, we're talking about the current enhanced wage that we have in place. And that is the ability to pay as low as the living wage and up to, the increase, for example, this year with the living wage being at $17.50, they can pay up to $23. So that is what creates that career ladder.
Okay. All right. In terms of the home health study, you said you awarded the contract in October. You're hoping for a 12-month situation. Director, when are you going to make it mandatory
The,
for participation?
you know, I have.
I mean, that's a bold statement, and
No,
that's why I kind of gave you the look.
I
You
have-
were like, I'm going to make
I
it
have-
required.
I have decided to float that proposal, that we will give them a date certain to, start having cost reports, completed if you want to be in the program. We will probably notify them. This is all me thinking about this out loud,
Mhm.
but I have been thinking about it for some time though. If we notify the agencies this summer, then we would expect them to be indicating that they are going to comply by January of next year.
Okay, so is the anticipation that perhaps we could see that included in the FY26 budget, depending on obviously the revenue pieces, et cetera, but
Well,
if you're getting the stuff back,
if it depends on it depends on how the audit, we have to give them time to do the audits. If we get cost reports, then the cost reports have to be audited. And we can use those cost reports. And maybe we can use unaudited cost reports to set the initial rates. But the problem with that is they have been so wildly off in what is an acceptable or allowable Medicaid cost. They would be perilous for us to accept those cost reports unaudited and then base rates on them. So I need to sit down and talk with Darren and Angelique about if we want the audited cost reports back in time for 26 budget. That's a heavy lift because they would have to get the cost reports audited probably by the end of this year. But it's, you know.
I mean, I'm out here, you know,
I hear you and I understand you and, you know, I just want to talk to.
we have 50 million, 11 people who say.
No, I agree with you.
This is a problem.
I have no problem with saying you have to have audited cost reports by the end of the year. But I need to make sure that, you know, Darren does a lot of the audits, Angelique is involved with them. I need to make sure that's real. I mean, that is reasonable.
Yeah.
So I'll have that conversation with them after this meeting.
Okay. I mean, look, fine. I'll look at the camera. This is my plea to the heads of these associations.
Right.
You guys come and you testify, you talk about how you need more money. The agency is literally telling you what your people, your members need to do in order for us to increase the rates. Help me help you. Like, bring everybody to the table and let's do this, because right now, in terms of the timeline that you're kind of laying out, it's like, we're not gonna get to this till 2027.
Well, Darren just told me it takes 3 or 4 months to audit. So if we tell them, you know, they need to have those audit, they need to have cost reports into us. But which fiscal year would it be? It would be 20.
So we're already auditing. We already
Yeah,
have
but I'm
some
talking about
home health
everybody.
agencies. Right, but remember, we're coming up with the new rate methodology proposal for 26. That is based on cost. The requirement to submit cost reports annually for a for a cost-based methodology would be for 26. So that would be the first year that we would actually implement it, because that would be the first year the new rate methodology.
Right, so they would have to, if it takes 3 or 4 months for us to audit the rest of the cost reports, they'd have to generally have those cost reports completed by this summer.
Yes, they complete cost
I'm
reports.
talking about the ones who don't.
They complete cost reports. They don't submit cost reports to us. Since our last.
The difference, if they're not.
since-
Wait, what? Hold on. You
Since
said
our last
they
hearing-
complete it, but they don't submit it.
Correct, because we're not the only, many of the home health agencies don't only provide services just to Medicaid. So many of them have cost reports, but because it wasn't mandatory and their rates are not based on their cost, sometimes they did not submit them. I'll give you an example. Since the last hearing, we received many cost reports that were outstanding. And so we received that information.
I will submit an email to all the home care agencies before the end of this month, telling them they have to submit cost reports in time for us to set rates using audited cost reports for fiscal year 26.
You said before the end of this month. It is April 29th.
That's right. So that email will go out tomorrow.
All right. I'm trying to get us moving forward because what I hear you saying is I'm not gonna sign off on a proposal to pay $28 an hour if I don't even know how much you put, like the costs are all together. So I'm trying to we're gonna try to sort of work through the tussle here. Okay. And the pre-hearing responses, you all said that you plan to implement 2 money follows the person programs using federal grants for long-term care supports. Can you describe what these programs and how will they be implemented?
So in our current submission, sorry, I'm trying to get to the right page. In our current submission to CMS, we've had funding that includes, my apologies.
I think it was
Okay,
question 9 of the
here it
pre-hearing.
is,
Okay,
sorry.
okay.
And so we currently, have, a program called Capacity Building.
Okay.
And within that program, it's in our currently approved Money Follows the Person grant this year. But we have a planned implementation of 25. And so we've carried it through our submission to CMS in FY 25 to support capacity building for our providers. Some of the main focuses is 1, focusing on workforce development, 2, providing gap funding for accessibility adaptation, good gracious, assisted devices and DME equipment. The 3rd is system enhancement for the EPD waiver case management database. And lastly, the 4th goal is home and community-based long-term service and supports marketing.
Okay, so capacity building is 1. You said you guys said that there were 2. What's the other program?
I believe within this core program, there are the 4 different arms of it. We can go back and check with Katherine and her staff that are leading the efforts.
Okay. I want to go back to a question really quickly about MCOs. So I understand that some of the savings in local Medicaid dollars are due to Healthcare Finance's decision to start compensating MCOs using the lower bound of the actuarial assessments of utilization.
Yes.
When we used to compensate at the middle. How will going to the lower bound affect MCO beneficiaries?
It shouldn't affect them at all. The actuary sets a rate range that is actuarially sound and gives you the opportunity to pay anywhere from a lower bound, medium, or highest bound rate. Depending on what you judge the condition, or we judge the condition of our health plans to be and the requirements therein. We typically set that rate at the mid-range because the actuary has told us that, you can go anywhere in this range, but to consistently go low or to consistently, you're gonna underpay. If you consistently go high, you're gonna overpay. So we target the mid-range, but it does not preclude us from going high or low in a given year. So this is a year where we have budget problems that we decide to go low. So, but this should be all blind to the beneficiary.
Okay.
The health plans are still required to pay for all of their healthcare services, regardless of whether or not they're paid at a lower bound, a mid bound, or a higher bound.
Right.
Now, we wouldn't want to do lower bound every year because at some point you're going to end up underfunding your health plans.
Okay. All right, let's talk about Cedar Hill. Didn't want Ben to have to come all the way down here and not have to answer any questions. So in March, the Bowser administration announced that Universal Health Services will be opening a new freestanding emergency department in Ward 7 on the Fletcher Johnson campus, further expanding the network of health infrastructure that includes the urgent care center in Ward 8 and the upcoming medical center. All right, is there any funding in the FY25 proposed budget for this project, or is it going to be entirely paid for by UHS?
Council member, thanks for the question. No, there is no funding in the mayor's budget for the FED at Fletcher Johnson. That is part of UHS's $75 million commitment to the district under the agreement signed in 2020.
Okay, but the district does have associated costs with preparing the site, because
The district has costs associated with preparing the site for the overall development, which is beyond, much bigger than just the FED site.
that's right. So when's the last time you've had a conversation with DGS or DMPED about the demo of Fletcher Johnson?
We're in constant communication. The RFP for DGS to run the demolition is to close May 15th.
Okay, close. All right. Now, are they gonna move your part of the land first? I'm just curious, like, are y'all priority, or are we gonna have to wait for everybody else
Yes,
to
as
get
the
their
first, entity on the site, the plan is structured such that the parcel that UHS needs access to will be finished in this sequenced manner, such that the school is removed, the utilities are run in that area first, and then we move along the rest of the site.
Okay, all right. I'm excited. We're still on track. Early 2025,
Yes, we are on track.
Q1 of 2025.
We are on track for early 25 and within budget.
Okay. So you do not foresee any additional funding needed at this particular time?
We do not.
Okay. Healthcare finances budget includes $275,000 for contractual services for the new hospital. In pre-hearing responses, you all said that this could be spent on projects that range in nature and quote, range in nature and scope, and that this funding is intended to supplement the UHS budget. What does this mean? How'd y'all determine
So the
275,000?
The comment of nature, range and scope pertains to the marketing and educational pieces, which we referenced in our responses.
Okay.
We already utilize those funds for legal services and special events. So in this year, last year, we didn't have any operating dollars specifically for the hospital. 2 years ago, we had money for the training at UMC. So this year, what we're anticipating is, in addition to the legal services and the special events that we anticipate in the FY25 fiscal year, we would like to have supplemental funding for outreach and education to the community around the opening of the facility.
Okay, is this beyond legal fees? Just tell me, is this is this a swag budget? Is this for the ribbon cutting?
No. So special events would be ribbon cutting.
Okay.
Right? Or the topping out ceremony. This is for actual coordination with UHS around the outreach, like true marketing and education.
Okay. Director, I need to ask, and you're director, but also you sit on the board still of UMC.
Correct.
Were you aware that they are about to close their wound center at the end of the month, as in I think tomorrow? But that there is no wound clinic now east of the river to service folks?
Yeah, the utilization in that wound clinic is, almost nobody uses it. It's very low.
Don't say nobody.
I didn't say no, I said almost nobody.
Okay, it's like
very,
50.
it's very low. I did not know that there was not another wound center east of the river. But the bottom line, council member, is if we keep all these services running as if they're if they have significant utilization, we're gonna need more money from the city, because that $15 to $22 million subsidy will not be enough.
Look, I understand that we always talked about the need to sort of transition in terms of the
Correct.
services and those kinds of things. And ensuring though that UMCs continue to provide those critical services. But emergency department is one, behavioral health is another, right?
Correct.
There's some other clinics for which they are slowing down and they're closing. I think my sort of frustration with this particular one was that it was very quick. UMC knew that this wound center was going to close. We had our hearing. When I asked the question about, are there any programs? They said that we're losing. They said no. And then 2 weeks later, I get a memo that says, and we're closing in 5 days. So
yeah,
I feel like the
Yeah, I'm not
as
sure.
we go through this process, the communication just needs to be tight.
Yeah, I'm not sure how that happened. I do know that we, the board, asked UMC for, UMC leadership for a plan that would scale down the operations to closure. And, you know, and that was some time ago, and they agreed to look at actual utilization across all of the hospital functions,
Mhm.
and then come back to us with a plan to start scale down that would do two things. It would be orderly in terms of care delivery, and it would also allow the hospital to, you know, continue to operate, but within the existing budget, including the subsidy. My thinking was that any service that closes, that the C-suite team would work with other hospitals to develop transfer agreements. So patients who would come to UMC looking for that kind of care could be logically referred to the other hospitals that are providing that service, even if it's across town. Now, if it's a Medicaid beneficiary, we'll pay for the trip. So that's not an issue. It's a little inconvenient, but we'll pay for the trip.
No more than a little. If you're going to a wound clinic, that is something significant.
Well, absolutely. That's why, you know, but the community would be notified that their wound clinic is closed.
Okay.
These are the hospitals that we have agreements with. If you are receiving Medicaid, feel free to use your transportation services to get to that doctor.
All right. I should have asked this earlier when Mr. Coleman was here. He testified earlier today. But Ben, are you aware of whether or not UHS plans to have a MAT program at Cedar Hill?
I'd have to defer to UHS. I can find out for you.
Okay. I'm curious about that, and then also whether or not they're going to offer wound clinic services at Cedar Hill as well. If you could get back to us about that.
Happy to ask.
That'd be great. Thank you. Okay, DCAS, our favorite football stadium of a system of programs. Okay, in the pre-hearing responses, Healthcare Finance noted that DCAS is planning to onboard a new operations and maintenance vendor in FY24 and FY25, and must allot funding for the overlap between the vendor and current staff contracts of about $344,000. If you are onboarding a vendor in FY24, why is the money also allocated for in FY25?
So we plan to bring the vendor on possibly August into September, October. So it's crossing fiscal years.
Got it. Okay.
And we have to transition, you know, we need enough time to transition staff. So.
Did you already pick a vendor?
No, we're in the process.
Okay, so there's no real like timeline piece just yet.
No.
Okay, in FY23, Healthcare Finance reported a $7.8 million surplus because of delays in contract spending, mainly in DCAS for operations and maintenance. So this is why I'm asking this question, because we've had some history here. In terms of how you all have adjusted this FY25 budget to reflect the reality based on the past experience. You feel pretty confident that 344 is needed?
Yes. Yes.
All right. The biggest share of the DCAS costs fall on contracts. $52 million out of $77 million, including notice printing, mailing services, DCAS, tier 1 call center, etc. How are you guys evaluating whether or not these contracts are working as anticipated or as effectively as you'd like?
Well, we monitor it with our vendors, but I think that that's the reason why we're doing new procurements now. We've had this as our focus over the last couple of years to ensure that we have the correct contracting, procedures and requirements in place so that we can ensure that we are making sure that we are measuring our contracts and holding our vendors accountable.
Okay. Is notice printing a federal requirement?
Yes.
Or like, can folks like opt out to a electronic?
mail.
We have to
We
mail.
have to mail.
This is how they
Bottom
keep
line,
the
we have
postal
to mail.
service open. Making everybody mail. Good gracious. Okay, how much do we spend on the call center? I'm not saying get rid of the call center, I'm curious. Of the 52, how much is the call center?
If I'm not mistaken, we are about around 8 million, if I'm not mistaken.
Okay.
But we've made a lot of updates to our call center, especially under the public health emergency.
Mhm.
We had to expand our call center. And now we are actually at the end of the process with our new procurement. So we'll have some updated estimates. And we've also expanded what just a call center, but more so a contact center, so that we can have our residents could have more access. And, it's instead of just a phone call, we'll have more services there.
Okay. How much do we spend on mail?
I would have to get that back to you. Get
Okay.
back to you on that one.
That's just a curious exercise on my part. Again, I feel like we are subsidizing the US Postal Service in some ways. Okay. In the pre-hearing responses, you all indicated that $1.3 million increase in software is to make the DCAS cloud compatible.
Yes, so we're moving from our on-premise to the cloud.
Okay.
And so we need to ensure that we have all of our software compatible with our new vendor and the softwares that come with making that move.
I'm in the wrong profession. $1.3 million just to make it compatible to go to the cloud.
It's a vendor. We also have a vendor that's coming on board. So it includes a new vendor. It includes the software that comes along with it. Plus, we have to keep our current software in place until we transition. So we also have some funding in there with Octo and, that overlap before we can actually see some costs, some decrease over the next years.
Okay, so we haven't identified a vendor for this project yet.
Yes, we do.
Oh, we do?
We implemented this in January.
Okay, so when do we think it's going to be over? Wait, hold on. So we implemented this in January,
We started.
but we're still budgeting for it in FY25?
Yes, because we have to start, we have to do our assessment, we have to get, but we still have to have the software. The contract, excuse me, sorry, yes. So we started on a process. We're doing our needs assessment currently right now with the vendor. Once all of that is done, then we'll know what what we can expect in the consumption, what other software we'll need, what we have to maintain moving forward. And so that will go, we expect that to go into 25.
Okay. All right, you guys had a project with Code for America to enhance user service. This was for summer of 24, so I guess that's coming up. Do you all have funding available in the FY25 budget to implement some of the changes or suggestions and suggested changes to the software based on this project over the summer?
Yes, we did. We have it just baked into our services contracts with the current staff.
Okay. Do you, are you all planning to continue your contract with Code for America in FY25?
That I would have to go back to the board, and this is a partnership with DHS. So we will continue. It is actually, hold on, let me back up. Yes, Code for America, we believe when we signed up, it would be about 3 years. So yes, sorry.
Okay. In the performance oversight, you all reported that you plan to execute a major upgrade to the Curum technology for the DCAS system in summer of 2024. Is this upgrade still scheduled to happen?
It is. We are in the process now. We're working with our vendor and with our contracts department, but we expect to have this done by July, August time.
Okay. And then finally, in this particular area, not finally altogether, sorry. At the performance oversight hearing, you all testified that you had took back 22 FTEs working on Medicaid processing to improve outcomes. Will those positions continue to be located under healthcare finance in the 25 budget?
Yes, this is the Medicaid branch. They were initially detailed to us and then made permanent with this current fiscal year, and we maintain them going forward.
Okay, so they are still there. Great. Moving along. While we're talking DCAST and DHS friends, Medicare recertifications. Okay, so I know that you guys have been working diligently to process Medicaid beneficiaries. Obviously, we heard a constituent earlier today who turned in the paperwork. It was turned off. She got it, everything sort of re-upped. So in your pre-hearing responses, you shared some updated numbers with us about the number and percentage of beneficiaries who've been renewed. And so it appears that the highest percentage of beneficiaries thus far who disenrolled due to no response, they had originally enrolled in the program in 2020. They originally enrolled in Medicaid in 2020 or in 2021. Do you all have any insight on that trend? I guess this is what you would anticipate have happened.
Yes, exactly. So without talking to individuals, the idea is that generally speaking, when there's an economic downturn, Medicaid enrollment goes up. And seeing the folks, the best case scenario that we can, take from these numbers is that folks came on during the pandemic. They may have lost a job, been laid off, et cetera, and then hopefully have been able to retain employment and employer-sponsored insurance or coverage through the exchange.
Okay, so we are getting to that stage where folks who were in it, or folks who have renewed last year are coming up again.
Correct. So we have two cohorts of folks renewing, some renewing for the first time since the PHE, and some people who have completed their initial renewal, the unwinding renewal, if you will, and going into their second annual Medicaid eligibility renewal. So their normal course of action.
All right. There's still 19,000 applications that are pending.
Yes.
Director Turnage. 19,000.
Yeah, and they're still on health insurance.
Some of them.
Some of them. Well, if they're pending,
Let's qualify that, because I know from people like,
if they're pending, they still should be on. We should, if they're not on, then they shouldn't be pending anymore.
I feel like the last time I talked to you at Performance, though, it was like 18,000. I don't feel like we're making any progress here.
Well, I know we had contemplated, concerned about the possibility of having recertifications run into new certifications. We had talked about talking to CMS about extending people automatically who were sort of stuck in pending. Melissa, did you have that conversation with CMS?
Yep, and we've communicated that to the public in terms of being able to extend folks that are pending if they've been at that kind of year mark, if they're coming up on their second one. So we are moving those folks forward. So we are moving through those.
So from like a process standpoint, let's say I'm a person with Medicaid. If I go in my portal, it still says that I'm pending for plan 23. Yeah, plan 23. Do I need to resubmit my income information for 24?
Talk through the process.
Sure. Eugene Sims, Policy Director, DHCF. So we've talked to, and the Deputy Mayor Melissa spoke about it. We've spoken with CMS. We know that if a case is still pending, by the time it comes up for recertification, that will have issues. So what CMS allowed us to do is simply renew those folks so that we could then reinitiate their second renewal after the pandemic. So for the second renewal, of course, as always, we will attempt to passively renew you. If you do not passively renew, then you will get a non-passive renewal packet, which of course will require you to submit your information, verifying your continued eligibility for Medicaid, like income, like residency, disability, things like that.
What percentage of this 19,000 do you anticipate are actually not eligible?
Well, I think our ongoing submitting, so folks who submitted and determined ineligible, I think it's in the low single digits, like 1 or 2%. April, that's right. So if the trend we've seen for the larger population holds true, then 1 to 2% of the pending folks would ultimately be determined ineligible.
Okay. So is there any concern that we're gonna, well, I don't know if there's concern, right? Are we gonna extend somebody who technically is probably ineligible? We're gonna extend them for a year?
Well, at this point, because of federal requirements that say we have to pen you, we cannot disconnect you from coverage until we process your application. The folks have already had their year of coverage.
Okay.
We are simply completing in the system so that are able to then reinitiate you. So the folks have already been connected for coverage for a year, regardless of whether or not they were actually eligible. This gives us opportunity to actually reinitiate them and hopefully get a true determination the second go.
Okay. Then, I mean, Director, and I'm gonna ask the same question that I asked Director Zeilinger at her budget hearing is like, how do we get back to inbox zero? Is that possible? And I'm not even just talking about on the Medicaid, but put on your deputy mayor hat, right? I got Medicaid crazy numbers. I've got SNAP crazy numbers. I've got TANF crazy numbers. And she's telling me it takes 6 months to onboard somebody. So they are relying on overtime, but then her overtime budget was slashed to like 27,000, even though I was like, girl, you've spent 2.3 million in overtime in this year alone. So how are you going to get by on $27,000 of overtime next year? What's our overall shifting here? And what do those conversations look like?
Well, I think, first of all, we go back to over 300,000 people that we've been managing in this process. And although I don't know if it's ever going to be a point where we're at zero in terms of folks who should have had a redetermination by date X, but I think it'll be to a manageable point where it can be a part of their normal workload, especially given some changes that we are making in other parts of the program. So I am less concerned about that. I would certainly like to see that 19,000 number drop a little quicker, but I think we are, given all the steps that we're taking, I think it's a manageable number where people are not going to end up losing care inappropriately, and our workers are not going to be overburdened. But it's not going to be at zero anytime soon, but it'll be manageable. And it'll be manageable and acceptable because people are not losing care.
No, that's good. I mean, look, at least we haven't been flagged for CMS like some
Right.
other states.
CMS, the data said we're like in top 5 in the country.
For some of our other public beneficiary programs.
No, not food stamps and
Yeah,
that's-
USDA is
yeah,
like,
they're
no.
all over us.
Yeah. So like we have to find a balance here.
Correct.
And if we have decided as a strategy that DHS is going to be the central location to process everybody's public benefit applications, then DHS can't be operating on shoestring and tape.
I think one of the challenges, and and Laura and I need to have an honest conversation about is it the system or is it the staff? And I don't know the answer to that question. And
It's been a while since we've had a DCAS hearing. Maybe we should re-up
no,
that.
no, we don't need to hear.
Councilmember White about that.
We can send you an email about it.
Sure, but an email doesn't allow for this type of banter and back and forth. But I think that like it's a question, right? I actually am genuinely interested in terms of the improvements that have been made in terms of the number of, what do they call it? A number of case actions that take place that they do on someone's, especially now that folks are supposedly in the office 4 days a week versus the 1 day a week situation. Just a curious academic exercise.
Sure. No, I understand. That
Did
makes sense.
productivity improve?
That makes sense.
So, all right. We'll put a note in that. Perhaps sometime in June, we'll revisit that conversation.
I'll be in South America in June.
Was there?
I'll be in South America.
Oh, you're planning your trip now? You want to know the exact dates to make sure you're gone?
I'll be back in December.
Oh, okay. All right. Behavioral health. Okay. So there's a lot that happened in the behavioral health space and not a lot that happened. All right. So last year, healthcare finance calculated DBH budget for the behavioral health rehabilitation local match at 61 million, which was an overcalculation. The council approved the budget at 54 million. There's a discrepancy between the approved budget and what DIFS shows. The FY24 approved amount in DIFS appears to be 65 million, while the council approved budget was 54 million. I don't know. Can someone explain that $9 million discrepancy?
We got two AFOs up here, so we.
I know. Between the AFOs.
It takes at least three to turn a light bulb though. So we-
So if we're actually looking at DBH's budget book, the 65 million is inclusive of 11 million for local only payments. That's not including the local match. So as we stated when I met with you a few weeks ago, there were a few technical corrections.
Okay.
And those technical corrections have been submitted. So
Okay.
the actual match budget is 54 million.
Okay, all right. Okay. So this year, healthcare finance calculated an approximately $10 million increase from last year for the behavioral health rehabilitation local match. So at 64.8 million. What assumptions and utilization calculations went into estimating about a $10 million increase for this line?
I actually would like to follow up with you on that so that I can provide you with the details.
Okay. I mean, it came from healthcare finance. So
Yeah,
I don't know if
we-
this is a Darren or Angelique.
Yeah, that's
Okay.
That's Angelique and her team.
Oh, a new person. If you could just introduce yourself for the record.
How you doing? I'm James Sims, Associate Director of Medicaid Finance. So generally, the increase was associated with the community supports that we saw in MHRS. In the telehealth modality, there was a tremendous growth, over 200% from 2020. So you see an increase in our budget to reflect some of the growth that we saw in that.
Over a 200% increase, you said, in the telehealth modality
From 2020, yeah.
Yes.
from 2020. Okay.
Some of the savings, to add context though, some of the savings that DBH proposed that's reflected in our budget are savings related to curbing some of that growth, but there was still an increase.
Okay. Yeah, I think we talked about some of the things around needing to have at least one person in-person,
Yeah.
I don't know, consultation visit, whatever, visit, and then going from there. Okay, so the 10 million is for utilization. All right. Healthcare Finance reported that part of this increase is also to implement the 1115 waiver. Can you break down the difference between the anticipated waiver implementation funds and any rate changes to behavioral health funds? Because I think, Melissa, you told Councilmember Nadeau that we shouldn't anticipate the 1115 waiver implementation for all things until FY26. So
Except for the current services that remain. So the currently approved waiver services like the IMD costs and the elimination of the dollar copay are still included in our budget. It would be the new proposed services.
okay,
'Cause this
so
is a
for
renewal,
existing
so-
things, it would continue. For new
Correct.
things, 26. Got it. Okay. So, of that 10 million, what percentage of that is around utilization versus 1115?
I don't have the breakout right now, but I can get that,
Okay,
those percentages.
that would be good. We'll follow up with that as well. Let me talk a little bit about the 1115 waiver while we're on it. So obviously we're really excited to see the proposed priorities for the whole person care transformation 1115 waiver, including continuing authority on behavioral health transformation and new authority to address some social needs and justice involved reentry services. All right. I'm going to ask the question, even though I think I kind of know, but I just want to, they've given me a path here. So, if you're planning to submit the renewal application on or around May 31st, when do you anticipate these changes to go into effect? You said, so would that be what, October 1 of 25?
So first, the current waiver expires December 31st of this calendar year. Well, December 31st, 2024. We do know that CMS has a backlog of approvals for 1115 waivers or renewals. I expect our current authority will be extended a few months. I am hopeful, and the timing, of course, is not up to me. And if we have any changes in November, then that will extend timeframes going forward. But I'm hoping that we would have approval of the renewal request early calendar year 2025, looking for fiscal year 26 to hopefully be implementing some of the new programs.
Okay. Is there anything, and this is going off script, but I'm thinking about this conversation we had with Health Benefit Exchange and sort of implementing a new program in the uncertainty of whatever is going to happen in the fall. Is there anything that you all like absolutely want that you'll say to CMS, if you approve this, we will implement it right away, just so that we have it locked in?
A couple, well,
Well, that challenge is, it's a new service. It's a new service, there's a challenge. We have to get approval for any new service. Now, there are lots of things I think Melissa wants to do, she's told me. And I suspect that what we need to start having conversations with the EOM about, you know, how we approach this, given that the 1115 waiver is due at the end of the calendar year. So yeah, we'll have those conversations. Melissa has a laundry list of things that what I would like her to do is make some effort to cost out what it would mean. So when we talk to EOM, we can say, look, you know, we want to put these services in the waiver, but this is what they'll cost. What do you think?
and that's why at this point, the approach is to secure the authority, the broad authority. Once we have that and it's signed off by CMS, like that's essentially a contractual agreement.
Okay.
And then that gives us the flexibility. The unfortunate thing is our current waiver expires December 31st, which means the renewal would start January 1. I know it's going to be delayed just because they have such a backlog.
Yeah.
And so even just asking for the authority, I think could, you know, I would not feel as confident if there's an administration change of how we will move forward on those things. But that's where I think asking for the authority and not getting to specific programs is the best path for us. And we've seen other states be successful with that.
Okay. All right. I'm glad we are thinking about these things and having sort of a strategy around it. I don't know if everybody else is thinking about these things and having a strategy around it as well. Okay. On the behavioral health side, you shared that you will continue IMD services and the removal of the MAT copay. What successes are you guys seeing in the previous demonstrations and on these two things?
Well, the success, the kind of just point blank one is the ability to use federal funding to pay for the IMD services. Normally that's an exclusion. Just the driving reason for putting forward the waiver request. It seems like it should be simple, but when the payer changes, having that continuity of care, so shifting inpatient to community-based is just tougher because you have less insight, and having that the ability to pay gives us one oversight of the provider, but also insight into where beneficiaries are going. You can better track them. So I think that's I think we have better integration because of that. If you recall, we had a number of community-based services in the waiver that transitioned to state plan authority. So they are now permanent services within our array of behavioral health services, which I think is just helping the overall transformation of the behavioral health care system, well beyond Medicaid. And I think they eliminate, $1 copay may not sound like a lot to folks, but if someone thinks they have to pay that $1 and that's going to keep them from walking in to get their MAT, I think that's success on its own too. We do have reporting that we do and an evaluation that is in progress. I can't recall, we had an extension to submit the midpoint evaluation. I can't recall if we've done that or not. And then once the waiver period is up, we'll have the final demonstration. The one thing that's unfortunate and challenging, and I don't think we'll fully be able to articulate the success of the waiver, is that we got approval December 31st of 2019, and we went live January 1st, 2020. And so right at the pandemic.
Got it.
And so you don't have the stability in trends and the before and after that you would typically see in something like this. So much is, we think this is attributed to because of the pandemic, and we're just not going to know. So I think, having a full understanding of the impact is going to be challenging. But I think if you look holistically at the changes to the behavioral health system that we've been able to support DBH with through the waiver, through all of our work to date, I think overall we're seeing things trend in the right way.
Okay. On the justice portion, what services do you anticipate providing for 90 days prior to release? Obviously, there's some limitations there because I don't exactly know how you do that for folks who are in FOP, but
Well, we are asking for some support to do that. The CMS regulation or guidance originally specifically excluded individuals in Bureau of Prisons, but we are incorporating language to see if they are willing to have that conversation with us, given the unique nature of the District of Columbia and the fact that we don't have state prisons. Folks are in our jail or they're in BOP. And quite frankly, the hardest folks to really reach to and know where they're going and when they're going, when they're coming back home are those in Bureau of Prisons.
Right.
I hear that more from advocates, from community-based organizations, providers. So it would be just so helpful to have that opportunity to reach. But really to try to connect within, that 90 days before someone's released is really just trying to make those connections so the individuals connect it when they return home and you're not setting those up day one, back in the community. The other piece we're looking at is, can we get like a 30-day fill of prescription? So, oftentimes it's, I think, a 3 to 7 day script that you walk out with.
Yeah.
And so I guess on day 1 or 2 back in the community, you're trying to run to your Walgreens or wherever and get your medicines refilled. And sometimes you need a new doctor's script for that. And I just don't think that makes sense that's a lot to put on someone.
Yeah. Okay. All right. Let me ask, I'm in my final section, which is about the BSA subtitles, which some people forget, but are super important, for us. Okay, so I appreciate, Director, you overviewing your testimony about the Medicaid Inpatient and Outpatient Hospital Directed Payments Act in the BSA. I also had an opportunity to meet with the Hospital Association and several of the CEOs about this in particular. This is, I would not call this a simple and straightforward revenue raiser for, it's convoluted and fragile, I think is what Jackie called it, Jackie Bowens, to sort of put it together. So our committee has discussed with your staff, we've discussed with several of the hospitals now about how some of the additional revenue will be spent. And I understand that DHCF and hospitals have some shared policy goals around it. I think you had a list. Now, interesting, your list looks different than the Hospital Association's list. I don't know. Why doesn't the subtitle include any specific requirements for how the additional revenue will be spent to improve patient care and health?
It's kind of tough to do without sort of, a process of collaboration with the hospitals, which we obviously haven't had time to do at this point. I mean, we have to remember that those are pretty complex business operations. And our view of what should be done and what can be done may be very different based on our lack of information about how they operate. I think at the end of the day, when we sit down and we'll talk about what we want to achieve or what we would like to see achieved, we'll be pretty much, I think, very close to being in the same place. But to try to do that in advance of the passage of the proposal, we haven't had enough time, and we don't know enough about, how hospitals operate, what each hospital's revenue situation is, how they would like to use the money. The biggest thing I think they have to address is the challenge with throughput, and that's going to touch workforce, that's going to touch discharge planning. It's going to touch a lot of things, and for us to say, okay, well, we want you to take X% of this money and put it towards population health without attention to how much it's going to cost them to address their, emergency room throughput will be a challenge. So we just need to have some time to sit down with Jackie Bowens and the CEOs of the hospitals and sort of come to some agreement on, how best to use these dollars, allow them to maintain the flexibility they need to run their operations.
Okay. The subtitle includes a district retention of 12% of the fees paid by the hospitals into the funds. And the pre-hearing responses, Healthcare Finance shared a breakdown of how you'll spend this retention in FY25, including $8.7 million towards inpatient hospital care. Can you explain how this funding is different than the funding that is generated from the inpatient hospital fund?
Angelique can talk about that.
What we did is we shifted, when we support hospital costs, we utilize local dollars, dedicated tax and Medicaid. So the portion that was going to local, that was being paid from local dollars, we shifted it to the administrative funding,
Okay,
making local funding available.
all right. In future years, the district retention can go towards the general fund. Why did you all include this provision, and would it comply with the CMS requirements to use these funds for non-Medicaid purposes?
It's my understanding it would be allowable and it was put in there as an option.
Okay. Alrighty. We discussed with your staff as well as with the hospitals the potential to fund the Prior Authorization Reform Amendment Act through this fund, since it will also benefit the hospitals. Do you have a position on that? No. 1.2. Turn your mic on.
You use a portion of the administrative fund that accrues to DHCF to fund.
The Prior Authorization Reform Amendment Act of 2023, which is partially already implemented
Right.
for the private insurance companies, but we have
Yeah.
Medicaid beneficiaries who don't benefit from the new reforms we have in place.
Yeah, now, the challenge will be, obviously, if you use that, I think you'd have to replace it, wouldn't you? Yeah, you have to replace that one. So I defer to the wisdom of council. If that's something that you all want to do, the only question is how you're going to replace the dollars, because we have them targeted for something in our budget. And if you take it for that and don't address what we have it targeted for, then our budget is out of balance.
Okay. We're not gonna submit a unbound.
I know, I'm just saying, my point is, I have great respect for the council's authority to, the mayor proposes, the council disposes, I understand that. So I don't get in the way of that. I just simply say, just to so problems are not created. Just everybody understands that those dollars are targeted for a specific purpose. And if you use it for other purposes, then some other money has to be found somewhere.
Like, I'll tell you, like I told the hospitals, we moved prior authorization as like the first thing when I became chair of this committee, is because all the providers said this was the thing. And then you guys said, oh, no, we got to bifurcate the system. Private insurance, different rules than the Medicaid. Private insurance is already law. It's already implemented. So I'm now sitting in a system where I'm trying to find some equity and some parity, so that if you have Medicaid insurance, you're not having to wait 12 days to get an approval for a surgery, where someone in private insurance only has to wait 3 days to get approval. You know what I'm saying?
I think that's a noble goal, to be honest. I'm not a big fan of prior authorization.
No, you call me.
I
You don't like prior
I know.
You don't like what's the cons, CONs?
No, I don't. But, I recognize people do, and they have their reasons, good or bad. But, yes, I'm assuming if that is the purpose that the money would be used for, I mean, we certainly have no philosophical problem with putting some of this money towards prior, as long as you all can, again, satisfy the CFO that, everything's okay.
Okay. Subtitle VH moves 5.5 annually, or excuse me, 5.5 million annually out of the Healthy DC Fund into the general fund. Is it correct that this is a special purpose revenue fund that's collected from 2% tax on the MCOs, and it's generally used to pay MCOs through Medicaid payment?
It's a dedicated tax fund, but it is a dedicated tax fund, and the primary revenue source is a 2% tax on all health insurers in the district, including the Medicaid and Alliance plans.
Okay, how are the MCOs responding to your proposal to sweep everything out of this SPR?
It's not sweeping everything out, it's just transfer of revenue. That fund, give me a moment, but it's a $5.6 million revenue sweep, right?
5.5.
$5.5 million revenue sweep. The total fund spending, it's on tab 9. You know, the budget for that fund in FY '25 is $74.5 million.
Okay.
So it's not sweeping out everything. It's just the difference between projected revenue and the budgeted.
In the pre-hearing responses, Healthcare Finance indicated that the recurring 5.5 million reduction will be offset, that the $5.5 million reduction will offset the amount available to fund managed care expenditures. Can you be more specific about what managed care expenditures will specifically be affected?
I think there was some confusion in the answer to that question. This is sweeping revenue that was not budgeted. So
Okay.
the projected revenue exceeds the budget amount. And so this is sweeping that projected revenue, so that money would not have been spent otherwise. And so, and then it does it over the financial plan. So it's basically taking that amount over each year of the financial plan. So MCO beneficiaries should not, MCOs and MCO beneficiaries should not be affected.
Got it. Okay. All right. Okay. You noted in your opening remarks that 10 million in local funds was moved off of the healthcare finance books and paid for by the Healthy DC dedicated tax. Was this part of subtitle what is it, the non-lapsing fund transfer subtitle?
You're referring to the savings at the beginning of the director's presentation?
Yeah.
There was additional revenue. Stick with me for a second, but the ACR proposal creates additional revenue for the MCOs.
Okay.
That additional revenue, because they're subject to a 2% tax on the
Oh.
revenue, creates additional tax revenue that goes back into Healthy DC. And then we shifted expenditures from local to Healthy DC, creating a local fund savings. And that's where that slide shows where there was some savings achieved by shifting expenditure from local to other funding sources.
Okay, I follow that. Did you follow that? Okay, great. Okay. As you were saying that, I was wondering, like, somebody who's watching this hearing who just turned it on for the first time, that was like alphabet soup to them. And I'm like super proud of myself that I understood every part of what you were saying. Okay. Are there any limitations on the SPR funds outside of MCO improvements?
Could you explain what you mean by limitations? I'm sorry.
So in terms of, I think this particular special purpose revenue fund was designed for MCO improvements, large catchment. Does that mean that we could use this fund for actual MCO improvement type issues like prior auth, where they tell us they need money to improve their websites?
So the Healthy DC Fund, the purposes are really for programs operated by the Department of Healthcare Finance. The agency uses it to primarily to fund MCO expenditures, but the fund is fully budgeted. It's fully committed for 24 and 25.
At its current 2% rate.
Yes.
It's 2% today. It could be
That's what the law.
2.02% tomorrow. Maybe use that a little bit to fund prior auth.
I mean,
I'm speaking hypothetical. I don't know what we're gonna do.
guess it could be.
I'm trying to understand. I guess my question is that if it is still within the realm of using it to help MCOs and healthcare, is that an allowable use of that money, of that fund?
The purpose of the Healthy DC Fund is for programs operated for the Department of Healthcare Finance.
Okay.
So.
Got it. All right. And I will say again, director and to your team, this is the joys of the tough budget year where we are literally shaking every couch cushion.
I completely
Why some of my questions were very specific about do you really need this $200,000 or this $344,000 or this $172,000?
Completely understand.
But that's all the questions that I have, I think. Is there anything I didn't ask you that you want to say for the record? Oh, no, just kidding. There's one thing I'm supposed to ask you. It wasn't in the written questions, but I recently met with ANCAA, Historic Anacostia, and they said that they had a meeting with you at some point, or maybe it was the mayor. I think it was probably the mayor. The mayor came to ANCAA, and she committed to them to do a long-range public health plan for Good Hope Road, or now Marionberry Avenue.
Yes.
Particularly around there's a MAT clinic, and then there are a couple of other mental health services, et cetera. I think the mayor came at the end of last year, and they haven't heard anything since then.
Right.
And so they asked that I ask you.
So
about
I, in fact, I went with the mayor on that visit. In fact, I've been there several times. I think the community's concern is that those particular, if this is the right issue, those particular businesses are challenging for the neighborhood. And they would like to see some effort to better disperse those businesses across the city. I think the mayor, I haven't talked to the mayor about it since those visits, except that she indicated to us that she wanted us to think through, what some of the issues were. There was an initial plan based on the mayor's direction to consider possibly UMC, but that was, before they are, now they're closer to closure. That is something, I think they're accurate, that that's something that the mayor looked at and expressed some concern about the cluster of those type of businesses particularly in that particular area. And we need to come up with a proposal that makes some sense, that would satisfy both the mayor's concerns and the community's concerns as well.
Okay. That's partly why I was asking about whether or not Cedar Hill might have an MAT. I think GW does have one. And so if Cedar Hill is going to have one, then perhaps, we can make some shifts around. But I did recently meet with them, and they wanted to make sure that I asked you that particular question. Oh, yeah. And sorry, I have one more extra piece of paper here about the behavioral health carve-in. So, my understanding is that we didn't do the behavioral health carve-in in 25 due to the funding pressures, but also that the price tag ended up being a bit higher than we expected when the actuarial assessment came back. What's the future of the behavioral health carve-in? And to the extent that you are communicating this with folks?
It's interesting to me as a spectator and someone who's observed the span of opinions on this since the first time it was announced. There's a lot of opposition to this when we first started talking about this at DHCF. A lot of the opposition came from DBH and some of the DBH providers. So I was a little nonplussed when we had to stop it because of budget. And we got this pushback from the DBH and the mental health. I was shocked. I thought they were saying, oh, we're not ready for this anyway. But I think the future of it, I think, Dr. Bazron and Melissa are committed to seeing carve-in for a number of very good reasons. And so the future of it depends a lot on what happens to the budget. I mean, if we see, if the 2% annual growth rate that the CFO has predicted materializes, but for a shorter time period, then this is something this is on our list of things to revisit with the executive office of the mayor. I know people say, well, why does it cost that? The bottom line is when we impose this on the health plans, which we don't have a problem doing, unfortunately, we pay their taxes and there's some upfront admin costs. The taxes are on revenue, and if we increase their revenue, then we have to give them money for the taxes. So that is the genesis for the cost. But I think there's enough support both at DHCF, at DVH, and in the mental health community for this now that if, you know, if funds turn around, this is certainly something that we would go back to the executive office of the mayor, would say, hey, this is something we really like to do if we can afford it.
And then you already said you're gonna follow up on the dental. I just want to make sure that.
Yes, I think, Melanie has already reached out to, I forgot her name that testified today.
Dr. Presson.
Yeah, and I spoke to her after, one of the provider meetings that we had, and she was very pointed in telling me that I said nothing about dental. And I said, I didn't say anything because I didn't know anything about dental. Now I know a lot more now than I knew then, and so we're going to pay her a visit. She says she's very busy, so I don't want her to take time from her practice to, you know, hoof it over to DHCF. So I'm gonna take Angelique and some others, and we're gonna go over and see her, and we're also gonna start having questions, conversations with the mental health plan, MCOs, and say, look, you shouldn't be paying, you know, somebody just 30% of the fee for service rate. I mean, the fee schedule. That's outrageous.
I will also just add, while you're out there sort of doing this for the dentist, which is super important, is that you also might want to look at it from the optometrist and ophthalmologist as well.
Yeah,
They didn't testify, but they have in the past.
sure.
And I think those are like the two areas, eyes and oral health, that are sort of treated like redheaded stepchildren, even though they are crucial parts
Absolutely.
of the body. And particularly when it comes to pediatric, right? If you can't see, you can't read the board,
Right.
et cetera.
Oh, absolutely.
Yeah. But again, is there anything I haven't asked you that you want to say for the record?
Not that wouldn't get me in trouble, so I'm gonna be quiet.
Wonderful. All
Yeah.
right. So thank you for providing testimony and for information to the committee. If we have additional questions, we'll follow up. We do have some follow-ups, so we'll send those to you guys. And if you can turn them around in pretty short order, because we have a markup
We will do.
next Thursday. So we're gonna marathon this through. But this concludes today's hearing. So if anyone would like to submit testimony, the public record for DMH or Justin Healthcare Finance will remain open until Tuesday, May 7th at 5 p.m. You may submit your written statements on the hearing management system at dccouncil.gov/hearings. This concludes
Well-
all of the FY.
One request,
Yes.
polite request, general request, if you do anything in markup that changes the state plan, please say may versus shall.
Okay. I don't know why you want to go back to difficult conversations from prior years. This concludes the FY25 budget oversight hearings for the Committee on Health. This was our last hearing. Over the next 10 days, we will develop our FY25 budget report and recommendations. The committee will mark up on Thursday, May 9th at 2:30. The time is 4:12, and this hearing is adjourned. Thank you.